and treatment for children in out-of-home placements. Chair recognizes the prime sponsor, Senator Whitley. Welcome.
Thank you, Mr. Chair, and good morning, members of the committee. I think we're going to be together a lot this morning, so it's good to see everyone. For the record, my name is Becky Whitley, and I'm honored to serve New Hampshire Senate District 15, including the wonderful communities of Concord, Henniker, Hopkinton, and Warner. So I'm honored today to bring forth Senate Bill 416, and this was brought to me by our illustrious New Hampshire child advocate. And the bill just very basically requires that the children's behavioral health assessments that we added to the system of care through Senate Bill 14 in 2018 and 19, that those also include evidence-based functional behavioral analysis and a behavioral intervention plan prior to the placement decision of a child out of a home. So folks may remember that in 2019, the legislature passed historic reforms to the children's mental health system and SB 14. Unfortunately, several years later, as we are building the system, we still have a significant amount of New Hampshire children receiving care out of their homes and even out of the state. These institutional placements can be very lengthy for children and disruptive, and of course, very, very costly to the state. So this is a solutions-oriented bill that is designed to really look at a child's needs before we are putting a kid out of placement. And we think that doing an assessment to understand the cause and meaning behind a child's problem behavior can really help us make informed decisions about various programming for the child. Many of these children have very difficult behaviors, of course, and high needs. And so they're often being placed in these costly placements without a real assessment about why their behaviors are so problematic. And so, of course, we want to, whenever we're taking a child out of home, we want to make sure it's for the best interest of the child. And also, of course, from a fiscal perspective, these institutional placements are very expensive. And so if it's necessary, it's necessary. But if it's not, we want to find something that's better suited for the child. So I think this is a really small step to make sure that children can get the right care that they need closer to home. We know that all the evidence shows us that while out-of-home placements are disruptive, the more we can keep our kids connected to their communities, they're better able to function once they get back from those placements. So the version that is before you passed the Senate with a really wonderful collaborative effort, and I'm very grateful for everyone who came to the table to make this a real workable bill. So I want to thank the Office of Child Advocate. I want to thank New Hampshire Legal Assistance, the Department of Education, and the Department of Health and Human Services, all who came to the table with a very unique perspective and a deep knowledge of the system, and brought their expertise to this bill. The system is complicated, but we are really working hard together collaboratively to make sure it is integrated for our children and families. And I think this bill is a really good solutions-oriented example of that collaborative effort in the children's system. So thank you for your consideration. I'm happy to take any questions, but in terms of technical expertise, there are certainly experts behind me that can speak to that. Thank you.
Thank you, Senator. You mentioned it was brought by the child advocate. I assume that is the former child advocate with the present child advocate ready to testify. Is that
Yes,
correct?
sir. Yes, sir.
Okay. Have you discussed this bill with the current and new child advocate?
I just saw her in the hall. She just started, I believe today is her first day.
Yeah.
Today is her first day.
You saw her in the hall. So
I
the
saw her-
answer is yes. Okay.
The answer
good.
is yes, and the deputy director is also here and worked on the bill.
Any questions for the Senator Prime Sponsor, Representative Weber?
Thank you so much, and thank you for bringing the bill. I am a CASA, so I'm very interested in this. And I will ask you, but if you'd prefer to
Sure.
defer, I understand
Sure.
that. My concern with the bill is how this is going to work in the case of 169C, which is the
Correct.
Child Protection Act, where you don't have a lot of, necessarily a lot of lead time, and a child needs to be removed from an unsafe environment and sent somewhere immediately. And I'm wondering how this evaluation works in that case. And the second half of the question is, having kids who are having complete inability to find appropriate assessment and treatment because of lack of qualified professionals to provide the assessment and treatment. How is that going to be dealt with given the very tight timeframes that are here?
Thank you for the question. Yes, that's certainly an issue that we heard from. That's, DHHS provided some information about that as well. That was a concern. If you look at page 2 of the bill, there is, let's see. So starting on line 3, the end of line 3 on page 2, if a functional behavior assessment cannot be completed prior to entry, it should be initiated within 30 days. So gives that lead time. The second question you raised is a very important one also about the availability of these, the people to do these assessments. That was also, raised in the context. I believe that we addressed that in here by sort of giving that leeway in terms of who is available to do it. But I think that is a very real consideration. We also, there is some flexibility about who can do these assessments, right? It could be a psychologist, it could be a board certified behavioral analysis. There are a number of folks that can do this assessment.
Representative Shapiro.
Thank you, Mr. Chairman. and Thank you for taking my question. Of course, these evaluations are better done way earlier than when someone is about to be in placement, so that they perhaps a child will stay in their home, or perhaps they'll stay in a less restrictive environment if people are attuned to their behavioral needs. So it's kind of late in the game when they're being considered for residential placement.
Correct.
And but I understand, and most of these kids probably have these behavioral analysis done through special education while they've been in school, or a lot of them have. I did a fair amount of them when I worked for the school district. So I'm wondering if when kids come to the point of having to be placed in an emergency, if there's been any thought of the proper agencies through DHHS actually having a contract with someone who can do these kinds of evaluations. So they'll have someone who is available to do them when they're needed, as opposed to 30 days after they're already in a residential placement.
Thank you for that question. I think the first part of what you were saying, I think, is really critical, because we're talking about children who are often multi-system involved, meaning they are maybe being placed by the Department of Health and Human Services, maybe parent is placing them. But also, children exist within the context of their community and their schools. And so there is a responsibility of the school district. And I think that was a very important reason why the Department of Ed was involved in the development of this draft, because we wanted to make sure that we weren't interfering with the special ed process, but that the proper agency was held responsible for doing what they needed to do. And so if you look at on page 2, lines starting at 11, that's why we looked at amending the special ed statute to make sure it was very clear whose responsibility it was to do the assessment and when. And I don't know if anyone from the DOE can sort of speak further to that, but that was a very important, critical discussion about who was responsible. In terms of contracting for the providers, DHHS is here and maybe they could just, talk through that contracting process.
Thank you.
Representative McKay.
Thank you, Mr. Chairman. Good morning, Senator.
Good morning.
You and I have the advantage of probably being the closest to this building than anybody else in the legislature.
Yes, sir.
The disadvantage comes in the mileage payout.
That is very true. That is very true.
I get it every 6 months. I'm looking at the last paragraph in this. I don't have a numbered one. It talks about a trained behavior analyst, which may include a board-certified behavior analyst.
Mhm.
And I don't know what that is.
Mhm.
I know about social workers and psychologists and all of that, mental health board,
Yep.
but I don't know what a um, board-certified behavior analyst, I don't know what that is.
So thank you for the question. I can't speak to the clinical requirements, but that is something that's already in special ed law. So it is an area that there are board certified behavioral analysts in New Hampshire. They do that. Perhaps Representative Shapiro could better answer that question. But that's something we pulled from special ed law. Yeah. But there are other people that can conduct this assessment, including psychologists.
And I hope social workers.
I believe so. I don't know. I don't know, actually. Thank you.
Thank you.
Representative Folsom.
Thank you, Chairman, and thank you for taking my question. It's a multiple part question.
Sure.
I'm going to try and sneak past the chair. In the first paragraph, it says institutional placements are costly for the state and not proven to reduce problem behavior. Residential care is costly for the state
Yep.
and not proven to support successful long-term outcomes or reduce problem. So my question is, are we looking to not place as many children in institutional placements, but rather in residential care placements where they have had a functional behavioral analysis, examine them and set up a program for them? And as a result, are we going to start requiring our foster care families to have to now get even more training in behavioral challenges?
Thank you for that question. So I think we're using residential care and institutional placements sort of interchangeably. Sometimes, not every residential placement is an institutional setting, but I will back up a little bit saying that the federal government has dramatically changed how they're going to give New Hampshire and all states, how they're going to fund child welfare. And that was through a federal law, the Families First Prevention Services Act. And the big shift is that they're looking towards prevention. How do we get these families, these children before, they're in crisis, but also how do we reduce the need for residential placement? So it's not so. And I think the state has really done a lot of work to reduce out of home placement to sort of these episodic needs. If a family's in crisis, if a children in crisis, maybe they need to be pulled out of home, get the treatment that they need, and go back. And so it's a real shift. And so I think this bill is just a very small piece of that shift. There is always a need for more foster families. Of course, we know we don't have a lot of therapeutic foster placements in New Hampshire. That is certainly a gap. The foster families we do have are deeply committed. I know that they often take very difficult children. Maybe I'll defer that part of the question about what they need in terms of training to DHHS, but you raise a very important point. Thank you.
You may either follow up or ask a different question. I caught you.
Can I have a follow-up? Okay, great. So I think I'm hearing from what you said about the federal law and the other things you talked about is that a goal is to keep the child in the family, in the home, and bring the counseling and training into the home, one, to reduce costs and hopefully to have a better outcome.
That's correct. The evidence really is showing us that it's more effective to use evidence-based interventions and to keep that child connected to their community and their family. If a child does need to be removed, you want to make sure it's for specific clinical needs and you're not just pulling a kid out to pull a kid out. And so Rebecca Ross, who has worked a lot in this system development and is now the director of Children's Behavioral Health, can speak to that. But I think you're exactly correct. Yep. Thank you.
Do you have another one? Anyone else with the question? Representative Gay.
Thank you, Mr. Chairman, and thank you for taking my question. This is an extremely difficult situation for any child, and I'm suspecting it's usually tied to ACEs, and the whole family is involved, so it's just huge. I'm wondering what is unique about functional behavioral analysis? What does that mean?
Right. So this is an assessment that we're very familiar with in the special ed context, that children often exhibit behaviors as a result perhaps of their mental health disorder, or perhaps, as you described, the impact of trauma. And so the idea is that we don't want to punish children for behaviors that are really problematic. We want to identify why the function, why they are behaving that way, and treat that rather than punishing them. So that is really the difference. The idea is to look at why they're behaving that way and just address them directly.
Okay,
I hope that answers your question.
Thank you, Senator, so much.
Thank you.
Chair recognizes, flown in at great expense from the state to our immediate south, Cassandra Sanchez, the new OCA head. Welcome to New Hampshire.
Good morning, Chairman Pearson. Thank you for your time. I do have a written copy of my testimony as well, if you would like me to share that with all.
Would you pass it around and not read it,
Yes.
but just summarize it?
I
We're
am
on a
going
very
to.
tight schedule.
Yes, absolutely. So again, thank you for your time, and I will summarize what I have here for you. I would like to note that
Just bring it a little closer to yourself.
Okay. Is that better? Okay, thank you. I would like to note that the Office of the Child Advocate is in support of the amended Senate Bill 416. So to note that, in following up in regards to the children out of home placements, I did want to note that we have found that often children are placed away from their homes in the community because of problematic behavior. Our understanding of several underlying causes of problematic behavior are exposure to trauma, disruptions in development, language impairment, and medical or intellectual disabilities in which are not being met. I do have a child case that I would like to share with you. Okay, so I would like to share a case of a 13-year-old boy in which the Office of the Child Advocate had an opportunity to meet with. He did live at home and had special educations to accommodate disability, including autism, which is a very behavioral diagnosis, which we often find in speaking about functional behavioral assessments and BCBA. They do often work very well with autism spectrum behaviors. So he lived at home. There was a series of events that included out-of-home placement at a facility, which isolated him away from his family due to COVID-19 restrictions. From that point on, he then had to be moved from that facility because his behavior is exacerbated and became unmanageable in that setting. He was moved to an ER setting where he had to stay for some time. He then had a month-long stay. He was a month-long stay in the emergency room before being admitted to Hampstead Hospital. He remained in Hampstead Hospital for 5 months. DCYF had a very difficult time finding him a placement due to his application, including these very difficult and aggressive behaviors. There was a request for an FBA, but that was never completed for him. He finally found a placement in a facility that was nearly 1,500 miles away from his home, and the transport cost to get him there due to the behaviors and having to have a special air flight cost $24,000. He now remains there nearly 5 months later, and there are many questions about the treatment and ability to meet his needs. There's still not an understanding of his behavior and the underlying causes of those behavior. And at this point, we do feel that if that functional behavioral analysis was completed, the treatment providers would have a better idea on how to treat him properly and effectively and get him back home, or at least closer to his family somewhere in New Hampshire. So that's just one example of many that occur across the state that we come in contact with. We also included here a memo from the state of Connecticut's Behavior Oversight Committee, in which they recently distributed information as to success of using functional behavioral assessments in children outside of a school setting. So that is in your attachment there. I would also like to note that some of the difficulty in placing these children is often because we don't have an understanding of their behaviors. They are then labeled as children who are difficult or disruptive, whether it be in the classroom or the home setting. And because then once that label is put on them, it's then difficult to treat them in multi-settings across their life. I'd also like to point out the cost of the residential programs, which yearly could range from $70,000 to $800,000 per year per child. If we had the ability to better identify their behaviors and needs and treat them earlier on, we could reduce this cost long term. Lastly, I would like to point out that BCBA is a master's level licensed position. There are many providers currently either working to get that. They have to have a certain level of behavioral psychology hours completed in a classroom and intern setting to be able to qualify for this license. I don't know the specific hours in the state of New Hampshire, but my understanding is that this is becoming increasingly popular in the world of clinical treatment due to the ability to treat behaviors in autism spectrum disorders where many other treatments are not effective.
And will you take a question or two?
Yes, I will.
You know, in carpentry, they say before you cut, it's a good idea to measure.
Yes.
And that's what I'm hearing here.
Yes.
Any questions for
Thank you.
Ms. Sanchez? Representative Leon.
Thank you, Mr. Chairman, and thank you and welcome.
Thank you.
My question is if these children that have higher needs and more specialized needs sometimes impact the availability of other beds, and if it reduces the amount of capacity for other children that need care.
Yes, absolutely. That is the case. And so the hope is by getting these behavioral analysis done early on, that there is potential as well that some children can either avoid residential placement altogether or can have a shorter stay in residential placement where the treatment is geared directly towards their behavioral needs, and then they can return to a less restrictive setting. Thank you.
Representative Gay.
Thank you. Right now, sorry, this sounds really clueless, but right now, number one, what is BCBA? Behavioral what?
I have to look up the specifics of the board certified behavioral analyst.
Okay, thank you. Up to now,
Would you like a follow-up?
yes, that was a
You may have one.
preamble. I'm sorry, that's not funny. It's almost like this is an afterthought. We've waited until the child has fallen in the deep end, and now we're suddenly going to say, oh, we need to do the BCBA, or we need a BCBA person to assess them. It sounds like, is this already being done early on? You know, when people realize that a child's behavior is uncontrollable, that's my non-professional term.
At this point, it's not being done other than in the school setting, and that's when it's required through special education and when a child already has an IEP in place and they are struggling even with the assistance of an IEP. And that's through a federal mandate for that.
My follow-up
you.
to that would be, there are some children in the deep end and we're trying to rescue them, but there's a lot of other children who aren't near the pool yet and we're trying to prevent them going to the deep end. Is that correct?
Yes, that is correct. Thank you.
So much. We are on a tight schedule. Appreciate that and welcome.
Thank you very
Once
much. My
again.
pleasure.
Next, the chair calls Emma Savigny, and help me on the pronunciation. Do I say the G or not? I don't. Are you any relation to Chloe, the actress?
No, I wish. That'd be pretty cool, huh?
Yeah. It's a name I don't encounter much. I just wondered.
Yes. Thank you for having me. As you are on a tight schedule and as most of the testimony I had prepared has been explained already, I'll just cover one quick question that I believe Representative Gay had to expand on the answer Senator Whitley gave on why a functional behavioral assessment is different or unique. And you,
Could we know who you're representing?
oh yes, I'm
Mr.
sorry.
Chairman?
Thank you.
Sorry.
Thank you. No, appreciate that. Thank you.
My name is Emma Savini. I am the Children's Behavioral Health Policy Coordinator at New Futures, which is a nonprofit, nonpartisan organization that educates, advocates, and collaborates for the health and wellness of all Granite Staters. So a functional behavioral assessment is a great tool for practitioners to use to get to the core root of a child's behavior. In performing the behavioral assessment, the practitioner who's reviewing the records will look to see what the triggering factor is in the behavior and how that triggering factor can either be changed to get more positive behavior from the child or how they can treat that behavior in a more positive way. So an example would be if a child is at school and they're triggered by, a teacher handing out paperwork and that's distracting. Instead, there can be a more positive route to redirecting that behavior. And so that trigger would only be able to be identified by a functional behavioral analysis or assessment, and so that gets to the root of the behavior and is a more effective tool at triggering or at combating that trigger. And so that effective tool would hopefully, as you've heard, make it so that the need for out-of-home placement is eliminated or significantly shortened because you're treating the trigger of the behavior instead of just a behavior without knowing why it's happening. I'm happy to take any questions, but the rest of my testimony is written and you can read it at your leisure.
Any questions? We plan on having some leisure in about a month and a half. Thank you,
Some light
Counselor.
reading at the
Appreciate
beach.
your coming.
Thank you.
And this, for the future, if I don't have it, it doesn't exist. I'll give you a break if you talk in 1 minute. All right. Anybody in the future, if you wish to testify, I have to have the pink card. When I'm out of pink cards, we're out of hearing. Okay?
Good morning, members of the committee. Rebecca Ross, Director of the Bureau for Children's Behavioral Health. I'm happy to take any of your questions. I believe there were some when I came in. Oh. How about now?
Better.
All right. Again, for the record, I'm Rebecca Ross, the Director of the Bureau for Children's Behavioral Health. I'm happy to take any of the questions that you have. We have weighed in on this bill. I think that the amendments better reflect the appropriateness of the use of functional behavioral assessments. While we don't believe they will solve every problem for every child who has a behavioral issue, if they have an appropriate diagnosis and it's clinically indicated, we do support using functional behavioral assessments in coordination with community services as well as residential-based treatment. This goes hand in hand with the CAT assessments that we've already implemented starting October 1 of last year that really do a holistic assessment of the need and level of care for residential treatment for youth and used for the appropriate youth and given the appropriate funding to support that, these will work consistent with the other system changes that we've done with the system of care.
Thank you so much, Representative Folsom.
Thank you, and thank you for taking my question. There's quite a few number of children that are already placed somewhere, and then we're looking at preventing possible out-of-home placements. What is the current status on the number of people that can perform these assessments? Because they left it a little bit open as to who could do that. And so is it going to take a long time to catch up? And which would you most likely concentrate on first? Would you concentrate on those already in placement that we could get them back home? Or trying prevention instead?
I think we would have to have a multi-pronged approach. I don't think we could say one or the other. I think if we incorporate it into our CAT assessment process, that would be helpful. The CAT assessments are done for every new placement as well as every change in placement. And as people are coming in to hopefully avoid placement, I think that they could, if they're not done in the educational setting because it's residential only or the home setting where there are concerns, we would need to be looking at that through our care management entities to determine if it's appropriate. Right now, Medicaid funds it for autism spectrum disorders. Originally, as written, the bill was for every youth. We didn't think that was appropriate, so we would have to do a deeper dive to figure out who the highest level of need would be to start with. There is a severe workforce shortage, and it would take time and resources to stand up an appropriate number of individuals. We've had a long wait list on the kids that we've already tried to seek these for.
Thank you, Representative Weber.
Thank you, and it's nice to see you again. I want to reiterate the question I had before, and I think some of it ties into what you just finished up with. My concern is about those kids who are under 169C, who are being placed not necessarily on their behavior, but mostly on the behavior of their parents or caregivers, but who nevertheless have significant needs of their own, many of which have not been met because of the problems in the home. And I'm seeing the potential here for a bottleneck of staggering proportions given those kids, the need to remove them quickly and find them a safe place to be, plus the shortage of qualified professionals. And I wonder how you see that playing out and whether we're going to get into trouble with the provisions of a law that require something that we can't provide at this point.
Those were the department's initial concerns when this bill came forward as a mandate for every youth going into residential. We knew we could not meet that. The effective date has been pushed out to 2024 in this version, which will help us be able to stand up some of that workforce. It gives us some flexibility to determine who it's clinically appropriate for, to not be doing them needlessly on kids who don't need another intervention that's not going to meet their needs. I am still concerned we don't have the resources to do it entirely in that amount of time.
Thank you, Representative Shapiro.
Thank you, Mr. Chairman. Thank you for taking this question. Might it be necessary for children who already have a behavior plan based on a behavioral analysis to amend that plan once residential placement is being considered? Because the plans that were initially done were done relative to the school environment and the classroom environment. And now these plans are going to have to address a residential situation.
Yes.
And so might that be necessary to also redo these plans, or at least update them and amend them if a residential placement is being considered?
Absolutely. And our expectation that everything would be individualized and comprehensive throughout their school and home life. And if they currently have a FBA for the school setting, but it doesn't address their home needs, then we would want to update it. I don't think it would be a starting over, because we would incorporate what we already have and move on to expand it.
I have a question. Under the fiscal note, it says it is assumed that any fiscal impact will begin in FY23. If you're saying this probably won't kick in until 24, would that be startup costs or look-aheads or recruitment?
We're going to update that fiscal note based on the amendments, and we're going to be turning that in. Originally, it had an earlier start date, but there may still be fiscal impact depending on how quickly we were looking to
From your
stand it up.
statement, am I presuming that this bill that we have before us is not the amended bill? Or is it?
It's amended, but it's my understanding Senator Whitley is going to have to work with the House for an additional amendment for
Okay,
some
so this
minor
kicks over to
changes.
finance that gets another shot at this. Okay, thank you.
Yes.
One more. Yes, Representative Weber.
I just want to know where in this it says 2024, because it doesn't, that I can find. It says this act shall take effect 60 days after its passage.
I apologize. I may be confusing this with the ACEs bill, but we did discuss postponing and amending further to extend it to be able to do that.
Representative
Mr. Chairman,
Knurr.
is this a second committee bill?
Yes,
Okay, thank you.
that's why I'd like to get the gist of it and get it out the door. Is it necessary?
Yeah,
Representative Knurr.
yes, just to inform you that Senator Whitley told me that
I
she
know.
already has
I'm-
some language. Oh, okay,
I'm
for
aware
the
of that.
amendment.
Thank
yeah.
you. Thank you.
You're very welcome.
The last minute on the bill. And I apologize for not reading what was obvious. It says right at the top, as amended by the Senate. That answers my question. Thank you.
Thank you, Mr. Chair. I appreciate another minute because I neglected to indicate that there was another amendment that all the parties had worked on. So the Department of Education, DHHS, and the other folks, and I have that right here. So on page 2, line 1, this is the requirement to do the assessment. So it should read behavioral starting the sentence from before. Basically, the assessment shall be done if clinically indicated. That's going to end the sentence on the top of page 2. And then if you look at line 6 on page 2, starting the sentence, the functional behavior assessment shall be conducted by individuals qualified to perform the assessment, which may include but is not limited to a board certified behavioral analysis or psychologist. And sure. So the First Amendment, oh, you got the First Amendment? Okay, then the Second Amendment is on page 2, starting, I guess, at the end of line 5. The functional behavioral assessment shall be conducted by individuals qualified to perform the assessment, which may include, but is not limited to, a board certified behavior analyst or psychologist.
And this amendment is going to go to the fiscal committee, which is where this bill goes next, or
I'll-
what?
I'll leave it
Finance,
I'll
I
leave
mean,
it up to
sorry.
yeah, I'll leave it up to the committee. And then the
Okay.
last change, of course, is on the line 23 of the second page. This act shall take effect 2024, or as deemed appropriate by the committee.
Thank you very much. We've got a schedule here. I'd like to get this out the door. Representative Shapiro.
Thank you. I'm sorry, I'm going to ask you to repeat, who are the people who may perform this?
So we tried to line up the language with Medicaid. So as Rebecca Ross indicated, that this service is covered under circumstances under Medicaid. So in the Medicaid context, as you folks know, they have to be a qualified provider. So that's why we said that the assessment shall be conducted by individuals qualified to perform the assessment, which may include but is not limited to a board certified behavior analyst or psychologist. So in the school context, many of these are provided by psychologists. So the Department of Education and school folks wanted to make sure that that's still available. If there was not a BCBA available, that a psychologist could provide it.
Well, I think, follow up.
Mine's a procedural thing.
Yes?
Were the amendments that I just saw, are those for this bill?
No.
Okay,
No.
because we're appear to be asking to vote on an amendment which we don't have, which we can't do. So I just want to be clear that the process here is exceedingly unfortunate.
We have two choices as I see it, and I will defer to greater experience. We could either vote this bill as we have it, because that's what we've got. And then it goes to finance, where the amendment we trust will appear.
Okay.
Or we close the hearing, somebody gets the amendment to us this afternoon, and I hope we will have time then to exec it, which we are supposed to do.
Happy to do that.
So those are the choices. Which would you prefer? Close the hearing now, move on, and then come back to exec it this afternoon? it looks like we're going to do that. Okay, so if you folks can get this amendment that you're describing to us in hard copy.
She'll have to have a name. Whose name is going to go on it? A name from the
I'd be
committee.
glad to lend my name. It has to be a House amendment, not a Senate amendment.
Yes.
We can't vote on Senate amendments.
So if you can write out the specifics, write it out.
Yep.
Give it to Representative Weber while we're having the next hearing. And then off it goes. What she has already said is what the amendment is going to be, and we're not. Would somebody answer that question?
Happy to. The way it's written, it would include children at risk of out-of-home placement. So it would include children who are struggling at home, who, if their behavioral concerns are not addressed, would be at risk of going into a residential placement.
Now I'm closing this hearing on Senate Bill 416. We will put it in the to-do pile, and we will have a hard copy of an amendment coming forward. Thank you for everybody's working this thing real well. Open the hearing on Senate Bill 459 relative to a healthcare facility workplace violence prevention program. The chair recognizes Senator Gray, who is the prime sponsor. Thank you. Okay.
Thank you, Mr. Chair. My name is James Gray. I'm a senator representing District 6, which starts in Rochester and goes up Route 11 to Alton, Barnstead, and Gilmanton. SB 459 is a result of many months of work by a study committee. This bill requires that healthcare facilities to implement and maintain workplace violence prevention programs and establish the Healthcare Workplace Safety Commission. It also permits law enforcement to arrest an individual without a warrant in certain circumstances to healthcare workplaces. That last part there, the warrantless arrest thing, I want you to assure you that this bill, the first thing it does is say that the organization, the hospital, what medical practice, whatever, needs to do de-escalation techniques. When the officer arrives on scene, he needs to do de-escalation techniques. And that is done intentionally to make sure that those people that are suffering from mental illness or other maladies, that there is time to evaluate what is going on. Certainly if someone is in imminent danger from the individual, then, you know, the officer already has the ability to arrest them with or without the changes in the warrantless arrest. The genesis of this bill started way back, I guess 5+ years ago, when I was the first senator. And we had a problem at the state hospital with one of my constituents. That constituent was severely injured, out of work for many months, and had the additional embarrassment that their name and other things had to be disclosed in the public setting for the compensation that they would get to be approved by the Executive Council. We've come a long way since then, but the part that this bill deals with is not the state facility, which is what we were concentrating on before, but other facilities. Doctors and nurses sometimes do not feel safe, and there is a high incidence of violence out there. I've got lots of people behind me that worked on or with the committee, and I'll try to answer any question you have or defer them to the experts behind me.
Representative Leon.
Thank you, Mr. Chairman, and thank you, Senator, for being here and taking these questions. My question is about the need for warrantless arrest if the officer is already there, already doing de-escalation techniques, and sees that there's still an imminent threat from that patient, from that person.
The interpretation by many of the officers is that warrantless arrests are not fruitful, that often there are lawyers that go and challenge the grounds that are in the warrantless arrest statute. Again, you know, we're trying to reach that sweet spot between, you know, somebody saying he did or she did whatever, and the cop saying, okay, I believe you, I'm going to arrest you. Okay. That is not the intent of the statute. That is not the intent of this bill. But there are situations where there is imminent danger for people in that. And we want to take the question out of the officer's mind that he is trying to weigh these things and make decisions that he doesn't need to make at that time, and tell him that basically that he'll be supported based on the results of any de-escalation techniques, both on the hospital's part or healthcare facilities part, and his own.
Senator, I have a question on page 4, line 6 of the bill. It is in the section appointing a commission, one of whom shall be appointed by the Speaker of the House. The Speaker of the House and I had another conversation last night of about a half an hour, the difficulty of finding people to appoint to commissions. I favor them a little bit more, even though I'm the one they ask to do a lot of their recruiting when somebody from the House has to be named. So the kind of understanding the Speaker and I have is that we're very happy not to ITL a bill that uses the word commission, as long as the representative or senator giving us the bill will assist in finding that individual that we will appoint as a House member. So if you have somebody in the House you know really likes this bill, I'll be really happy to hear that from you at a later date.
I can tell you that between myself and two other senators, that there was a lot of support in the Senate, and that the three of us, I'm sure, will work together to find that individual that needs to participate. It may even be one of our retired physicians. You know, I'm looking over at the candidates right here on your committee, and I'm sure that they have a vested interest in keeping their colleagues safe.
I'll take that as a yes. Any other questions for the senator? Representative Knirk.
Yeah, mine's kind of more a technical question. If we look on page 5, lines 33 to 34, the caption says Chapter 151G of New Hampshire Healthcare Quality, so on. And then what it's all about below it is line 35 is the arrest without a warrant, and that's RSA 59410-1C, or Roman 1C. Why? What is that caption 3334 ahead of that for? Can somebody clarify?
That would have been done by OLS, and it may be just a Scribner's error.
That's what I'm wondering.
But we can certainly get you that information.
Representative Leon.
Thank you, Mr. Chairman. Would you believe that my reading of this says that that is Section 3, which changes the title, and then the arrest without warrant, starting on 35, or a new section?
Yes, I would believe that.
Any other questions for the senator? Seeing none, thank you, Senator. And the chair calls Senator Rosenwald from Nashua. Welcome back to the House Committee.
It's always great to be here. For the record, I'm Cindy Rosenwald from District 13 in Nashua, and I was a member of the Workplace or Safety and Healthcare Workplaces Study Committee, and I'd like to add my support, my strong support for this bill. The committee worked for months, and we were really careful to avoid criminalizing mental illness while working to improve the safety of healthcare workers, and to achieve this specific language, which we argued about the way we argue about may versus shall, but for longer. We worked with NAMI New Hampshire, the ACLU, the Disabilities Rights Center, the hospitals, some law enforcement, and we got to agreement on the specific language in front of you. It threads the needle exquisitely carefully, and it really represents months of collaboration among a wide variety of people with very disparate views. And the data piece will also be important to our understanding of why violence is rising in healthcare workplaces and how we can reduce it. I really hope the committee will vote this bill ought to pass. Thank you.
Thank you, Senator. Any questions for the Senator Representative Woods?
Thank you, Mr. Chair, and thank you, Senator, for taking my question. And the people that are on the commission, there are no physicians specifically. I know the senator before you said he pointed to a few individuals that might qualify, but the medical society or the nursing profession are not specifically included. Was that? I'm kind of curious, as that these are the folks that are going to be right at the hub of this kind of activity.
That piece, the commission was also worked on over a period of months outside of the specific legislatively created commission. Senator Sherman led that work group. He
Okay.
was not on the official study commission, but I guess there was not an identified need to specifically name a physician, and I'm speaking from the place of being married to one.
I have a feeling, Senator, maybe the House representative will be a physician. I just have
Perhaps.
that feeling. Representative Knirk.
Actually, looking at page 4, number G, which is where we talk about the appointment by the Speaker of the House, is it not true that that does not restrict it to being a legislator, that it is a member at large, and the Speaker of the House could appoint a non-legislator, who could conceivably be recommended by the nurses or the New Hampshire Medical Society or something? And is that correct? And is it also a benefit because it's not coterminous with legislative service, therefore they can have a long-term appointment and not have to change every couple of years?
That is correct.
Thank you.
Any other questions for Senator Rosenwald? Representative McKay.
I'm taking Representative Snow's place.
That's the assistant clerk's job, too.
On page 2, line 27, the word perpetrator shows up. And I think that that may be something that you missed in terms of language, and the first perpetrator would be a patient. So I wonder if that, if you couldn't just say a classification of each person.
It certainly could, because this is not in 594, that section. It's in 151. So it could be individual.
Thank you.
Any further questions? Seeing none, thank
Thank
you,
you.
Senator. The chair recognizes Dan Mcguire of Epsom, and he says he's representing himself, and he opposes the bill. And we are now in the 3-minute zone. Every testimony now will be no longer than 3 minutes. You may start the watch.
I accept that challenge. Thank you, Mr. Chairman. For the record, my name is Dan Mcguire. I'm from Epsom. I'm a former member of the House. I have to disagree with my friends, the senators who spoke recently on this bill. And this is a bill that seems to act in advance of facts. It creates a bunch of reports to get a lot of detailed information about workplace violence in hospitals, but it already proposes a solution to that problem. And so in order to vote for this bill, you have to assume that there's a lot of workplace violence in hospitals. The hospitals involved have done nothing to effective against it. And the method proposed here, extra training, will be effective. And if so, why haven't the people actually experiencing this, the hospitals, why haven't they implemented such training, right? This bill requires them to do so on their own nickel, but if somehow they're experiencing a problem, but they need this bill to help them solve it. I don't understand that.
We
doesn't
will
make
be
sense.
having somebody from the Hospital Association address that in a few minutes.
Thank you.
Welcome.
Furthermore, so it would make more sense to get the reporting first, figure out what is the size of this problem, and then propose legislation if necessary. The other problem, so the question is how much, this is the kind of bill that adds cost to healthcare, right? This is millions of dollars. It looks like from the fiscal note, it's $272,000. But that's just because, that's just to hire the training people at the 2 state-run hospitals. That doesn't include the training people at all the other hospitals, all the urgent care centers, all of that stuff. And it doesn't include the waste of time in training for all the doctors, all the nurses, all the other employees at all of those locations, right? Taking time away from their skilled jobs to do that kind of training. We don't know how much training it is. Is it an hour? Is it a half a day? Is it a day? Who knows, right? All right. But I think that the worst part of the bill is the section you've talked about a little bit, which is section 4, starting at the bottom of page 5, the criminal section. This is a bill that has not gone to any criminal justice committee and will not go to any criminal justice committee. It will go from your committee to the finance committee. So that changing criminal law is something that should be done very carefully and very thoughtfully. And the idea that somehow a police officer should act differently depending on where in the state they're standing, to me, makes no sense at all. Thank you, Mr. Chairman.
Any questions? Questions? Representative Gay.
Thank you. Are you thinking about the de-escalation that law officers are supposed to be already doing in non-healthcare settings?
Yes, thank you for the question. I'm just reading the section on page 6. The amount. So this is a section of law. If you read the entire section, it's about when are police officers allowed to arrest people without a warrant. It's very generally written. It's something that's been developed over hundreds of years, and it's criminal law, so it's extremely important and carefully written. So this is adding another section to it, saying if you're standing in a hospital facility and you're observing medically necessary care, how is a police officer supposed to know that? Then they should act differently than they would if they were standing on the street. You see what I mean? It doesn't make sense. And it should be something that the Criminal Justice Committee and the Judiciary Committee vet. This should be a separate bill.
We will have somebody from the Attorney General's office testifying as well.
All right. Thank you, Mr. Chairman.
Thank you, sir. The chair recognizes Paula Minahan from the New Hampshire Hospital Association. And friend.
If I could, I would also like to have Chris Herring join
Sure,
me, my
you may.
colleague from the Foundation for Healthy Communities.
Okay.
Thank you.
Do you have handouts? You do. And the clock starts
Whoa.
now.
All right. Thank you. Good morning, Mr. Chairman, members of the committee. For the record, Paula Minahan, Senior Vice President, State Government Relations for the New Hampshire Hospital Association, representing all our hospitals. With me today is Chris Herring, Vice President of Quality Improvement with the Foundation for Healthy Communities, which is an affiliate of the Hospital Association. We are in strong support of Senate Bill 459, and we do appreciate Senator Gray's sponsoring this bill, as well as other co-sponsors, including Representative McMahon and Representative Green. It is, as Senator Gray stated, it's a result of the Senate Bill 100 that was passed last year. I will not reiterate all the work that was done, as Senators Rosenwald and Gray have already outlined that. We did have numerous study committee meetings and as well as work sessions. So this is a result of many, many hours of work of many, many committed individuals. I want to just outline real briefly the 4 sections of the bill, and then Chris is going to explain in more detail the importance of the legislation and specifically why we set up the commission the way we did. So the first section is about collecting data, and it is focused on hospitals and urgent care centers. That was done a deliberative process. We had discussions with many other groups of individual providers, and it was determined to start with hospitals and urgent care centers. And each facility is will be responsible for implementing and maintaining a workplace violence prevention program. Also, we had significant input from the Nurses Association, and I know that they are here today to provide some additional information relative to the data collection and annual reporting. The second section, it does establish the New Hampshire Healthcare Workplace Safety Commission. It is modeled after the New Hampshire Healthcare Quality and Safety Commission, which actually passed out of this committee probably about 15 years ago and is now a permanent commission. What is important to outline, and I think it already has been stated, there are no legislators per se on this commission. There are some committee members that are at, what's the terminology? The at-large members, which could be citizens of, just citizens. So anyone. And section 3 does change, as Representative Leon stated. It's just adding the word patient to the existing Healthcare Quality and Safety Commission to make it clear. One commission is workplace safety and one commission is patient safety. That's what that section is. And then section 4 is the change to the warrantless arrest statute. And we do have folks here, a security officer that from Catholic Medical Center that can address that more effectively, since he is a retired police chief from the Manchester Police Department. Now I'm going to turn over to Chris.
And yes, Chris of her own pink card. Thank you.
Good morning, Mr. Chairman and members of the committee. My name's Chris Herring, Vice President of Quality Improvement at Foundation for Healthy Communities, and I'm the administrator for the New Hampshire Healthcare Quality and Safety Commission. So I'm here to provide background on the role and structure of that commission and to explain why establishing a similar entity to examine healthcare workplace violence is imperative. The New Hampshire Healthcare Quality and Safety Commission was originally established in 2005 by the New Hampshire General Court to provide a confidential forum for quality professionals from all New Hampshire hospitals and ambulatory surgery centers to share information on adverse patient care events and to learn how to prevent them. For the past 17 years, commission members have enjoyed the opportunity to look beyond their own organization's experiences and data into statewide data to identify patient safety trends and to share frankly with their colleagues. This ability has resulted in substantial learning for all participants and a much more proactive approach by each organization to reduce preventable harm. In 2015, hospitals unfortunately started seeing an increase in violent acts against healthcare workers, and the New Hampshire Healthcare Quality and Safety Commission became the de facto entity to discuss these, as no other forum existed. Hospital safety officers have been invited into the commission meetings to present on workplace safety events and to share their recommendations and policies to make hospital workplaces safer. Commission members who often do not have primary responsibility for their hospital safety programs have in turn shared these recommendations and resources with their safety officers, emergency management coordinators, and senior executives. The Commission has urged hospitals to collect workplace safety data, but unlike the mandatory reporting requirement of adverse events, by the New Hampshire Department of Health and Human Services, there is no mandatory requirement for workplace violence events. Currently, workplace violence data is incomplete and lacking standardization. Unfortunately, violent acts have continued to escalate in hospitals. Continuing to have these events reported via the Quality Commission is suboptimal for the reasons that the Commission's focus is on patient safety and not workplace safety. Quality professionals are not typically in charge of hospital safety programs and the ones who can affect change in these programs. Ambulatory surgery centers are not experiencing similar violence, so much of this discussion is not germane to them. And other healthcare entities who are experiencing increased workplace violence, i.e. urgent care centers, are not represented. Because the structure of the Quality Commission has been so successful in allowing hospitals and ASCs to improve patient care and patient safety, it makes sense to replicate this same structure to create a commission specifically focused on healthcare workplace violence prevention. Thank you.
Will you take questions? Yes. Representative Leon.
Thank you, Mr. Chairman, and thank you for taking the questions. My question is actually for Ms. Herring. I was curious about how much involvement the urgent care centers have had in this whole process, because it sounds like the hospitals and ambulatory surgical centers are involved. And I just wanted to know if they've just been included, or if they've, including standalone and hospital urgent care centers, have been a part of this development.
So the urgent care centers have not been involved in the Quality and Patient Safety Commission, but in the work group that we had over the course of months with Senator Sherman, they were involved in the conversation, as were other healthcare organizations, to determine who really were experiencing workplace violence events. And the urgent care centers have been, unfortunately, with increasing numbers.
Thank you.
You're welcome.
Any other questions? Representative Acton.
Thank you, Mr. Chair. Thank you for taking my question. On page 2, section 3, it refers to the Joint Commission standards. What health facilities, as defined in this piece of legislation, are not already adhering to the Joint Commission standards on health, workplace violence, and why wouldn't they, that would require this legislation?
That's a great question. Thank you. So there are currently 6 hospitals in the state of New Hampshire that are accredited by the Joint Commission. Hospitals have the ability for CMS certification survey that's administered by the Department of Health and Human Services. They can also have a deemed organization that does their accreditation, such as the Joint Commission or DNV, for example. So those hospitals that are not Joint Commission accredited do not have to follow all of the Joint Commission standards.
Okay. Any further questions? Seeing none, thank you. And the chair calls John Patty from Catholic Medical Center.
Morning, Mr. Chairman, committee members. My name is John Patty. I'm the Executive Director of Support Services at Catholic Medical Center and a retired sergeant from the Manchester Police Department. I'd like to begin by thanking everyone who's involved in this bipartisan process of developing the language in the bill that you have in front of you. I very much appreciate their patience and input. Those involved include Senators Gray, Rosenwald, Sherman, Representatives Green, McMahon, and Litchfield. We also received helpful input from ACLU, NAMI, DRC, New Hampshire Attorney General's Office, New Hampshire Chiefs of Police Association, Paul Minahan, and New Hampshire Hospital Association, and many hospital staff members throughout the state. When I was hired as a director of security at CMC, I was astonished at the behavior of patients and what the clinical staff endure. If you're not aware, assaults on and workplace violence at healthcare facilities has been an increasing concern for healthcare workers. Depending on what publication you read, the stats indicate that healthcare workers are 4 to 5 times more likely than other private industry employees to be the victim of workplace violence. There are many studies, including some from OSHA, that show the prevalence of assaults in these settings. Part of the work that went into this bill focused on the need for collecting relevant data to support the need for a workplace violence prevention program for healthcare facilities throughout the state. This data will be used to support a commission to review and analyze healthcare workplace violence and safety issues that are affecting our healthcare workers. As the executive director overseeing security, I'm aware of the reports of assaults on our employees. On many occasions, we would call the police to report an assault on a healthcare employee, only to be told by the police that they would not make a warrantless arrest, but rather apply for an arrest warrant, which can sometimes take up to 2 weeks, in the city of Manchester. Imagine how frightening it is for our healthcare workers who are victims of an assault and then have to remain in close proximity with that person to provide care for them. I believe this decision not to arrest is based upon the language in the current statute under New Hampshire RSA 594.10, which reads in part, if not immediately arrested, such person will cause further personal injury or damage to property. This language essentially requires the officer to predict future behavior of the suspect in order to make the warrantless arrest. In my opinion, not making an arrest at that juncture places the victim in peril, requiring another assault for a warrantless arrest to be made. This equates to a pattern of abuse. With the unique perspective of having been on both sides of this issue, I wanted to amend the language to provide the police with more clarity in the statute, which would give them greater confidence in making a warrantless arrest, while at the same time providing our healthcare workers a measure of safety and assurance. The result of this endeavor was the amended language to RSA 594.10, which now clearly authorizes the police to make an arrest without a warrant for an assault against a healthcare worker. Oh, look at that. That was good.
Thank you. Would you take any questions?
Yes, please.
Representative Leon.
Thank you, Mr. Chairman, and thank you for being here and taking the questions. My question is about why, if they've already committed an assault, they wouldn't be able to be arrested. And if there wasn't enough documentation to do that, why the hospital wouldn't be able to trespass that person and prohibit them from entering the premises.
So a couple matters. So the language in the statute now does authorize an arrest without a warrant. It's just not clear. So, it essentially predicts future behavior, right? That if they do make an arrest, they're predicting that the person will commit a further offense, right? So, not all police are comfortable making that arrest. And, in my career too, 22 years, I'm hard pressed to think of any time I made an arrest on that language because of trying to predict that future behavior. Trespassing somebody, you have to provide care to the person that's seeking care, so we can't trespass them at that time, right? The trespass can come afterwards, but that includes an administrative discharge of that patient from care from the facility. It's a lengthy process.
Follow up.
Oh, I better understand the problem with somebody who's a patient, but it sounds like there's also the issue of non-patient, which should be solved with trespass. My biggest question here is just trying to make sure that if that person is arrested, they'd be moved to another part of care in order to still get that care, even if they're arrested for assault. I'm trying to understand how to not destroy everybody else's rights in order to respect the true need to protect our healthcare workers.
Sure. Again, so this isn't new language. It's not authorizing the police. It's not giving them more power. It's just clarifying an assault on a healthcare worker. So, and to your point, there are different settings in the hospital, right? So you may have a patient who comes into the ED who assaults somebody, right? And as soon as that patient is cleared, they can be arrested. Conversely, if it's a inpatient, right, the police do not have to arrest, but now they can have, better, more comfort in making that arrest with this new language, and that patient would still need to be medically cleared, obviously, before that arrest could be made. If they're not medically cleared, then an arrest warrant can still be applied for.
Follow up.
Thank you, and I'm sorry for the other question. So even if they're able to arrest them and they're getting care and they're not medically cleared, you're still not removing that patient from the situation where they're placing these healthcare workers at risk. Is that what I'm understanding here?
Well, they can be. They can be. That's the point. So there are times, I'm sure, when a patient cannot be medically cleared at that time. But in those circumstances when they are medically cleared, then yes, they can be arrested.
Okay, thank you. I think this is just beyond my knowledge for criminal justice.
Okay. Representative King.
Thank you, Mr. Chairman, for the opportunity to ask this question, and thank you for taking this question. Earlier, we heard from Dan Mcguire in his testimony that we don't have numbers on exactly how big this issue is. And here we have somebody who is working with this in the field. So can you give us some idea just how big this problem is?
Sure. So, as with the assistance of the New Hampshire Hospital Association, there's a director of security group that meets. And I can tell you that we collect some data from some of the hospitals, not all report. So the data that I have is from January of 2020 through June of 2021, so 18-month period. Out of 13 hospitals reporting, there were 671 reported assaults.
Thank you.
Representative Knirk.
Yes, thank you. Just a quick question back on the arrest of an inpatient, let's say.
Yes,
I'm thinking of the analogy when we have a patient who is an inmate of the county jail or the state prison and is brought to the hospital for care, and they often have a 24-hour guard. They're already convicted and so on, or being held prior to trial. If a person is arrested, I presume that would give the power that then they could have a guard outside their room. Is that what, arresting but keeping on site for care, is that what would happen in that case?
Yes. So, there are some police departments who won't have the manpower to, remain, and that's understandable. That's not what we're seeking here. This is intended to, again, clarify in the statute when the police can make an arrest. I don't think it's reasonable to expect a second assault to take place before the police can make an arrest. And honestly, again, being in that field for a number of years, it's a difficult situation to be placed in to predict future behavior of somebody.
Representative Weber.
Thank you. And just following up on Representative Leon's question about trespass, isn't that a process that takes a significant amount of time also? I mean, this is not something that's useful in a time-sensitive setting, because don't you have to give the notice, have them trespass again, and then take action?
So there is a clear distinction between a patient and let's say a family member, right? So if a family member commits this assault, yes, they can be removed from the hospital at that moment, yeah, and trespassed or arrested. If you're a patient there, you can't be trespassed at that moment. Okay.
Representative Gay.
Thank you. Are you satisfied that the amendment that you said we needed is in the bill, or still needs to be added to the bill?
No, the amendment is added to this bill, and yes, with the work of all the people involved in that committee, yes, it's in there, and it's sufficient to give the police clarity for what they need to do.
Thank you.
Representative McKay.
Thank you, Mr. Chairman. I must admit I've been preoccupied with the size of the commission, which is about at least 45 people. And it seems to me a very large operation, to say the least. But my concern is, are we talking about mentally ill patients? And are they being handled by police instead of being referred to the more appropriate hospitalization? And since you've had experience on both sides, I thought it might be helpful to see if we are talking about the mentally ill.
So it does include everybody, anybody who makes or commits an assault against healthcare workers. And I think there's been prior testimony that maybe you have all have heard, that just because you have a mental health issue does not mean you're not responsible for some of your actions, including assaults. They're not just mental health patients, obviously, who commit these assaults. There's a lot of people who come in who are just, they don't treat people very nicely, and some come in under the influence, and so this is intended to give the police some clarity in that statute and to provide some assurance for those healthcare workers who would have to be in close proximity to that person for an extended period of time. It's very uncomfortable.
Thank you so much, sir. Appreciate your testimony. The chair calls Pam DiNapoli from, I think, NHNA, I'm going to guess is New Hampshire Nurses Association. And remember, we are in the 3-minute presentation rule. Thank you.
I remember. Thank you. My name is Pam DiNapoli. I'm a nurse, and I'm currently the executive director of the New Hampshire Nurses Association. I'm not going to read from my testimony. I just wanted to clarify from some questions that I've heard. I also just want to point out that I had sent digitally. We conducted a study, Violent and Aggression in Healthcare, to provide data to the committee, which fully describes the problem of workplace violence specific to Merrimack County. So I hope you take a minute to look at that. So I also want to thank Senator Gray's committee and then the process. So as you know, New Hampshire Nurses Association has been working for over 3 years to try to get some sort of legislation related to protecting our nurses. So we were happy to be involved with this process. The subcommittee that really developed the language around workplace violence and programs was led by Dr. Sherman, the Nurse Association, Hospital Association, Urgent Care, and Security. So we're also very happy with the way that the language is. The bill, as a result, is comprehensive, it's evidence-based, and it's much needed in this healthcare arena. The problems that it attempts to mitigate include there is a definition of violence. When we look at finding out why nurses don't report violence, it's often that they don't realize that it's violence. So when somebody uses aggressive language against them, they don't typically report that, but that's threatening behavior, and that's something that we have to be aware of. It proposes policy guidelines consistent with the Joint Commission recommendations. So in response to the previous question, the Joint Commission just recently expanded its recommendations around violence in January 2022. Many of the hospitals in New Hampshire are not Joint Commission accredited. So what we attempted to do with this bill was to standardize the policies and guidelines consistent with Joint Commission and those who are not Joint Commission accredited. If you also read in the bill that if hospitals are already collecting this data based on Joint Commission recommendations, they can simply submit that data to the Commission. They don't have to have double work on that. It recommends policies and procedures that prevent and respond to workplace violence, and it was developed by experts in the field. It includes risk assessment. So right now there are many risk assessment tools that aren't often used to identify when a patient may be at risk for violence. It creates in response to what do you do with a patient who's violent. It helps to create clinical pathways for that patient to keep the patient safe. So if the patient is suffering from mental illness and is the root of their aggression, it provides clinical pathways to keep both the healthcare worker and the patient safe.
Thank you. Will you take questions?
Sure.
Any questions? Representative Gay.
Could you tell us the email address that you sent that so we can find it? We get 150 minimum per day.
I sent it to the committee.
We get 150 a day. So could you say
it was-
what your email address is so we can search for it?
Your email.
Oh, my email. Oh, sorry.
The sender.
nhna.ned@gmail.com.
nhna.ned@gmail.
Right.
It's on the letter.
Thank
Representative Wood says. Any further questions? Representative Acton.
Thank you, Mr. Chair, and thank you for taking my question. No, I'm looking at the documentation you handed out here in the type of incident, and I'm noticing that upwards of 60% of the incidents are non-physical, verbal aggression, harassment, intimidation. Having been in a lot of different healthcare settings before, you know, it's a stressful environment in emergency rooms and so forth. You know, I can see that my question is, why are we including so many non-physical incidents where it may be people just angry, having to wait at 3 a.m, so forth? Why are we including that 60% of that in the incidents that we're talking about, including enhanced arresting capabilities?
So when we developed the definition, we used the OSHA standards. So that's based on OSHA standards. And what it does is to say that not all injuries are physical. So if I'm aggressed at work over time, I'm going to suffer some long-term consequences. So we're protecting the overall mental health. So if we look at the suffering of nurses now in the healthcare, because people are waiting and people are angry and people are yelling at us every day, and it's a very difficult situation. So we just wanted to recognize, if I report aggressive behavior, and if you look in the bill, there's a provision that that nurse or that healthcare worker can receive treatment for that. We think it's important.
Any further questions?
And I think I just heard, it doesn't mean they'll be arrested. So if you look at that amendment about who would be arrested, so aggressive behavior, it's on an even playing field. When would it be considered criminal? So it really just helps to de-escalate and provide supports and services to those healthcare workers.
Representative DeLamus.
Thank you, Mr. Chairman. Thank you for taking my question. And you may not have the answer. I'm just curious to know if the person, let's say you have a patient who is aggressive verbally, does that verbal aggression become something that's a record on that person? And does a stack of verbal aggression eventually make that person more apt to be arrested? I don't know.
There's right now that what we've learned from some hospitals that there are policies around labeling. So if there's a person who's consistently reported to have a certain behavior, they could actually be what they call red flags, so that that person would be at high risk, and then the opportunity to maybe not provide treatment to that patient in that facility. Or it also, I mean, risk assessment. So this person's coming in. So one of the evidence-based guidelines is that you have two people. So if you have this person who's red flagged, you identify that that person's coming for treatment, and you have a second person with you so that you're safe.
Thank you so much for your testimony. The chair now recognizes Representative Jess Edwards, who has checked off the box, I oppose the bill. And give us your 3-minute best, Representative.
Thank you, Mr. Chair. I'm Representative Jess Edwards, representing Auburn, Chester, and Sandown. And I want to talk to you about my opposition to the bill as it's currently written. It seems as though there may be a legitimate concern in the healthcare system that's probably been aggravated by the stresses of the pandemic on society. And I just want to be cautious about solving a temporary problem with a long-term solution. Our healthcare system operates as part of our society. It's not separate and distinct away from our society. So I think we need to be very careful when we take a look at things like the way violence is defined in this bill. The definition of violence in this bill is way too broad. We're basically criminalizing the potentially criminalizing words and disagreement. And I would ask that you shave that down, and then it wouldn't be so bad if it weren't for the fact that this would generate a warrantless arrest for words. And so that's just too far. We heard testimony earlier saying that an arrest cannot be made if somebody has been the victim of assault and battery, that the police will only make an arrest if they perceive a future assault and battery. I think that suggests that the law is broken in the criminal justice arena, and that we should be solving the societal problem of maybe an incomplete law in the criminal justice arena, and not trying to solve it in the microcosm of healthcare. So I'm also not interested in having DHHS add 2 bodies for this. I think what could happen is that we should not be mandating this. If the hospital association members think they need this data and this data is valuable and that there's a use for this data, they can voluntarily agree to collect the data on their own without a state mandate. So I would try to avoid that, and because I think this is a potentially dangerous bill in terms of over-criminalization, I would ask that you consider a suspense date on it, so that if we've messed this up by passing it, that it'll take care of itself later, or we could extend it or tweak it to keep it alive. So I'm definitely opposed to this bill as written.
Representative, would you take a question?
Sure.
Representative Knirk.
Thank you very much. Given that there was an article, review article published in 2016, about 4 years before the pandemic, about the problem of healthcare workplace violence, and the fact that it was rather pervasive already at that point, is it not? Would you believe that this is not related purely to the pandemic, and this bill is not a response to the pandemic?
I'd say what you're saying is possibly true, but unless we have the data lined out for us, we're not able to discern exactly what the trends have been in New Hampshire. What is the problem in New Hampshire that we're trying to solve? And do we have a data-driven assessment that we could derive the threat analysis on, and then we could address the threat and not the perception? So that article may be absolutely dead on, but I don't think it may be a necessary part of the puzzle, but not sufficient in my view.
Representative Weber.
Thank you, and thank you for taking my question. This is about the arrest without a warrant. Is it possible that you may have misunderstood the earlier testimony, because 594:10, which is the existing arrest statute, generally, as a first proposition, requires the officer to have seen the crime? And that's what I believe was meant when the gentleman earlier testified, oh, you can't do it on past behavior. A threat, an assault happens, the officer arrives after the assault happens, and they can no longer use that first assault as the basis for an arrest unless they think there's an imminent threat of new assaultive behavior. And this, isn't it true that this language is just clarifying and helping, as the gentleman earlier testified, a police officer who thinks that more assaultive behavior is going to happen and can prevent that assaultive behavior rather than waiting for a second assault to occur?
I agree with pretty much everything you just said, Representative Weber, and I think what you just put your finger on is a bigger problem. If we cannot have our law enforcement arrest somebody for hitting somebody, even after they've attacked the individual, but they may not attack them a second time, I think the law is broken. I'd rather fix that part of our statutes without a carve out for healthcare. I spent over 40 years in healthcare. Healthcare is a special place for me. I just don't think we should be carving out exemptions unique to our healthcare providers.
Representative Leon.
Thank you, Mr. Chairman, and thank you for taking the questions. I'm saying that this is a bit of a pivot. I'm saying that urgent cares are all going to be included, and the only ones that will be represented on the board will be those with 3 or more locations. I was wondering if you're aware, if you know how many single or 2 location urgent cares we have in the state, because this is going to be overly burdensome on them.
I made the last 5 years of my career in compliance, and compliance with anything, it can be very expensive. It can eat into scarce resources. It can distract the organization from its primary focus. And I do not want us to continue to build a compliance state. I would say to your question, I don't know. I don't know what the numbers are. But if the hospital association wants to build a voluntary community to gather this data because it is widely perceived to be an issue that needs to be addressed, I would do that on a voluntary basis without the government in the room.
Representative Knirk.
Thank you very much. Would you believe that on page 6, in the section where it adds the specific information in about warrantless arrest, that it doesn't really change the question about whether assault has been committed or not, but it mentions, it explicitly brings in healthcare facilities in terms of saying that it's either through actual or threatened violence will interfere in the provision of medically necessary healthcare services. So do you not think it's important if we have a person who is disrupting the function of an urgent care or an emergency room in a hospital so severely that other patients who are having a heart attack cannot be treated because they cannot deal with this unruly patient who has disrupted the work in the EW? Is that something you contend?
No, sir. I would say that you and I are probably have far more in agreement on this than your question would imply, I think. I do think we need to have continuity of operations in our healthcare environment. But we need that in everywhere. We need that at Walmart. We need that at the gas station. We need that. That's a general societal issue. And if the issues that the healthcare community is experiencing is to the extent that it's generalizable to other settings, we should be fixing it overall, addressing it overall, and not just in the healthcare operations. And to your point about page 6, it does specifically say, while in the care of medical professional or on the premises of a residential care or healthcare facilities, that by definition is a carve-out.
Representative Knirk for follow-up.
You made an analogy to Walmart. Do you feel that it is just as important that a person can buy a coat at Walmart as it is to get their heart attack treated in an emergency room?
I wouldn't try to draw an analogy between them, because I think all people and all employees in all walks of society have an expectation of public safety, and that the state has an obligation to create or to support an environment in which public safety is a generalizable good part of our society. And so it's like the healthcare system is saying, well, I'm thirsty, and instead of giving them a glass of water, we're turning the fire hose on the people who use the system.
Thank you, Representative Edwards. The chair recognizes Jeffrey Ward from the Attorney General's office. And I think since some of our questions were legal questions, here's the guy.
Thank you. The legal question.
Microphone.
Thank you. I hope the legal questions that were asked will get re-asked, because I'm happy to provide any clarity on that. But my name is Jeffrey Ward. I'm the Chief of the Criminal Justice Bureau at the Attorney General's Office and a Senior Assistant Attorney General. I was involved early on with the Committee to Study Workplace Safety, spoke and addressed that committee a number of times, and actually even prior to that was engaged by Senator Sherman with the former Attorney General to start to work on language and solutions that would help address this issue. As both Senator Gray and Senator Rosenwald said to you, significant work and thought went into the language used here. It is minimal. It is a targeted solution. It does not expand the criminal law in the sense that no new crime is created. And I think that's important for the discussion that I've heard thus far. And important to understand that this bill has two very separate sections. It has the section creating the commission that has definitions, and then it has the section that amends the warrantless arrest statute. So for example, the definition of workplace violence is not a criminal definition. It would not become part of the criminal law. It would not impact or change anything about the criminal law. That definition relates only to the commission itself and deals with, as I think was addressed, OSHA standards and things of that like, but would not become a definition of workplace violence under the criminal law. I think the committee needs to be aware what it means for there to be a warrantless arrest. Currently, warrantless arrests are permitted for any felony offenses. So felony crimes, there already can be a warrantless arrest for any felony offense, regardless of where it occurs. Currently, there are warrantless arrests for DV, domestic violence related misdemeanor crimes as well. And the rationale behind that and the reason for that and the reason you see for the language here is it allows for an immediate response. Because otherwise, misdemeanor offenses, if not domestic violence or if not addressed by the amendment here, require the officer either witness the offense themselves in person for there to be a warrantless arrest, or requires, as Sergeant Patty discussed, a prediction of future behavior. And so what that has resulted in that prediction of future behavior section, as I'll refer to it, it's very difficult and rarely, if ever, as you heard through testimony, is utilized. So instead, carving out this very limited language that allows for warrantless arrest under these limited scenarios within a healthcare setting allows for the immediate response to these issues. And that's because healthcare settings are very unique in that there are few, and I certainly struggle to think of any, where a victim of violence is required both professionally, ethically, morally, to stay in contact with the perpetrator of that violence.
Are you willing now to take questions?
I am more than happy to take questions with respect
Any
to this.
questions? Representative DeLamus.
Thank you, Mr. Chairman. Thank you for taking my question. Do the officers, I'm sorry to ask this even, do the officers still need to witness the act of violence to make an immediate arrest for a misdemeanor?
So under the current law, for there to be a warrantless arrest for a misdemeanor offense, an officer would need to witness that misdemeanor offense. Under the current law, for there to be a warrantless arrest, for example, of a felony offense, the officer does not need to witness the felony offense. It only applies presently to misdemeanors. And with respect to that, I also think it's important to understand, we're all familiar with the warrant process. You go to the court and you apply for the warrant based on the facts of the case, and the court determines whether or not there's probable cause. That doesn't go away in the warrantless arrest scenario. The arresting officer still has to supply to the court a statement that makes clear that there was probable cause for that arrest, and the court still reviews that. So the constitutional protections you have in place for an arrest with a warrant don't go away simply because there's a warrantless arrest. Those constitutional protections remain. They occur after the arrest has taken place, but a court is still going to review and make a determination as to whether or not there was probable cause for that arrest.
Follow up?
Follow up.
Thank you. Would you believe that I fear that we are, I want to know how we are making our officers have to become thought police. I'm very concerned about that an officer has to predict whether or not someone's going to act after the fact. I'm not even sure how that's a question.
So, what I can say with respect to that is the current law that would be most applicable in the scenarios that have been described for you in healthcare settings would require a prediction of future behavior, which is why it's not utilized. Okay, it's not utilized because we don't make those predictions of future behavior. What we're asking for and what the committee has came out of the committee to study workplace safety was, rather than ask for that prediction of future behavior to make sure that workers are safe in a healthcare setting, again, where they're required to be in contact with this individual on an ongoing basis if that individual is a patient, is that you don't have to predict that future behavior. If there's been an assault, then you can go and make that warrantless arrest. You can go and make that warrantless arrest without having to leave and go apply for an arrest warrant, And that can take a significant amount of time, as you've heard earlier. Instead, that officer can go and make that warrantless arrest. If that individual is still in need of health care and can't be discharged, that officer can remain on scene and provide the safety and security for that health care to continue with that individual who is then under their custody. I think there was a question over here earlier about whether or not, sort of analogizing this to when patients from the prison are transported to medical facilities, they are accompanied by someone. So someone can be in custody without having to be taken to jail. Officer arrives and places that person under arrest without a warrant. They are then in that officer's custody. They can remain at the healthcare facility as long as is needed to have their health care done, to get treated, and then can be transported from the facility. But you then there have an officer on scene and an individual who's under the custody of that officer, who's under the control of that officer while they're receiving their health care services.
And this is current?
No, this is what I'm telling you this would do, would create that scenario. Yes.
Okay, thank you.
Representative Knirk.
So, sir, would you agree then that perhaps healthcare facilities are a little bit different than Walmart and other places? Because when we have an event in an emergency room or even on a hospital floor, the impact goes beyond just the worker who has been threatened, but can actually stop the provision of care to others, including particularly critically ill patients who could conceivably die because they cannot be cared for due to the disruption, and therefore removal of the disruption would be helpful. Would you agree with that?
I do. You know, as I discussed earlier, this is a unique setting where someone could be a victim of an assault. A healthcare worker can be a victim of an assault, and they are required to stay. They are required to remain in contact with their assailant if that person is the patient. Continue to provide them healthcare services, as are other healthcare workers who may have been there or witnessed that assault, or who may come into contact with that patient thereafter. And that was the issue in the committee to study this that came to us most regularly from the healthcare industry and folks that work in that field. Is they have a job to do. They need to be able to do that job. They can't stop doing that job because they've been assaulted by somebody. They can't say, sorry, sir, you know, we're not going to treat you anymore for your medical issue because you've committed a crime. In spite of that fact, they still have to do that work. And so that's why this was a limited, targeted way to get an officer on scene, to get that person potentially in the custody of that officer. Again, there's nothing that requires the arrest, but they certainly may arrest and have that person under their custody and their control in order to allow for those healthcare workers to continue to do their job safely.
Okay, last one, Representative Leon.
Thank you, Mr. Chairman. I appreciate that the violence doesn't carry over to the language from the licensing statutes. Where in the criminal code is medically necessary healthcare services included? Because I'm concerned I'm concerned about the implications of using provision of medically necessary healthcare services to allow a warrantless arrest when that's not defined anywhere in the criminal code, if that is the only section where definitions apply.
So with respect to this section, this would become part of the criminal code. So the provision of medically necessary healthcare services, to the extent that that were to be interpreted by a court or questioned by a court, if there was an argument that this arrest was invalid because the assault did not occur during the course of the provision of medically necessary services, it's a term the court would have to define and interpret, and absent a statutorily created definition would be the dictionary definition. And we would call on the healthcare providers to provide testimony as to whether or not that medical care at the time was medically necessary. For the officer on scene, that would be the question asked of the individuals who were providing the health care, who contacted law enforcement.
Follow up.
Is what was going on medically necessary?
So absent a definition in the criminal code, would it then reach to statutory definitions in the rest of the New Hampshire code before going to the dictionary?
So with respect, whether or not medically necessary healthcare services is defined elsewhere in the code books, certainly the court could look to that. I can't tell you exactly what they would do, but most commonly would refer to a dictionary definition.
Thank you so much for your testimony, and I'm now closing the hearing on Senate Bill 459 FN. And since this has to get out the door sometime today and the schedule has become more than problematic, I'm going to now open the exec session on 459. And if we have any amendments that wish to be considered.
Yes, I have an amendment that I can pass around here. I'll try and split it somewhat evenly. It's a bit short, so I will lead ahead of you receiving it. It's amend the bill by replacing all after Section 3 with the following, which is a new effective date. That removes the warrantless arrest because I believe there's still more may I speak to that? And I believe there's still more questions that should be handled by criminal justice.
If you are looking at the bill, the removal parts start on page 5, line 35.
And they go through page 6, line 4, and it removes line 6, which is the effective date of that removed section.
So I'll wait till everybody gets the amendment, but that is what it does. It removes that last little part about arrests without warrants. And when everybody has found that, we can have a discussion about it. Yes, Representative Snow. But first, before you ask the question, what do we do? What do we do next?
Oh, sorry about that.
I'm gonna miss him.
Thank you. I was going to ask the lawyer this, but I didn't. We ran out of time, I guess. Number one, I'm bothered by the fact that there's nothing that I could find in this bill that says how frequently this commission has to meet. Most commissions say you meet quarterly or you meet. How often does it meet? Is it only at the will of a chairman, or how does that work?
Could I suggest we're going to discuss the amendment and the amendment only?
Sorry.
Then we'll have a chance
Thank
to
you.
do the other. That's okay.
I'm sorry.
No apology necessary. Representative Knark.
I think I have a slightly different take on the warrantless arrest section than some other people, because I really don't see where it enhances how arrests are done as much. It defines this issue of if you actual or threaten violence, interfere in the provision of medically necessary healthcare services. With the old lingo we used to use when I was around, we used to call them disruptive patients. These are patients who came to the emergency room and were perhaps yelling, screaming, throwing chairs around, doing stuff they maybe hadn't even truly physically assaulted anybody, but it brought to a standstill the care in the emergency room for a sustained period of time until they could be dealt with. And this would give the ability for law enforcement to come in and get that person under control so that care can be given. Because, I mean, think a little bit about what we see in airplanes, which is, we see some certainly disruptive behavior there, where we can't call on law enforcement to arrest, but there are things that are done in that setting. But the healthcare facility is a different place. It's trying to provide care for people who may be coming in the front door with a gunshot wound, with a heart attack, and if you disrupt that flow, you're going to cause harm to other people. I think it's not just the workplace, the worker who gets harmed. And the patient, it's other patients who get harmed. And this happens on the floor too, when we have to shut down the activity of a certain portion of a wing because we have a highly disruptive patient.
Representative Leon.
I appreciate, Representative, that is a very significant concern. My belief would be that if patients walking in would experience that disruption, so would an officer responding. So an ongoing disruption would be something that they were witness to and able to see and able to address. So while I appreciate just how disruptive that can be, I think that is a different case than what we're looking at here. Would you like me to move the amendment or not yet?
Representative Nadarapam.
Several years ago, I was running a group in inpatient psychiatric hospital alone with about 10 teenagers. Nobody's behavior was escalating. And then out of the blue, a hand went around my throat, pulled me back against the wall, and I thought I would die. I was beginning to black out. Eventually, one of the other kids left the room through the kitchen and called staff, and I'm sorry, it was upsetting, but the girl who assaulted me was 17, taller than me, stronger than me, and it was already an inpatient psychiatric hospital. There was not a room where they would have locked her away, so staff kept her. I went somewhere else, and she was arrested and removed from the hospital. So a 2-week warrant would not have worked for her. Had she not been removed from my group in this hospital, I would not have returned to work because she was capable of riling up all the other patients as well. So I think that's a different instance than some of you others have experienced, but it was the appropriate response. So however amendments could be worded to in the moment, she needed to be removed. Needs to work out. So I wanted to give that perspective, and I'm sorry.
Anyone else wish to share, speak? Representative Gay?
Thank you. I was wondering, you said, Representative, you said that that girl was arrested. So I'm wondering, it sounds like we're splitting a hair trying to make sure that the current law can be used to remove a person who has just done an assault but's not continuing to do it. And it sounds like we're trying to, with this large bill, address that instance. The patient hit somebody or threatened them severely physically, and we need to make sure that we're giving law enforcement the right to remove them, or at least to keep them from assaulting anymore while they're getting this treatment. Am I understanding this correctly? This is what we're trying to address. Because I have severe problems with lumping physical with verbal abuse resulting in an arrest.
Thank you. Representative Soloway.
Thank you, Mr. Chairman. In community health, we practice what is called the precautionary principle, and we have to balance what we anticipate to be incomes or potential incomes with past events. I must say that given our experience as a nation, we are at risk of violent events in healthcare settings in New Hampshire. If we wait for those events to occur, we will wring our hands and say, what could we have done to prevent this? But we are at a juncture where here today, we can be preventive. We can practice our precautionary principle. In addition, we can help to create secure confidence among vulnerable healthcare workers. There are certain systems which are vulnerable. Walmart is not one of them. An airplane or an airport where security is an issue, that's a vulnerable system. Our healthcare settings are highly vulnerable systems. If we make the call to security, it takes minutes for security to arrive. The episode is over in seconds. Security arrives to do cleanup, not to do prevention. We have an opportunity here right now to do prevention. I'd like to speak against the amendment, and when it comes time to vote, I will vote for the bill.
Representative Weber.
Thank you. And in addition to Representative Salloway's comments, I want to remind the representative that this is the criminal statute, so it's not taking action on verbal actions unless they are threatening of criminal assault. And then you don't have to wait for a criminal assault to be witnessed in order to avoid having the criminal assault happen. But just saying, hurry up and get to me or something like that and yelling is not included because that's a different part. That's the civil part of the statute. It's not the criminal part. And I too will be voting against the amendment.
Anyone else? Representative Shapiro.
Yes, I just want to remind people at least in my hearing of the testimony and my reading of the bill, how small a change we're actually making. In the case of Representative Nutter Upham, perhaps that was already a felony, a felony assault, and so they didn't need a warrant to make that arrest. And that's the case without passing this bill. And this, from my understanding, this in no way criminalizes disagreements or people being frustrated with words. So this just gives a small amount of increased flexibility for law enforcement when they arrive. And like with many things that we deal with, there's a trade-off. There's patient safety and there's the continued safe operation of a medical facility, and there's the personal freedom of someone who might in this situation get arrested. But I guess I will vote against the amendment because I think this is a very small incremental change which will help healthcare facilities remain more stable and more safe.
I instruct my staff at our medical facility that if people are just spouting off, that's one thing. If people are angry and upset, that's another thing. But whenever they start to say something threatening to a staff, they are immediately to leave the room and call the police. And we will then instruct the police as to what has been said, and the police gives us the presumption of being the correct one, and action is taken, which we leave to them. I would like more discretion ability here, and I will be voting against the amendment as well. Anyone else? And then we'll give the representative last call. And this is the last one who will now be speaking to this.
Thank you, Mr. Chairman. I will share some of my personal experience. When I was at Boston Medical Center waiting for surgical repair of my broken femur, my life was threatened by one of the janitors. I understand that yes, I'll tell you sometime over some other drink or something, but it was threatened by one of the janitors. I understand that there are threats. I understand that there are risks. I did not bring the amendment that I think probably would have been most effective because when seconds count, security and the police are far away. I thought perhaps the best way to address these lethal threats to healthcare workers would be to prohibit the prohibition of carrying tools of self-defense. However, that's criminal justice, just as adding this change to misdemeanors is. So I guess I will go ahead and move Amendment 2022-1387H.
Do we have a second? Representative DeLamis, and we really did this in reverse order. We've discussed it. And this is the chair speaking to Republicans, particularly seat fillers. It is our normal protocol that the vice chair kind of signals to the caucus how the caucus is to vote. But since the person moving the amendment is that person, any Republican in here is not doing violence to, I didn't mean that, doing, I really did not mean that, doing injustice to, you may vote your conscience, is my, including seat fillers. The motion before us ought to pass on House Bill 459, Amendment 1387, moved by Representative Leon and seconded by Representative DeLamis. The clerk may call the roll.
And it will be the assistant clerk. Representative Leon.
Yes.
Representative McMahon.
No.
Representative Acton.
Yes.
Representative Gay. Representative Mooney.
Yes.
Representative Folsom.
Yes.
Representative Bohm. Representative King, no. Representative Kofalt.
Yes.
Representative DeLamis.
Yes.
Representative Weber.
No.
Representative McKay.
No.
Representative Snow.
No.
Representative Knirk.
No.
Representative Soloway. No. Representative Cannon, I'm sorry. No. Representative Nutter Upham.
No.
Representative Shapiro. No. Representative Woods.
I'm sorry, no, I'm trying to get my.
Representative Query.
Sorry.
And Representative Pearson.
No.
All right.
I hope that light didn't burn through your body there.
One, two, three, 6, 7. We're missing something.
Does anybody get a number?
Just a second. 1,
8 to 13.
okay.
That's what I have.
Somebody here then. 8 to 13.
8 to 13. The motion is defeated. And now the chair recognizes someone for the bill to, before us. Senate Bill 459. Do I have a motion? Representative Weber. Representative Weber, the motion is ought to pass. I'd like to get a Republican, if I may, because we like to do these things here. No, you don't need to change parties. That's okay. Thank you for the offer, though. I will second it then. And any further discussion? This is the bill as before us. You want to speak?
Yeah.
Okay.
Thank you. I actually have the most problem with the size of the commission. All these people, we are getting bills in front of us now over and over because commissions and committees cannot form a quorum because there's so many people assigned to it. And I really struggle with the fact that there's just, and I'm not just talking legislators here. I'm talking about the general public trying to get 45 people all showing up, enough of them at a meeting to have a quorum to vote on something. So I'm voting no based on the whole commission setup.
I'd like to ask, can somebody point me to where a quorum is defined in the bill? I don't see it, but that's just me. Representative Weber.
Quorum generally, when not defined, is half plus one, but based on what I understand, and perhaps if I am wrong, somebody in the audience will make loud noises, the current Safety Commission is a commission that has an enormous amount of people who go, because what they are doing is sharing data among themselves and sharing best practices. And my further understanding is that it's important to have this done not voluntarily, but in this setting to keep everything very confidential so that people can have those conversations safely. And my understanding is that because this is something that the folks who are the most affected want, people come and they share information, and perhaps it's not necessary to have a quorum. It's the sharing of the information that is important here, and the ability to look at each other's practices and learn from each other. And that is why I think, although I share Representative Folsom's deep concern with large commissions, I think that this one is an exception to that. And so I will be voting for the bill.
Can anyone from the audience make a loud but not threatening noise as to the comment? Ms. Manahan. That was very gentle, but not to the point.
Since Chris, good morning. Since Chris Herring is actually staff to the Quality Commission, I think you should hear it from the source.
Source.
Representative Weber, you are spot on. when you speak to the fact that the people that participate want to participate and that the sole purpose is to share information and to learn from each other. And that's how, and with that confidential protection, people feel that they can speak very frankly and that they can learn best practices and identify ways forward that they would not be able to do individually.
To that point, has it been your experience that there's ever been a difficulty because of a lack of quorum?
No, sir.
Okay, thank you. Representative Berm.
Thank you, Mr. Chairman. Yeah, I agree on the side of the commission and what's been done in the past on large commissions. You keep them small and then you, in the bill, you say and this following will be invited. And I'm having a problem figuring out how many on the commission, because item C there on, one, it says one representative from each non-hospital affiliated urgent care network of 3 or more. How many is that? I mean, that's kind of vague. So anyway, yeah, I agree. Commission is too big, and there are ways of making smaller commissions.
Representative McKay.
Chairman, I added up about 45, and I was preoccupied with the size and not paying attention to the rest of the legislation. I will vote in support with the understanding that the commission is going to understand that some of that behavior that happens in hospitals is because the person is mentally ill and that they need help themselves rather than being arrested. In fact, the criminal side of that is very complicated in terms of competence, so that I know I get repetitive about mental health, but this is a good example where somebody is demonstrating very clearly that they have a serious mental illness and don't need to be arrested for it, but they do need to be hospitalized and taken care of. And therefore, that allows me to vote for this.
Representative McKay, may I speak to that in that 47 years of visiting parishioners in the hospital, I've witnessed all kinds of things. And in 2 instances where there was a relatively low-level physical assault by a patient who was arguably mentally in need of special care, it was handled differently than somebody who just got angry and popped somebody. And I was very impressed at how the hospital did that. And my assumption is hospitals are aware of this and, for the most part, absent evidence, are doing that. Representative Knurk.
Yes, also, I'd like to point out that, again, it comments that the first step is de-escalation, which would be in a mental health setting, working toward trying to treat the mental health problem. But the other thing I'd like to point out is, earlier Representative Leon was concerned that we didn't have enough people because we were maybe leaving out urgent cares of only 2 or fewer, and Representative Folsom thinks there's too many, so it sounds like we've hit the Goldilocks spot of just the right amount.
Or the theoretical possibility of you can be wrong in 2 different directions at the same time. Representative Folsom.
You know, my thought is have a commission that's much smaller, but ask for reports to be given by those other people. They could come, give their report. They can even stay in the room while others give their report, but it'll be a smaller commission that actually writes the overall report that comes back to the legislature with all the data. And so that those are the people that have to be there. And that is a smaller number and easier to handle than 45 people in the room, you know, trying to discuss and vote on something. So I have a whole different concept of how that could work much better.
Representative Gay.
Thank you. My vision, I can understand why you would want a large number of people invited so that they could all have input. My concern is I didn't see exactly what the output's supposed to be. To me, it makes good sense just for these people to be together, talking, learning from each other without an output, but usually a commission has an output. So I was wondering if maybe we ought to just specify if it has to have a quorum, let's specify a low number and let it be just an educational, ongoing educational organization is what it is, in my view, when you have 45 or more people, which is it's a fruitful endeavor. So I see it as a good thing. But if we got to say how many people have to be there for a quorum, if that's a requirement for a commission, let's just amend it and put a low number.
Representative Snow.
Thank you, Mr. Chairman. A couple of things bother me. I'm also bothered by the size and was surprised to see that the New Hampshire Hospital Association was not included in that number. And I wondered why they weren't. And would a possible solution be that, what? Sorry. But could that, even if, I'm glad they are included, but could they have sort of a subcommittee that made up of all the hospitals and have them give the report to the entire committee rather than have all 45 people serving on that committee? Point number two, I think there's nothing in this bill that indicates how frequently this commission is going to meet. And, most of those commissions either meet quarterly or some other. So there ought to be something in the bill that requires them to meet periodically. And finally, I'm bothered by section 151J5 on page 4 at the bottom, the confidentiality. One of my concerns is that all the information given by an individual to the commission about an act of violence that they either had committed or witnessed. What happens to somebody who was, I know of one nurse who was permanently and totally disabled by the assault that was committed on them. And obviously they're going to go to civil court to try to recover some of their damages. And with the fact that that person gave testimony to this commission preclude there being a witness in that civil trial to get damages to them because of the protections that are built in.
Representative Weber.
Okay. This bill is not something that comes initially from the legislature, is my understanding, but it comes initially from the people who are on this commission. This isn't us collecting the names of people. It's them saying that through a process of negotiation over a great deal of time, the stakeholders have agreed that this is the best way to do what the stakeholders want to do. And therefore, given that very few legislators and possibly no legislators are included, I think we ought to approve this bill so the stakeholders can do what the stakeholders need to do. They need our approval because of the issue of confidentiality to be able to keep their workings confidential for the protection of the people who are involved. And I see the confidentiality requirement as being the commission can't go out and tell people what happened within the commission, but I don't see it as somebody who is not on the commission who may address the commission then being barred from doing what they need to do outside of the commission. I think that we are working too hard to create problems where none exist. And we have had two people oppose the entire idea of this commission. I get that. That's their opinion, and they're entitled to it. But the people who are affected by the commission want this commission. I think we ought to give it to them. Thank you.
I've served on several commissions, committees, and councils. And in one of them, somebody who was a new member and had only ever served on one of these kinds of things said, "Oh, but this isn't how we do it on such and such." And the rest of us who had served on multiple said, "Your one experience does not define how a commission, committee, or council works." If any of you have been, some of you have been on multiples of these, each has its own unique life. Representative Kofalt.
Thank you, Mr. Chairman. My concern, well, I guess the question I would ask first and foremost is, why the stakeholders who are interested in this require the state to establish a commission at all. They are free to get together, meet, discuss, set standards. This was one of the objections that was raised is our data is incomplete and we don't have standardized data. I think there's nothing to prevent the stakeholders from gathering, setting standards amongst themselves, and seeing to it that there is a regular reporting process there. To the extent that there are any who choose not to participate, I think that is an entirely appropriate voluntary step if there are healthcare facilities that don't believe that it is helpful in preventing workplace violence in their organizations. The other concern I have here is some of what we heard with respect to the definition of violence. To me, a violence is an intention to harm. And there is, words can be a statement of intention to harm. They can be threatening. Nevertheless, I'm a little concerned when I hear statements like someone may not know that they were subjected to violence. This, to me, suggests a broadening of the definition, which just makes me a little bit uneasy when we start to expand the scope of words like this in ways that have very real-world ramifications for people who may simply be upset and are voicing a complaint, perhaps voicing a complaint in a higher tone of voice than they might otherwise. Will that be construed as violence, even though there is no threat involved with it? So these are some of the concerns that I have about this bill, and I intend to vote against it.
Representative Weber.
I'm going to take one more stab at the confidentiality concept. The data that they're talking about is all confidential because it's people's medical treatment and what happens in the medical treatment section. So they can't share it because to do so breaches confidentiality. They can't share it just among themselves. Oh, let's get together and share it. They can't do that unless we authorize them to do that. And once you have shared confidential information, it's no longer confidential. So we need the provisions of this statute both to allow them to have the meetings to share the information on the one hand, and to keep that information protected on the other hand. And that's what the confidentiality language in here does. So this can't happen unless we help it.
To the question of why don't they just get together and then make some recommendations, I would argue that they have and they did, and that's this bill. Representative Knurk.
Yes, thank you. I just want to get back to that size thing because that seems to be one of the big bugaboos. If we look at Chapter 151G, which is the New Hampshire Healthcare Quality and Safety Commission, its members are almost identical to this in terms of how they're appointed. It's also one representative of each hospital, one representative of each freestanding ambulatory center. They have around 50 or something like that, and I understand that they have been able to meet quorum because these are people who want to work together to do this. We're giving them, as Representative Weber has just said, the ability to do it with proper safeguards and guardrails. And I think, again, since they're asking for it, they're likely to show up, and I think we have the Goldilocks position.
Representative Leon.
Thank you, Mr. Chairman. I appreciate now much better the need for them to have a commission where they're able to share that information, which is confidential, together. There are other problems, though. And this takes a much bigger bite than just allowing that group to meet and share confidential information. It allows them to advise on rulemaking and rulemaking on people who don't have a seat at the table, like those urgent care centers with 1 or 2 locations with the most economic stress and business costs for them, and then would have to comply with things that were designed for hospital systems and for large multi-location systems. That's one concern, that might put 1 and 2 location urgent cares out of business or force them to consolidate if they exist. Maybe they don't. We don't know. Then there's also no guidance to the legislature, and it doesn't need to have legislative members. So why is this then taking that information, changing definitions in the statute, and reaching far greater than providing a protective umbrella for this group to meet. I better understand the need, but I think that this bill goes too far. I agree with a lot of the concerns that are here, and I think that I wish we had the time to carve this out and make it a lot tighter. But if there's guidance on rulemaking authority, when you only have some people at the table, when you're changing definitions in law where words spoken not necessarily out of mental illness, out of pain. When you're in pain, you are not in good control of your words either. That when somebody is in pain trying to get care, they may not be understood. They may have somebody saying, "Oh, honey, your leg's not broken." Even though it is, you get a little harsh at that point, and I might have been arrested underneath that for what I said to the woman in the emergency room. I know it wasn't kind, but I was in a lot of pain. I believe that at the core of this is good and at the core of this is helpful, but I think that everything that surrounds the core is a problem, and because of that, I unfortunately am going to have to vote against this.
The chair has a parliamentary question for the parliamentarian. Is it possible that any of these concerns, adding extra care center or something, could be crafted as an amendment to be presented when the bill goes to Finance 3 and it's dealt with there?
It could be, in much as I deplore the process, Finance does it regularly.
Well, I know the guy who chairs Finance 3, kind of like him too, and so not to give him extra work, but that's just, we are deploring what isn't when I'm trying to suggest what could be. Okay, Representative Knirk.
Just a quick thought. Workforce, healthcare workforce in this state has been a problem, and it's been a problem for a number of years, and it's only getting worse. And we already had information about that this is a problem that's gone on for a long time, and references to the issues of burnout and people leaving the profession because they just can't take the abuse anymore, plus other issues. This is something that our workers want and deserve, and our hospitals want to be able to protect them and be able to staff. I think we should vote yes on an ought to pass. And could I move ought to pass?
No.
Oh, it's already moved. I'm sorry. My apologies.
It's a nice thought. Yeah. Representative Acton.
Thank you, Mr. Chair. I oppose this bill for a variety of reasons that have been mentioned, but I'm also worried about the exemptions that are giving to the facilities that are covered under the JACO or the so that divides it. So we don't really know, is the Elliott Hospital, CMC, Dartmouth Hitchcock, are they even part of this, or are they given exemptions because they're already doing this through their accrediting agencies? And also, the final point.
Let's the expert answer that exact question.
So Representative, just to be clear, you are wondering which ones are under this because they're joint commission versus not. We were just using joint commission as a structure because I think as Pam DiNapoli explained that they have this in the joint commission regulation, that their regulations, if you will. So we wanted a structure that all would be under, but every single hospital would be part of this. We're just using that as the structure because DNV and CMS did not have this specific instruction. But every hospital or every facility, hospital and urgent care center that participates would fall under the same guidelines. It was just a guidance.
Okay.
Representative Acton, you may continue.
All right, thank you. And finally, like this horrible situation that occurred to my friend from Nashua, the facility itself is actually the first line in preventing things like this happening. She should have never been in that room alone. That was a problem that sets that facility up for liability, and the facility should be taking action on this, not waiting years later for us to come up with a law. So that's my opposition. I plan to vote no.
The bill before us, the motion before us is ought to pass, as is. Senate Bill 459 FN, moved by Representative Weber and seconded by the chair. Would either of the clerks please call the roll?
Representative Leon,
No.
Representative McMahon,
Yes.
Representative Acton,
No.
Representative Gay, Representative Mooney,
No.
Representative Folsom,
No.
Representative Bohm, Representative King, no. Representative Colfelt,
No.
Representative DeLamus, Representative Weber, Representative McKay,
Yes.
Representative Snow,
Yes.
Representative Knirk,
Yes.
Representative Soloway,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Woods,
Yes.
Representative Query,
Yes.
Representative Pearson.
Yes, 12-9. The bill passes 12-9. And we will take a 10-minute mercy break and then come back and throw ourselves into SB 407. And I apologize for all the nasty thoughts, any senators in the room, that I've had when I've gone to your hearings and had to sit a long time waiting for my turn. I apologize for those thoughts.
Do you need a minority reporter?
Would you write the minority report?
407 relative to expanding Medicaid to include certain postpartum health care services, making an appropriation. Therefore, the chair recognizes Senator Prentice to present her bill. When the music stops, you may be seated. It has. You can bring
Can I
up.
bring up Henry Lipman? From
Oh, you can
DHHS
bring them
to
all
join
up.
me? Okay, we'll just start with Henry.
Did you ever get your vacation, Mr. Lipman?
I did, and I had a good one.
Oh, good. We'll look at slides later. Okay, thank you. You do look tanned. You went to the Cape.
Was there a sun on the Cape? Oh, it is.
Third time was a charm.
Yeah.
Well, here we are.
Yes.
Okay. Good morning.
Good morning.
Good morning, and Chair Pearson and members of House Health and Human Services and Elderly Affairs. For the record, my name is Sue Prentice. I'm the state senator representing District 5, which are 9 communities along the Connecticut River Valley of beautiful Connecticut River Valley of New Hampshire. And yes, and Representative Pearson, or Chair, I'm sensitive to if I've ever made you have to wait for a hearing. I apologize. I'm okay with waiting my turn.
You're kind of doing that now. Would you
Yeah.
start the testimony?
Just being sensitive. Okay, so I'm here today to introduce Senate Bill 407. This is the Healthy Moms, Healthy Babies Act of 2022. This legislation would amend the state Medicaid plan to provide 12 months of continuous coverage for new moms at a most vulnerable time, the postpartum period. There is a group of New Hampshire moms who become eligible for Medicaid coverage under what's known as the pregnancy pathway, and this goes through 60 days after giving birth. This group, due to their income, which is 196% of the federal poverty level, are not covered under the granted advantage. We have an opportunity here in New Hampshire to cover these moms for this full 12 months after giving birth and take advantage of matching federal dollars available to New Hampshire under the American Rescue Plan to do so. Emily Baker, who is a high-risk obstetrician at DHMC, shared with me that the Maternal Mortality Review Board in New Hampshire has also found what is absolutely clear across the nation, that the numbers of maternal deaths are increasing, and the majority of these maternal deaths are occurring during the postpartum period, as well as the vast majority of these deaths are preventable. Some different examples of pregnancy-related conditions that can go through to a postpartum period, because we have to remember, although it might be defined as 60 days in this particular category, a mom postpartum, a calendar, a condition doesn't count the 60 days. It counts until it can be taken care of. So circulatory concerns such as heart failure and blood clots, infections, complications from anesthesia, addiction-related issues, and depression are just some of the postpartum conditions related to that pregnancy that their treatment may require, and many do, past 60 days. This rise in postpartum deaths correctly infers that there's also an increase in the burden of medical and psychiatric morbidity that needs to be addressed, and can only be addressed when these women have access to health care that they can afford. In state fiscal year 2019, the New Hampshire Medicaid covered 2,795 women in this pregnancy pathway category, as I refer to it. Okay, so that is 2,795 women. No, they covered pregnant women. 762, which is 27%, lost their coverage 60 days out. So that would be I stand corrected, our pregnancy pathway women. I was getting excited and kind of moving ahead. So 60 days out, as their incomes were a little too high to qualify for the granted advantage, which is our Medicaid expansion program here in New Hampshire. We have a remedy to cover these women before us. Our moms, their babies, and families cannot wait. Let us take this opportunity here to close this gap, to provide coverage, which provides access to health care in places in New Hampshire for families, New Hampshire moms, and our smallest, most welcome members of our state at home on a solid, let's start them off on a solid foundation for their lives. I am happy to answer questions that you might have. I have a number of technical experts with me to address some questions that I think may come up. So I'm starting with Director Littman from HHS, because I'm sure there are questions about how this works.
Chair has a question. This is your map, right? This is a map, your map in defense of the bill. This is other states doing something like this, right?
Yes.
I like to look at maps, would you believe, because I like to see what kinds of states do things. And I'm noticing that pending legislation on this is in that left-wing bastion of socialism called Alabama.
Yes.
And so when I see things that look counterintuitive, it makes me quite curious that this does not seem to me, looking at the map, the predictables are saying yes and the other predictables are saying no. And would you care to comment?
Yes, I think that you've made the observation that I was intending by sharing the map, that this seems to be, states like Texas and, New Jersey, California. You pointed out Alabama. I think there's actually one more update to this map that since April, that Louisiana, another state that you might not expect to be in that grouping, Missouri, have looked at this issue. And when you look at it, it's really not, there are costs of doing this which aren't great, but there's also the longer term costs that go beyond the program itself. When a mom does not get the care that she needs and unable to care for the child. And, earlier in the hearing before us, we talked about the healthcare workforce shortage. 60 days postpartum does not give you very much time to get your health care done. If you've tried to get a medical appointment or a series of medical appointments, to try to get everything done within 60 days is not an easy thing to do either. I think during the discussion of this committee with the dental bill, I think, looking at what would happen in the commercial market, most people wouldn't lose their coverage within 60 days. I'm not saying that no one would, but I think that's generally what we're trying to do here, I think, is bring a level of equity in terms of access and in terms of what other people are able to get. And, I think when we look at your first hearing dealing with DCYF type issues, that when things aren't taken care of up front, there's a short term, it's not pay me now or pay me later. And usually the pay me later is much more expensive. I did want to bring up to the committee, if I could, if it's all right, for me to expand upon some comments here, that during the public health emergency, we've had the continuous enrollment provision in effect because of the public health emergency, where states got an additional 6.2% to cover individuals. During a 12-month period, February going back 12 months, in terms of individuals that had more than one birth in that period, was just 52 births out of the entire Medicaid births in the state. The second thing I would say is that if there's a disruption of coverage and someone were to have a second pregnancy within a year, if they still met the income requirements, they would come back on to Medicaid. I think that on the fiscal side of this, that the benefits that an individual would be entitled to are the same benefits that they have during the 60-day period, no more, no less. That what's being made available by the federal government is that individuals who are on standard Medicaid, the federal match would be 50%, because it's a requirement under all states that offer this coverage to have at least 60 days of coverage. And so the 50% would apply for the group that we were talking about first. Someone who is on granted advantage on Medicaid expansion, there'd be a higher match. And I think that the additional cost of doing this program is pretty nominal in the sense of what we look at, what the costs are caring for children who get off on the wrong place, and for mothers that end up not getting their needs met in that 60-day period.
Questions to the panel of experts? Representative Leon.
Thank you, Mr. Chairman, and thank you for being here. Thank you for getting that information on those that are the 12-month to 12-month births. Do you have any information on the 20-month or 21 months so that you'd capture not just that birth within that 12 months, but another pregnancy?
I don't with me. I could run that type of information.
Thank you.
Representative Shapiro.
Thank you, Mr. Chairman, and thank you for taking my question. Both the former question, the previous question, and your previous comments, Mr. Littman, talked about the concern about somehow this program incentivizing women to get pregnant sooner rather than later to keep their insurance. But I'm wondering if, in fact, women are able to keep their insurance for 12 months, is there a greater possibility that they will get the kind of birth control that they need to plan their families and not get pregnant so quickly?
I think that's one of the things you'll probably hear from some of the people who speak behind me, but I think that you could infer that that's more likely that they would have the benefit and not have the expense that they might not be able to afford.
Thank you. Wow. And I've never been kept waiting in your committee, by the way. Senator Perkins Quokka. Come on up. I'll make the move. Senator? Okay, but the card isn't. The chair recognizes Representative Megan Murray. Welcome back.
Thank you. Thank you for having me. Honorable colleagues of the House, Health and Human Services and Elderly Affairs. I have previously, for the record, my name is Megan Murray. I represent the town of Amherst, Hillsborough District 22, and for the record, I have submitted testimony to you electronically.
Would you be comfortable in removing your mask?
Sure.
Because it would help my ears.
That's
Thank you.
Yep. In any case, I have submitted it electronically, and in the interest of time, I will present a portion of this that I think is pertinent to have a conversation around. I am here today simply seeking a path for care during pregnancy and for a full year after, so that women, their children, and their families have the best chance possible at addressing issues around a mother's health. In the long term, women and their families benefit from healthier outcomes, and providers and insurers see less expensive, less complex, and expensive care because a woman's overall general health is better maintained. I'd like to share a personal anecdote. In my 30s, with my third pregnancy, I developed postpartum anxiety. What was amazing to me about that then was that I didn't know what it was. And in fact, I was only and primarily asked about the baby blues, which are postpartum depression. It took me nearly 3 months, that's 90 days, to figure out what was going on. And in that moment, it was a result of a traumatic delivery with my daughter that was a result of an epidural that resulted in a spinal fluid leak. It required 2 repair procedures to stop the leak. I was fortunate enough to have insurance that covered 80% of my care, but still, as a new mom again, it was cumbersome and frankly unsettling, as my other 2 birth experiences were unremarkable and uncomplicated. If women have similar situations as this and receive Medicaid, as it stands right now, they may only have 60 days of coverage. I was treated for nearly a year with medication, physical therapy related to the epidural injury itself, as well as therapy around the anxiety that had formed as a result. Simply put, postpartum health isn't something that stops after 60 days. I am hopeful that this committee finds this version more appealing and will support SB 407 so that women, families, and their babies can experience healthier, uninterrupted healthcare treatment and better outcomes for themselves and their families. So with that, I thank you.
Thank you for your testimony, Representative. Now we have a number of people coming up, and we're going to kick in the 3-minute rule. And the chair recognizes Nancy Vaughn from the American Heart Association. Please hand out your testimonies, and we would ask that you not read it to us, because we can read it to us, but that you would summarize what you've got to say. Thank you. And the clock starts.
Good almost afternoon. For the record, I am Nancy Vaughn with the American Heart Association here in New Hampshire.
I am here to provide some testimony and comments on in support of the Senate Bill 407. I have passed out my testimony with an attachment of a document from the American Heart Association. I'll try not to reiterate what has been said before. I stepped up. But basically, heart disease is the #1 killer of postpartum moms. And about 2 out of 3 deaths are actually preventable. So there's a lot that can be done with increased access to health care beyond that 60 days, as others have said before. The threat begins during pregnancy and can continue later into life. The American Heart Association is working to decrease this maternal mortality rate and also improve the cardiovascular health of women before pregnancy, during pregnancy, after, and into their adulthood. As a matter of fact, this was just this past September, the American Heart Association issued a policy statement with a call to action for maternal health and saving mothers. And one very important step of this call to action is advocating for Medicaid extension to 12 months postpartum. The full-year coverage would prevent the time necessary to address common lingering health effects, which include high blood pressure, diabetes, blood clots, or cardiomyopathy, and may not surface for weeks or months post-delivery. Beyond, wanting to prevent maternal deaths, this extension into later life of cardiovascular disease and risk again, starts from not having preventive care during the postpartum period for these health risks that pop up as a result of their pregnancy. So again, this is extremely important to be able to continue healthcare access for women beyond that 60 days. And just in conclusion, health problems during pregnancy and the postpartum period also impose a significant burden on families. I see this bill as being very pro-family. It's also good for communities and the healthcare system. Women who develop cardiovascular health issues during the postpartum period and do not have access to health insurance are still going to be seeking care for their health issues, which usually are progressively more severe than if they had been treated originally during that postpartum period. I've also been in contact with some OBGYNs in the state just to also get some more information about what kind of treatment is given to women postpartum. Again, preventing a second pregnancy really soon is part of that. And they also sent letters of testimony to you.
Will you accept questions?
Yes, I will.
Any questions? Thank you for your testimony.
Thank
The
you
chair
very much.
recognizes Holly Stevens from NAMI. You've got handouts to hand out. And the same 3-minute rule. And the 3 minutes do not start until you're seated, which is not a request that you give your testimony standing.
Although that would be funny. Hello, Chairman Pearson, members of the committee. My name is Holly Stevens. Are you having trouble hearing me? You're welcome. I wear it unless people are having trouble hearing me because my doctor has specifically told me that I should not get COVID. So my name is Holly Stevens. I am the Director of Public Policy at NAMI, New Hampshire, here today to speak. Thank you. Where was I? I'm here today speaking in support of Senate Bill 407. I will try to make this even quicker than 3 minutes because I know that you have seen a House version of this bill and now you're looking at the Senate version of this bill, hoping that that you might reconsider some of this given new information. I wanted to just highlight the mental health aspects. One of the most prevalent illnesses facing postpartum moms is depression. 11.2% of New Hampshire women with a recent live birth reported experiencing depressive symptoms, which is a pretty significant rate. And in 2020, nearly 1/4 of all births in New Hampshire were billed to Medicaid. So 11.2% of 1/4 of all births. That's the women that we're looking at with just postpartum depressive issues. And in addition to moms having mental health issues in the postpartum period, children of women who experience postpartum depression are also affected. Research has demonstrated an association between postpartum depression and delayed cognitive and language development, disorganized or insecure attachment, higher rates of behavioral problems, and lower grades. So not only does this affect the moms, but it affects their children as well. So being able to have that full year of coverage will allow physicians to screen moms for postpartum depression and other mental illnesses associated with the postpartum period, and get the treatment that is needed so that both mom and baby can be healthy. And with that, I will take any questions.
Anyone with a loud voice have a question? Hearing and seeing none, thank you.
Thank you very much.
Hope to have some help here soon. Katie Merrow from the Hampshire Foundation. Thank you.
I was looking for an unplugged something because it's working through the speakers, but not through the rest of the system.
I'm going to keep standing until we're done with, if I may. Hi, it's working.
You're on. Yeah, we're back on.
Yeah. Good morning, Mr. Chairman and honorable members of the committee.
It's good
Thank-
afternoon, but I apologize. Go ahead.
Good afternoon, right. My name is Katie Merrow from the New Hampshire Charitable Foundation, New Hampshire's community foundation here in the state. And I want to start with, so driving to work this morning, I had to stop for the school bus, and there was a little blonde girl about this tall who's crossing the street, and every car was stopped, both directions. Nobody's driving around. And I was thinking about that law that this legislature passed around stopping for a school bus and the importance of that in protecting the future of our state. SB 407 is that kind of law. And for the New Hampshire Charitable Foundation, we have long invested in children and families and prioritized that. And in particular, prioritizing new moms and babies in our investments around both early childhood development, substance use, and mental health care. While philanthropy is able to help in this area around the edges, we are not able to carry that or do sustaining investments. Really, only the state can do that. And this bill, in our understanding, has three main points that are the basics that are critical. One, it's a defined small population of the most vulnerable, some of the most vulnerable citizens in our state, meaning moms who've just had babies and their children, and moms who've just had babies who don't have access to health insurance. Secondly, we know that providing health care in that first year after a mom's had a baby has proven long-term impacts, including preventing death, as we just heard about from the Heart Association, and also facilitating a return to work. And we know the importance of the workforce issues. And lastly, this is given all that, this is a very modest investment that will be required from the state with a very high financial return and potential for cost savings. So for those reasons, we're in strong support of this bill. And I would just close in saying, I think you have an incredible opportunity to pass a bill that will protect the future of our state and support our families in a critical way. And we urge you to support it. And thank
Would
you
you
very
take
much.
questions?
Absolutely.
Are there questions? Seeing none, thank you so much. And the chair recognizes Devin Quinn from the New Hampshire Women's Foundation with copies for all.
Good afternoon.
Good afternoon.
Chair and members of the committee, my name is Devin Quinn. I'm here from the New Hampshire Women's Foundation, and we enthusiastically support SB 407. I want to make sure I'm talking about things that you haven't heard yet, and keeping it short. On the first page of my testimony, I just wanted to point out that 24% of pregnancy-related deaths are between 43 to 365 days postpartum. So a full quarter of maternal mortality is in the window we're talking about. I also want to point out that of women who were dealing with substance use before getting pregnant, the most likely time for relapse overdoses was 7 to 12 months postpartum. So that would be in the place we're considering. I'm a visual learner, so I gave you a little map to explain what the section of we're talking about. Red is Medicaid Advantage, blue is the existing pregnancy eligibility, and green is what we're talking about, that expansion.
Excuse me for a second. Are the handouts lost somewhere because they didn't get up front? Oh, they're still coming.
Coming both ways.
We got this far and we're out.
We're not counting this towards your time, by the way. This is just our little thing here.
Should have 25.
There was a stack.
It was over on the other side.
That's the last page, yes.
Have two more. The Republicans weren't here.
I only need one. Okay, we've got another one a begging here. Okay, good, thank you. Okay. Resume.
Sure, sorry about that. On the next page, I just wanted to give, when we're talking about 138 and 196, what numbers are that exactly, and who does that represent? And the next page gives you a couple of real numbers to actually think about this in terms of family size and where they would fall on that. And a couple of occupations just to give you a sense of between a median and entry-level salary if they're at the beginning of their career. You know, for example, food prep service workers may shift with tips or hours or things like that. The last page is the same map that Director Lippman gave you. Great minds think alike, to give myself credit. And I know previously there was a concern with the continuous eligibility issue, and I know that that's something that we can't opt out of in this. I do want to, and also that we don't know how many folks would actually go above 130 or 196, and how many people that would have been applicable to. But did want to mention that there is still a monthly reporting requirement. They wouldn't be removed from the program if they did go above eligibility, but that monthly requirement would give us the data that you're seeking at the end of this program in 5 years. And that's, you know, the match to this program in a short window. That's something that we could reassess later, but you'd have that data because it is being collected, and wanted to mention that. But in the whole, we support this bill because it helps a lot of folks, and hoping you have some more new information to help with this decision.
Would you take a question? If there is one. Any questions, the chair recognizes Representative Folsom.
Thank you. And thank you for taking my question. On your first sheet here, it says that 24% of the pregnancy-related deaths were 43 to 365 days postpartum. So 76% of those pregnancy-related deaths happen within the first 60 days.
No, well, it includes during pregnancy, at birth, and 60 days after. There's a couple of different ways they break it down. I'm happy to give you that more information, but 24% of maternal deaths are more than 43 days after birth.
Okay.
Thank you, Mr. Chairman, and thank you for taking the questions. You spoke about it sunsetting after 5 years, but I don't see anything in here. Is that because it ties into the larger program and would be reauthorized with that?
Director Lippman would have to answer that question for you.
Thank you.
Seeing nothing further, thank you so much. And you beat the clock. I owe you 6 seconds when I see you next.
I can give it to someone else.
Chair recognizes Heather Martin from Salem, representing herself.
Hello, everybody. Thank you for your time and listening to me speak. My name is Heather Martin. I'm here to speak to you today about maternal mental health, not just our mom's physical health postpartum, but their mental health, which is just as important as physical health. I am a passionate maternal mental health advocate for our moms and our families here in New Hampshire. I work with mothers and families in Dartmouth, Hitchcock, and Manchester in the pediatrics department. I'm also a postpartum support coordinator here in the state, so I hear from moms every day seeking mental health help. I became passionate about maternal mental health after losing my only sister to suicide 13 years ago. She suffered from what we think was postpartum psychosis, a maternal mental health disorder that affects mothers, sometimes without detection. She had no history of mental health issues, and her baby, her first, was only 3 weeks old. Had she received the mental health help and support that she needed, I believe she would still be here with us today. In January of 2020, pre-pandemic, concerned about some of our mothers that I was seeing in the pediatric clinic, I approached Dartmouth Hitchcock, my team at Dartmouth Hitchcock, Manchester, about integrating routine postpartum screenings at the baby's visits, which is already recommended by the AAP. We launched successfully a workflow to help our moms find help and support for their maternal mental health struggles. Postpartum screenings are essential for our mothers up to 12 months postpartum. We are getting consistent positive screenings up to 12 months postpartum. We need to help our struggling moms here in New Hampshire. The COVID pandemic has even worsened this for our mothers. They are more isolated than ever and are without the hands-on support of family and friends. The pressure, the hormone changes make for a perfect recipe for anxiety and depression. Postpartum anxiety, depression, and suicide risk are always a concern for our mothers, but the pandemic has worsened this for them. 1 in 5 mothers suffer from a maternal mental health disorder. That is a fact, like postpartum depression. And less than 15% of them will receive mental health treatment. Postpartum screenings are the most important tool that we have here for our families in New Hampshire. Many of these mothers that I see struggling have Medicaid. This workflow has been a crucial part of the care of our mothers and our babies. It's not just about the moms, it's about the babies and the families. Without it, mothers can be at risk for suicide or untreated maternal mental health disorders. Sorry, I'm out of time. I really need you guys to support this bill. I talk to moms every day and they're struggling. It lasts for up to a year, sometimes more than that. Thank you.
And thank you so much. Again, I'd call Senator Perkins Quokka, filled out a card, probably had to go to another meeting, so. Okay. And last, the chair recognizes Bob Dunn from the representative of the Roman Catholic Diocese of Manchester.
Thank you, Mr. Chair, members of Sorry. Good morning, Mr. Chair, members of the committee. I'm Bob Dunn, the Director of Public Policy for the Roman Catholic Diocese of Manchester, and I'm here today on behalf of Bishop Peter Labashi in support of SB 407. I would note that the policy of extending Medicaid postpartum benefits out to 12 months is supported by Catholic bishops around the country as a pro-life measure. When we look at legislation, we focus on the two fundamental principles of Catholic social thought, which are human dignity and the common good. And those obviously are the cornerstones of the body politic that is established by the New Hampshire Constitution and the federal Constitution. And we think that SB 407 unquestionably advances those principles of human dignity and the common good. I won't go through all the data because you've heard that already, but I think it makes a compelling case that this bill will make a significant difference in the lives of individual people. And I would urge the House to seize this opportunity. The federal money that is available, as you know, is only available for a finite period. And I'd also ask you to consider that each mother who is impacted by this bill also represents at least one baby who is impacted indirectly by this bill. And that gives that child the prospects of a better life than would be the case otherwise. And I think from the 2019 data, I think there were about 762 people that went off Medicaid and would be covered under this law. So that's 762 individual lives that would be improved or even saved by virtue of what this legislation does. And I also would ask you to consider that we don't want women to be deterred from having children because of the prospects of not having sufficient health care on the other side of birth. Family is the keystone, and we should prioritize our care for mothers and babies. Lastly, I do want to address what was in the blurb on House Bill 1563. And this committee, the majority of this committee had been concerned about the potential long-term impacts of this legislation. And I would just suggest perhaps considering a prospective repeal provision that would be in this bill, and then you could be sure that there would not be a commitment beyond the existence of the federal funds. Thank you very much.
Would you take questions?
Certainly.
Any questions for Mr. Dunn? Representative Shapiro.
Thank you, Mr. Chairman. This is actually not a question for Mr. Dunn, but there was a question that came up before about the idea of this sunsetting after 5 years, and I don't think we ever got an answer from anybody, although I think Mr. Littman was pointed out as the person who could answer that. Does this bill sunset after 5 years?
For the record, Henry Littman, Medicaid Director. For the record, the American Rescue Plan Act included 5 years under the state plan option. So that is an accurate
follow-up.
Follow-up. So does that mean that the funding will sunset after 5 years, or the actual bill, the actual program will sunset after 5 years?
The additional federal match that covers months 3 through 12, that would be what would sunset federally unless there's additional federal legislation. I think the American Rescue Plan provided some funding for a period of time.
But if this bill were to pass and the federal funds were to sunset, this bill does not sunset New Hampshire funds, does it?
It does not, which, I think I heard that, the committee here considered potentially putting something in place that would require it to be reviewed or sunset. or reauthorized, I think that that's a concern. I think that is a smart thing to do.
Representative Weber.
Thank you, and thank you for taking my question. But we are understanding that the federal plan runs for 5 years,
Yes.
so we have time to make arrangements for what happens when that sunsets during the course of the 5 years. And we also have a further option. Is this a second committee bill, Mr.
Yes,
Chair?
it is.
The Finance Committee would also be allowed to turn their eagle eyes to the fiscal effects of this bill and put in an entirely appropriate adjustment based on fiscal considerations. Is that not true?
Yes.
If we approve the policy.
Yes.
Thank you.
Questions for either Mr. Dunn or Mr. Lippman, since they're both there sharing the microphone so nicely. Representative Folsom.
Thank you. A lot has been said about the American Rescue Plan paying for this for 5 years. However, when you read the language, it basically says that the governor shall determine if any discretionary funds appropriated in the American Rescue Plan Act or any other federal funds can be used for this purpose. And then the commissioner will expend those federal funds. Any remainder shall be appropriated from the general fund. So if the governor decides he wants to spend the American Rescue Plan money somewhere else, it could be that the whole fund then has to come out of the state fund.
So in order for us to, assuming it was passed, we would have to file a state plan amendment, which would sort of memorialize how we're going to fund and finance it for that 5-year period.
Mm-hmm. Well,
and so I guess to follow up to that, the amount of federal funding would equal no less than 50% and likely some number north of that based on the fact that CMS is allowing that individuals who have their baby during the time that they may be in Medicaid expansion where the federal match is 90%, that they wouldn't there'd be a change in the federal match during that additional period of time, so that there'd be some match that would be greater than 50% for this program.
Follow up?
Thank you. So basically, it's not really totally covered by the federal funds. There is going to be a state expenditure of some kind.
Yes, if that wasn't clear, that is
okay.
What the American Rescue Plan Act did was to provide where today the law of the land is that they only provide that match for 60 days. The American Rescue Plan Act allows states to now get that match up to a year.
Oh, the match just comes for a year.
No, up for the year. When I'm talking about the eligibility for the woman. Yep.
Thank you. Thank you.
Representative Knirk.
Yes, just to clarify, if we look at the bill, page 2, lines, say we start about 7 or 8, it's or 9, that the governor will determine if any discretionary funds appropriated or can be used for this purpose. Well, first of all, they already have been directed. It is a federal program and it's being done in other states. And then it says, and the commissioner shall expend such federal funds for this purpose. So it looks like it does not give discretion to the governor to ignore these funds and use them for something else, because if he determines that the funds are available, which they are, he shall expend them for this purpose. He can't divert them. Is that not correct?
I think that's a correct reading of it. And I think, there's a long history of the state plan amendments being honored in that fashion in this state and elsewhere.
Thank you.
Representative Weber.
Thank you. And I had a slightly different take on that, but I defer to your expertise. But first of all, is this not an issue that is far more in the purview of the Finance Committee rather than us, because we're the people who do the policy? And secondly, that was a rhetorical question.
Would you believe?
My real question is, no, I was a question. I just don't need an answer. The section that Representative Knirk just quoted half of the funds are coming from the federal government.
Yes.
That's in the plan. I read this appropriation as being an appropriation if there were other funds available to be used for the state portion. This allows them to be used for the state portion, thus reducing the amount that the state would have to come up with from general funds, and the rest of the state portion comes from general funds.
I would
Is that
agree.
correct?
I would agree with that, and also for those people who are covered under Medicaid Expansion Granted Advantage, that the funds don't come from general funds; they come from the Granted Advantage Healthcare Trust, which is a combination of things. And I think that's probably why that artful writing is there.
Representative Leon.
Thank you, Mr. Chairman, and thank you for taking the questions. My question is, right now, are we allowed to remove anybody from Medicaid and Medicare and Medicaid? And is there any visibility as to when that's going to be lifted, or is that tied to everything else that's tied to the state of emergency?
So what you're referring to is the public health emergency. I think that what the federal government has advised state governors repeatedly is that they'll give 60 days notice. This week, I expect we'll see a renewal of that. Our current planning is that this will be the final public health emergency renewal that would have continuous enrollment. That may not be the case, depending on what the maturity of COVID is and other things. The main reason that I think that the public health emergency is continuing is not necessarily for the continuous enrollment piece, but for the emergency use authorization of certain pharmaceuticals and biologics. We don't have anything definitive on this, so what I'm saying here is somewhat speculative, but in my professional association of Medicaid directors, there's some discussion that a future public health emergency renewal, not necessarily the one that's likely to happen this week, but future ones where they may decouple the continuous enrollment from the public health emergency and design a different public health emergency to take care of the emergency use authorizations and those related items. Again, I want to just emphasize that's not a fact. That's what I'm hearing secondhand, if you will, in a professional association.
Well, thank you both. And Bob, I would just say to you a little play on a poem by a 1600s English poet named John Donne. You are done.
Done right.
I hope only metaphorically, Mr. Chairman.
I believe the learned Dean of St. Paul's Cathedral and poet meant it as such. And there we are. So this ends the hearing, and for planning purposes, I would like, after exec session, to start 403, see how far we get. When we all need lunch, we'll take about a 35 to 40-minute lunch break and then pick up the schedule wherever we are. So I'd like to open the exec session on Senate Bill 407, what we just heard. And Chair will entertain a motion. Yes.
I would like to move ought to pass.
Okay, there is no amendment. The motion is OTP made by Knurk. Any second? Representative Acton. And we can now discuss. Representative Leon.
Thank you, Mr. Chairman. I still remain concerned about all of the downstream consequences of this. I'm also seeing that we're moving closer and closer to the budget process, and that a lot of these arguments for women in that first year after birth apply to the general population as well. I think we're going to be having larger conversations, and I think that I don't expect that the federal government will be decoupling that. I understand they have the opportunity to, but that would just be a huge black eye on the administration if they were to take away this continuing enrollment while they were still continuing the EUAs for diagnostics and therapeutics. I think we have more time to act. I think we have more time to look and see what we actually believe is our full package. And for that reason, I'm going to be opposing this.
Representative Shapiro.
Thank you, Mr. Chairman. Truth be told, I am totally for this, passing this bill, but I was very moved by Mr. Dunn's comment that this, as far as the Catholic Church goes, that this is a pro-life measure. And I think that we want to be consistent in doing everything we can to encourage young families, to encourage people having children who will be healthy, having families that will be healthy. And I think this measure is directly aimed at doing that. So I think that I will vote yes, and I hope everyone else will vote yes.
Representative Woods.
Thank you, Mr. Chair. Certainly, this is not a perfect bill, but I would request anybody to show me a bill that this legislature ever passed that was perfect. And we have to start someplace. Certainly, the ROI, return on investment for this age group in this situation is immense. I think this is a very good start, something that's long overdue. And perhaps is an argument for universal health care in general. Thank you.
Representative Knark.
Yes, I share Representative Leon's concerns about downstream issues, but my concern is if we don't pass this, we already know the downstream issues of not providing coverage because of the increased mortality of the developed countries. We have the worst maternal mortality of all of the developed countries currently, and it's increasing. We also are the only developed country that doesn't provide universal access, as Representative Woods just said. Yes, indeed, other people can have these problems. That's a good argument for universal health care, but I don't think we're discussing that now. And the postpartum period is a time of unique risk. Pregnancy and childbirth is an enormous physiologic change, as all of you who have had one know. And the risks are significantly higher during that period of time. So yes, the return on investment will be very high, and we should do it. The funds are available now. We should do it now. Thank you.
Representative Folsom.
Thank you. One of my main concerns is the whole funding issue of the American Rescue Plan money and what the state will have to put out. And I would appreciate if something can be worded where it does sunset in 5 years when the money stops coming from the federal government, so that we can examine the program and get some actual data gathered in those years, so that we know if it's really something that needs to be funded going farther.
Representative Shapiro.
I would fully support Representative Folsom's idea of having this be reevaluated or renewed or sunset in 5 years. But I think because of the timing in terms of today's schedule, and in terms of like having to actually vote on some bills, that could happen in the Finance Committee. And I personally would support that.
Representative Knark.
Yes, and particularly that's important because it has to do with the financial aspect, and therefore much more sensible for them to do it there. Thank you.
Anyone else? Representative Soloway.
I'm with Councilor Dunn. If we're going to support birth, we need to support life.
3 things from me. Number 1, thank you, Representative Edwards, for Finance 3 taking a look at possible sunset on this. Secondly, we do not have little ones in our medical practice, but we do have teenagers. And I've heard my providers say more than once, you know, some of the stuff we're having to deal with, probably we wouldn't have had to if this had been taken care of when they were 6 months old, but now it's expensive. And number 3, I will just say that I fear that some of my fellow pro-life, and I would even say leaders, are pro-fetus, but not pro-life. So I will be voting for this. And the motion before us, is there a motion? There is a motion before us on, is there a motion before this? Yes, there is. Thank you. I'm one bill ahead. Representative Knurk and seconded by Representative Acton. The motion is out of pass. The bill is 407 FN. And would a clerk please call the roll?
He would. Representative Leon.
No.
Representative McMahon.
Yes.
Representative Acton.
Yes.
Representative Gay. Representative Mooney.
Yes.
Representative Folsom.
Yes.
Representative Bohm.
No.
Representative King, yes. Representative Kolthoff.
No.
Representative DeLamus. Representative Weber. Representative McKay. Representative Snow.
Yes.
Representative Knurk.
Yes.
Representative Solway. Representative Cannon.
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro.
Yes.
Representative Woods.
Yes.
Representative Query.
Yes.
And Representative Pearson.
Yes.
And 4 against, that would mean 17 yeses. 17 to 4.
17 to 4. The bill passes 17 to 4. Representative Knurk, a blurb. And in opposition? I'm sorry?
I'll ask around when we do lunch so that I'm not wrong.
Okay, we'll ask around amongst the 4 who voted no. All right. No, not enough for consent. Nice try. Now open the hearing on Senate Bill 403, and thank you, Representative Whitley, for being in your place.
Thank you, Mr. Chair, and hello again, members of the committee. For the record, my name is Becky Whitley, and I'm honored to serve New Hampshire Senate District 15, including the communities of Concord, Henniker, Hopkinton, and Warner. I'm going to take the committee in a different direction, but I would say it's very related. This bill also supports moms and babies. So today I'm honored to introduce Senate Bill 403. And what this bill does is reestablishes the farmers market program in the WIC program. For a quick refresher, the WIC program provides supplemental foods, healthcare referrals, and nutrition education, including, importantly, in my opinion, breastfeeding support at no cost to low-income pregnant and postpartum women, and also, very importantly, to young children, to infants and young children who are found to be at nutritional risk. So at its essence, this program provides food for women and babies. So as a mother, I can't even imagine being in a situation where I did not have enough food for myself or enough food for my son. At particularly a very vulnerable time in a mother's life, when their baby is a newborn and when you're doing your best to try to provide for that baby on a daily basis. So this is a bipartisan bill. You'll see both bicamerally and both in the House and the Senate, there was bipartisan support and sponsorship. It passed the Senate Health and Human Services Committee with a 5-0 vote and the full Senate, and it was on the consent calendar. That's because I think this is really good policy. It's good policy for moms, it's good for babies, and I would also say it's really good for our local economies. And I think it's really a very wonderful opportunity to pass such good policy that has so many diverse benefits to Granite Staters. So the WIC Farmers Market program that's established in this bill will supply locally grown fresh produce to WIC participants through the distribution of vouchers redeemable at New Hampshire's farmers markets. So in addition to improved nutrition, the added benefit of this program is an increased demand for New Hampshire grown fresh produce at our local farmers markets. In the communities that I represent, our farmers markets are the centers of our communities. They're also central to our local economies and weekly gathering places to meet your friends and neighbors. I, like many of you, have many incredible family-owned farms in my district that add so much to our local communities and our local economies. Establishing the WIC Farmers Market program builds on the widespread support for the SNAP Farmers Market program that was included in last year's budget, a policy we all agreed is good for New Hampshire because it's a triple win for Granite Staters. It boosts the local economy, provides health benefits to WIC recipients, and provides new opportunities for local farmers. So just a technical note on this program, like the SNAP program, food benefits in WIC are 100% matched by federal dollars. 100%. So that means a modest state investment in this bill will allow the state to draw down those federal dollars, not only, again, to broaden access to very nutritious food for the WIC participants, but also to add to our economy. This is more free federal dollars that will flow into the state. I will note that the state match piece is required for the administrative side of the program, of which we will also receive federal funds. So again, federal funds support 100% of the food costs and 70% of the administrative cost of the farmers market program. So I would ask, why wouldn't we want to take advantage of a program that provides so much into our local communities? This bill supports the fact that everyone should have access to our delicious New Hampshire grown fruits and vegetables. It will also reduce the disparity in who can access those delicious foods and also support our remarkable local farms and vendors. Thank you so much for your consideration. I'm happy to take any questions, any technical questions about the WIC program or the actual administration of farmers market. I will defer to Lisa Soroy, who is here from the department, and she manages the program.
Any questions for the senator? Representative Folsom.
Thank you, and thank you for taking this question. I think farmers markets are the best thing going in our state, and I was really glad to see that we put this into SB 2 last year. They put it in under SNAP. Implement SNAP incentive programs enabling beneficiaries of the federal supplement nutrition program to receive dollar-for-dollar match for fresh fruits and vegetables, with an emphasis on locally grown at participating farmers markets, farm stands, mobile markets, community-supported agricultural sites, grocery stores, or other participating drug food retailers. So it sounds like we've got it.
Thank you for the question, Representative Folsom. That was for the SNAP program, and the bill before you is for the WIC program. It's a different program.
Representative Gay.
Could you explain the difference? Where I live in Salem, the farmers market does respect the coupons, and I'm not sure what the title of the coupons that they get. I'll just call it a coupon, but I thought it was food stamps. What's the difference?
Yeah, thank you for the program. Thank you for the question. The SNAP program is colloquially known as food stamps. And so there is already an active farmers market. It was privately funded previously. As Representative Folsom said, last year we initiated some state investment to draw down additional federal dollars. The bill before you is for the WIC program. There's different eligibility, and the WIC program and there's different eligibility criteria for the WIC program. And so this just aligns the farmers market program that we already have in SNAP with the WIC program for those WIC participants. Did I answer your question?
Can you draw both?
That I don't know. I would defer that question to Lisa Soroy.
Representative Leon.
Thank you, Mr. Chairman, and thank you, Senator. I didn't realize that we had the SNAP already going to the farmers markets. And I'm really, really concerned about inflation and people being able to purchase things, especially food, especially with the fact that fertilizer's gone up 4 times. We're not going to be able to plant as much. I don't know if we know how many people are taking advantage of, how many people are eligible for this and getting delicious fruits and vegetables that they don't have to plant and grow themselves in order to eat them. I know I'm already sort of priced out of the farmers markets for what I'm willing to pay for produce. And I'm just curious how much more this is going to shift the balance to just taking those federal dollars that are driving the inflation and use that to choose who's able to buy at the farmers markets. It's a hard topic.
Yeah, I'm not sure I understand the question fully, but I mean, right now because we don't have access for everyone to buy fresh fruits and vegetables, you're exactly right. We are creating a disparity. There are only certain people that can afford, and I think, balancing with what we did with SNAP last year, what we're going to do with WIC this year, we're balancing out that disparity.
We crossed ships, but that's all right. Thank you.
Yeah, I'm happy to, if you wanted to ask it a different way. I'm not quite sure I understood your question.
I think it's more of a up in the clouds
Philosophical.
economics question, so I'll just drop it. Thank you.
Any further questions for the senator? Seeing none, the chair recognizes Brendan Cornwell from the New Hampshire Food Bank. A great name for a food provider. Mr. Cornwell.
Excellent. Thank you. This is awesome. Very excited to be here. I just finished the Ben Franklin documentary. Thank you for your service.
Just to let you know, we're now in the 3-minute zone, starting now.
My name is Brendan Cornwell. I work for the New Hampshire Food Bank. I coordinate the Grant State Market Match program, which is very similar to the program that's being proposed. I have some note cards. I'm going to take them out now. I'm not going to read, just notes. All right. So I've been working with New Hampshire farmers for 10 years on this program. In 2021, do you know how much of the millions and millions of dollars in federal food aid that came into New Hampshire went to New Hampshire farmers? 0.2%. 0.2% of all the federal food aid that came into this state is going to food that is being grown in Mexico, California, and China. I don't think it's appropriate for New Hampshire citizens' tax money to subsidize farms in another country. I think that if we're going to be taking tax dollars to use to feed our citizens, we can do the very least and buy that food from New Hampshire farms. Like, I don't think it's fair that we're going to take all this money and just be like, yeah, go ahead, buy food from China. That's not going to help anything. That's not going to help our state. That's not going to help our economy. That's not going to help anything. It's going to help China. And that's not really what we want to do. Like, we have to provide for New Hampshire citizens, and the farmers of New Hampshire are the backbone of this state, and they need to be provided for. They do not have access to these federal dollars unless we create programs for them to do it. It's just not going to happen. These federal tax dollars aren't just going to magically appear in farmers' pockets. We have to do something. So, yeah. Yeah. I don't like that. Fruits and vegetables from other countries. Yeah, I'm not up for subsidizing foreign countries, and I would really appreciate that any funds that you can divert from foreign countries to New Hampshire farmers would be a benefit to the state.
Thank you. Would you take any questions from the group, the committee?
Yes.
Okay.
Yes,
You don't have to answer them, but you can take them. Representative
them.
Kofalt.
Yes, thank you for taking my question. So, would vendors at farmers markets be required to accept WIC? And if so, would they require any special equipment to do that under this program?
Good question. Under this program, we will be working with farmers markets to get as many farmers and as many vendors up as possible. There are certain vendors that do sell stuff that will not be, is not allowed to be sold under WIC. So there will be an extensive training for what can and cannot be sold. And, we're not going to force anybody to take money, but the people that want to take money should be able to take the money.
I believe somebody coming up to testify subsequently will be able to supplement what you've just said. Representative Leon.
Thank you, Mr. Chairman, and thank you for taking the question. Was your 0.2% number that purchased directly from farmers through farmers markets here in New Hampshire, or was that taking into account the produce in the grocery stores that also has some local?
I said direct to farmers.
Thank you.
Thank you for your testimony. The chair recognizes Deli Champagne from Save the Children Action Network. You have written testimony that you can hand out. Oh, just keep it coming. And thank you so much. You get 3 minutes.
First of all, thank you, everybody. This has been a fun day. I
Isn't it
love
fun?
watching your
Oh, yeah.
interactions back and
This
forth.
is the best committee in the House.
It
We
really
won't
is.
deduct that from your
Okay,
time.
Yeah. Well, I enjoy the way you conduct business, and I appreciate the way you conduct business. So my name is Deli Champagne, and I work for Save the Children Action Network, and we love this bill. We love any bill that supports good nutrition. That's one of our top priorities in this country. We're actually an international organization, and we have 3 primary goals, and one of them is proper nutrition. But I just wanted to tell you a quick story. So I was born to a teenage mother. My mother had a baby at 15, one at 16 who died, and then one at 17. I had a good dad. He was a mechanic. They got married. But we didn't have fruits and vegetables at my house growing up. I thought fruits and vegetables came from a can. So we would have can of corn or can of peas. We did have baked potato. That was a biggie. And my sister and I would get so excited if we got cream of corn. That was a real treat. So I never developed an affinity for fruits and vegetables. And to this day, I'm 58 years old, and there are about 5 fruits or vegetables that I eat. It is so embarrassing.
But they're doing you well. Look at you.
I don't think so.
I do.
When I go to restaurants or when I go to people's houses, I am picking out the onions and the peppers, and I just don't like any of that stuff. I never developed a taste for it as a child. So when I had a baby, I was nursing and my baby was constipated. So I took the baby to the doctor and I said, "What's going on? My baby's not pooping." And he said, "Well, what are you eating?" And I told him, and he said, "Well, where are your vegetables?" And I said, "Well, I don't eat vegetables. I wasn't raised on vegetables. I can't even identify certain vegetables at a store. And I have a master's degree. So my baby had to have more vegetables. So I forced myself into eating broccoli and cauliflower and have since grown to like them. Within the last 5 years, I love avocado. It's so great. But I'm telling you, this was a real issue for me and for my poor family. So I just want you to be aware that these habits start really young, and I didn't have an opportunity to develop those habits. So I love this program. I love that we can help families. And do I have 30 more seconds?
Yeah.
Okay. I talked to a woman from UNH Cooperative Extension the other day. She does nutrition around the state to Head Start students. And she asked me, would Save the Children be able to give us some money because I'd like to buy some fresh fruits and vegetables when I do my courses with these young children? And I said, well, sure. What do you need? And she said, well, they've never really seen a banana, so I'd love to show them how to peel a banana. And they don't know how an orange, gets cut up into slivers and pieces. And so I'd love to show them how to do that. I was like floored. Oh my God, in this day and age, a lot of our kids have never, she said, a lot of them have never seen a piece of fresh fruit. And I have to say, I was the same way.
Unfortunately, no time for seconds. Thank you so much.
Thank
You are a
you.
great avocado for this bill. What was your master's degree in?
I have a master's degree in education. I'm a social studies teacher by love, by heart. Yeah. That's a whole nother story, though.
Yes, it is.
Any
Would
questions?
Any questions? I get to say that. Any questions?
Thank you again, you guys. You're awesome.
It's true. Chair calls Tiffany Dudler? Dodier? Oh, thank you. Yes, a French name pronounced right. Thank you. From the Hampshire Hunger Solutions, with written testimony being passed out, and she's going to do this in under 3 minutes.
Absolutely.
Yeah, right.
Thank you, Chairman, and thank you to the committee. My name is Tiffany Dodier. I, as he said, is from New Hampshire Hunger Solutions. I'm the Community Engagement Director as well as a registered dietitian. And part of my job, one of the many hats that I wear, is coordinating and co-facilitating a statewide coalition that seeks to improve access to local nutritious food. And we do that through a few different ways, policy and advocacy, of course, being one, as well as connecting to break down silos and establish coordinated efforts to improve programming and problem solving. And so I'm here to express not only our organization's support for SB 403, but as well as the support for this coalition. I did check this morning the online support sign in, and we have over 101, I believe, over 100 signed into this bill. So this is a really wide-reaching bill that has a lot of support in many sectors that we work with, including private farms as well as businesses. So I wanted to express that support, and as well as foot stomp some of the earlier testimony about the long-standing impacts of this bill in terms of even generationally the kind of habits that this establishes. So we know that early exposure to fruits and vegetables leads to greater consumption earlier, as Deli so eloquently put it. And so also, though, I wanted to really foot stomp this idea of a center and community. And if you can imagine, I mean, in my area, when I go on the seacoast of New Hampshire to farmers markets, it's this buzz, this community. There's like even sometimes live music and artisans and local maple syrup and honey and all the things that make New Hampshire great. And children get to experience this, but also watch their parents participate in and be a part of a community and be invested in that community. And that translates into adulthood, as well as if those children go on to have their own children. So we're really investing in long-term impacts, even beyond what any of us might even see in this lifetime in the future of New Hampshire. So with that, that's all I have to say. If you have any questions, I'm happy to take them.
Next time you come, I owe you 45 seconds. Thank you. Questions, Representative Gay?
Yes, ma'am. Thank you so much for being here and being so enthusiastic. And I was wondering on this sheet, it says, what will it do? It says the bill appropriates $300,000 for admin and enhancement of WIC, providing an additional $30 benefit to be used at farmers markets. So is that what the benefit does? Everybody who qualifies for WIC gets $30 to spend?
I'll defer to Lisa Soroyce to answer that, but I believe that the funding would allow $30 per WIC participant to be
For
spent.
the year?
So for a 3-month time frame that they are allowed to purchase fruits and vegetables at farmers markets. Yes.
Further questions? Thank you so much.
Thank you.
And the chair recognizes Lisa, and I'm going to get corrected. Sir Wa. May I say Sir Wa? Thank him for me.
Hello, everyone. Thank you for the opportunity. I am passing around testimony, and I'm really going to summarize it and try to clear up some of the misunderstandings. So I work for the Department of Health and Human Services in the Division of Public Health. I oversee our nutrition services section in public health, which oversees our statewide WIC nutrition program, commodity supplemental foods, which is a senior federally funded nutrition program, breastfeeding programs, and our senior farmers market nutrition program, all of which are funded through USDA.
Okay.
And so just to clarify from the beginning, so the WIC program is funded by USDA, although very different from SNAP or food stamps. Our income guidelines are different. We have categorical requirements, so it is only for pregnant women, breastfeeding women, 6 months postpartum, and children up to the age they turn 5. So it's a very short time where we have concentrated effort of healthy foods, nutrition education, breastfeeding to try to result in healthy outcomes to have school-ready children. So for the WIC program, our income guidelines are 185% federal poverty, which is higher than SNAP. So it is likely that there are families that are not eligible for SNAP that are eligible for WIC because they're in a little bit of a higher income, but still a lower income in comparison. And so the WIC program is very prescriptive in the foods that we offer. If you're not familiar, we have rules around which cereals, so there's limits to the sugar of the cereal, low-fat milk, fruits and vegetables, whole grain bread only, brown rice only. So it really is a time where we're trying to establish healthy habits in children and pregnant women to have full-term healthy babies being born. And so to go back briefly, so in the WIC program, we do offer a fruit and vegetable benefit. It's a cash value, if you will. So for children, they receive a $9 value per month. And for a woman, they receive an $11 per month value. They choose how to spend those dollars at our local retail grocery stores that are authorized. And in New Hampshire, it's all of our large big box retail grocery stores, as well as a handful of medium and small corner stores that meet our guidelines that we have to go in and certify them that they have eligible food there. And so that fruit and vegetable benefit that families can redeem is for that 1 month. Right now, under the CR that we were in the budget that just passed at the federal level for WIC, we have received some enhanced dollars just for the fruit and vegetable benefit for our families. So for a child, only right now, they used to receive $9.
Wrap it up.
They're now receiving $24, but this all expires when this budget ends, and we don't know what will happen. The feedback has been incredible. And so this WIC Farmers Market is separate from WIC. It is a one-time benefit. Federal dollars only would give a $10 benefit one time to a child to go to the farmer's market. You're not getting much. So this bill would appropriate additional funds. So each child, 9,000 kids, would receive a one-time $30 benefit to go to the farmer's market and pick out fruits and vegetables with their family.
So my question to you is, we didn't have this before, and we're not going to have it again. This is a one-time deal.
So we did have this program. So the WIC Farmers Market has been in existence for 30 years.
Okay.
We had it up until 2010.
Okay.
At that time, a decision was made financially that it couldn't be sustained anymore. And so New Hampshire stopped seeking approval from USDA.
Okay.
We are now asking to bring it back. We have been approved by USDA to reestablish, which will give us our federal grant to move forward to reestablish. But this will provide additional dollars to enhance that benefit so there's more buying power to go to the local farmers markets.
So you're all set to be reestablished, and presumably this will be in the next budget and all of that. So all this is, and I mean all, is a one-time $30 thing that's going to cost $300,000.
Yes, but to then continue year after year. Every year we have to go back to USDA and ask for approval, but we're asking for appropriation in the budget every 2 years.
In the budget. So this is going to be in the budget.
Yes.
Okay. Thank you. Any other questions? Representative Gay.
Thanks. Does this mean that they'll get the $10, the ordinary $10 for fruits and vegetables plus the 30?
No, so the end result would be $30. So the federal plus the state dollars.
Other questions? Representative Folsom.
Thank you. Thank you for taking the questions. So the money that they get now, can they not spend that at the farmers markets? Why not?
They cannot. So in New Hampshire, we have not made the decision to authorize farmers markets because of the limited capacity that we have to oversee that component when it's integrated with the WIC program. And it's $9. So the amount of work that it would take just is not worth it.
But if the farmer sells the vegetables to my local market basket, the farmer in New Hampshire is selling New Hampshire grown vegetables to somebody who goes to that market and uses food stamp or whatever.
That is true.
Okay. Any other questions? Representative Leon.
Thank you, Mr. Chairman, and thank you. I hope this is clarifying. Does this replace the $9, now $24 spent at the grocery stores, or is this an addition to that $9 or $24 at the grocery stores?
This is an addition.
Thank you.
Just for farmers markets.
Thank you.
Representative Kofalt.
Thank you, Mr. Chairman, and thank you for taking my question. So how would the vendor requirements or the store requirements differ between a grocery store, which is required, for example, to buy approved formula and have that in stock? How would those requirements differ from a farmer's market, would the farmer's market, for example, be required to maintain an EWIC terminal to take EWIC transactions? And are there other differences in the requirements between the two?
Yeah, so thanks for that question. The WIC Farmers Market program nationally is not caught up to where the WIC nutrition program is with electronic benefits. So right now, nationally, the majority of WIC Farmers Market programs are using a paper coupon to go to the market because the farmers are just not ready yet to do an electronic system for WIC Farmers Market. The SNAP system and the WIC system do not integrate.
Follow up?
Thank you, Mr. Chairman. So, having worked at a grocery store years ago and managing that store, you know, our paper coupon system at the time resulted in an unusually high number of rejected coupons, to the point where we just looked upon it as a charitable contribution. Are you aware of the sort of the rejection rate or the return rate among these paper coupons in existing farmers markets programs?
Thank you. So I would say the important takeaway here is for farmers market, it's a dollar-based coupon and not a prescriptive food-based coupon. Like the grocery stores, it's certain bread, it's certain peanut butter, it's certain eggs. That's where that margin of error comes in because it is difficult finding those correct foods. And you're right, there had been a lot of rejected paper coupons in the past. Thankfully, we're past that. But the farmer's market coupon would be a $30 coupon, and we would likely break it into 6 $5 ones. And there's no change back, so it goes to the farmer, and then the farmer submits that for payment. And so there's not checking off for certain items.
Any further questions? Representative Gay.
This probably isn't a question. But
It's got to be a question.
Well, would you believe what
That's
they
a question.
do in Salem? They convert. I'm hoping this is helpful. The person with the coupons goes to the head of them, and they get converted into little pieces, you know, coins, so that they can spend it, because that's not likely they'd spend $30 in one spot. So that way they were able to use their total amount at several different places, and the money changers just did the help.
Yeah, so that's likely the SNAP program, and they're able to convert their coupon, if you will, into wooden tokens for redemption. The WIC Farmers Market program has different federal regulations that would not allow a wooden token system to exist for us. So it would be different, but it would also be used to redeem for fresh fruits and vegetables at the farmer's market. No, so all of the farmers that choose to want to be certified at a market can choose to accept the WIC benefit. No, as a state, we can choose how to break down that $30.
Any other questions? Seeing none, thank you so much. And Representative Edwards.
Thank you, Mr. Speaker. I always like talking to you all because this is my second favorite committee.
And we miss you.
Yeah.
We came into this committee together.
I prefer the other one because of the fewer puns, but so I would say that
Representative Shapiro, can that be treated? Is that in DSM?
So this is not an unfamiliar topic, right? Because we just did this in the budget cycle for the SNAP program, and as I was getting up to speed on this, I found it hard to say no to vegetables to kids, and it helped that was all federal money. At least the vast majority of it was federal money. So I was a supporter. Nobody mentioned to me at the time that WIC was going to come next. So this is a little bit of a surprise to me, and I just don't really like surprises. As I'm looking at the bill from a strictly finance perspective, we've imposed a manpower ceiling on DHHS, and this seeks to tweak that manpower ceiling. It asks for the money to be non-lapsing. As a general rule for budget discipline, we don't like non-lapsing dollars. And then I think this, your vice chair's point about this being potentially inflationary, I think my pop psychology around economics would suggest that it would be, because the New Hampshire farmers have already planned what they're going to plant. This doesn't go into effect until 1 July. So this will be additional money chasing a fixed supply, which is almost the textbook definition of inflation. And so I think I'll be spending time thinking about whether or not the effective date should be 1 July 22 as stated in this bill, or if that should be postponed to say 1 January 23 so that we can pick it up in the budget cycle as an ordinary course of business, and that farmers can plan for it instead of it just being a surprise demand. So those are just some general thoughts about this bill. And because people in the back are advocates, and I had to say the ugly things, this is think of this as having to eat your vegetables. You got to think about the downsides to these things.
Any questions, Representative Soloway?
Thank you, Mr. Chairman. Thank you, Representative. It's nice to see you back. You survived the Cornhuskers. If the farmer does in fact see his or her prices for his or her produce go up, will he or she then be encouraged to plant more next season?
Sure, that's how price mechanisms work in the long run, but also in the short run, anyone who is not the beneficiary of WIC in this case would be subject to higher prices in the short term. So we would be basically taking a fixed supply and picking winners and losers in terms of pricing, I think.
A quick follow-up.
Follow-up.
Would we then be encouraging our farmers to be more productive in the next season?
Yes, sir, which is why I'm toying with the idea of changing the effective date from 1 July to 1 January. So that way they can do all of the rational planning that you suggest they ought to be doing.
Representative Weber.
Thank you. And is not the issue of the effective date and the dollars that need to be supplied for this a matter for the Finance Committee, and perhaps the health benefits of vegetables for pregnant, postpartum women and children up to 5 is something that perhaps this committee ought to support as a matter of health policy?
Well, as one of those people who rub two nickels together, I would say that I have been a supporter of the SNAP program as it expanded to provide the farmers market benefit, and I'm not opposed to this. I just am taking a look at the the downsides to it and trying to figure out how to best say yes.
Follow up.
And the follow-up is, isn't it one of the delightful situations where Health and Human Services in this case gets to be the good guys and say we're for food and kids and moms, and the Finance Committee has to be the big bad folks who think about things like effective dates?
I can play the bad guy. I'm okay if it came over amended to take out non-lapsing, changing the effective date, and getting rid of the manpower. I would love you.
Representative Leon.
Thank you, Mr. Chairman.
I'm moving
and-
quickly past blame shifting here.
And
Yes, go.
thank you, Representative. I know we both appreciate the market signals, but with this being a standalone bill and not being part of the budget process, would it even make sense for our farmers who are looking at fertilizer prices that are higher, fuel prices higher for their tractors, manpower prices higher for our tractors, to go ahead and plan for something that might not show up again next year? Or would it make more sense to not mess with our current market that feels like the housing bubble? I'm sorry, everybody said, oh, but if this happens, we have trouble. But it feels like it's just another shoe that we're throwing into the inflationary furnace. And do you believe that there's actually truly a market signal when it's only one-time funds?
Well, because I think I've heard them say that they want to keep this in the budget, and so it would be an ongoing program, but the first one is, they have to do it this way because it wasn't part of the budget. I do think it would be an ongoing cost. 300,000 in the grand scheme of New Hampshire agriculture probably isn't anything but theoretically inflationary. But I'm not an economist. I don't know the total size of our agricultural business, but 300,000 can't be much.
Representative Gay.
Thank you. If we took out non-lapsing and let this be a standalone trial for this year, would that make it more palatable so that kids could have a chance to do it?
So Representative Weber wants to hear me say that I have deep respect for the policy committee, and if that's the determination of the policy committee, that'd be great.
Representative, we assumed that. You don't have to say it.
Oh, one more question about money.
Would you like a follow-up, Representative
thank
Gay? You may have one.
Is does anybody know, is this $30 for 1 year? Or somebody said something about every biennial budget. So is this $30 a year or $30 for 2 years?
Because this starts at the beginning of the second year of this budget cycle, I think this 300,000 was meant to be one time, but the fact that it says non-lapsing means it'll carry over into future fiscal years. Presumably, if they put it into the budget, there'll be fresh dollars to go with the fresh vegetables on 1 July of whatever the year is, 24 or 23. Yeah, I'm losing my dates. So, but that's the way I understood it. And I understood the previous testimony to say that since they would be doing paper coupons, it wouldn't be a $30 coupon. They would create multiples so that there would support transactions.
Seeing no further questions, thank you so much for your testimony. And the sponsor gets 1 minute, just because we're the greatest committee in the House.
I know, appreciate it's been a long day for you. I did want to speak to those inflationary drivers, but I think the other thing to remember is that, and I don't speak for every farmers, but what I do know for my local farmers is that they do have food waste. They do have food that they have to throw away, and why not use that surplus to feed vulnerable populations? But I'm happy to, I think that is perhaps a valid discussion for the Finance Committee and one that the Farm Bureau, I'm sure, would like to engage in. Thank you.
Thank you. And with that, close the hearing on Senate Bill 403 FNA and open the exec session on the same, and the chair calls on the Vice Chair, Representative Leon, for a motion.
Thank you, Mr. Chairman. I move ITL.
Do we have a second? Representative Kofalt, and speak to your motion.
Thank you, Mr. Chairman. I understand that this is very well intentioned, and the point is to get vegetables in the hands and mouths of our children. I feel that we are at a precipice. I feel that there are a lot of challenges. If you go to the grocery store, you can't even find what you're looking for on the shelf, whether it be chicken or anything else. And I'm just very, very concerned that instead of saying, grab some seed packets and maybe we should all throw some in the ground, or figuring out a way to cut food waste, cut regulations that are in the way of distributing what today is food waste, that we are looking at just throwing $30 a kid to try and solve a problem that won't be solved, but it'll probably further exacerbate our supply chain issues.
Anyone else? Representative Acton.
Well, I'm sorry to say that I'm very much in disagreement with that. We face an extreme food crisis right now. Countries like Lebanon, like I heard from my friend in Haiti yesterday, they're running out of food. Peru already has deadly food riots. We can't wait for another year or anything to get this going. Now, this is a very symbolic program. Last year, they had a program at the farmers markets where veterans could get a $20 coupon. Now, I don't expect to be able to feed my family with the $20 coupon, but it promoted that the farmers markets existed, and I was able to go there, and it created a habit. And then my wife and I and my daughter started going every week without the coupons and buying an armload of locally produced produce, and that's, I think, what's happening here. So we shouldn't look at it as like, oh, it's only $30. It's training people to use local resources that we have to start using. I can't explain enough that we are going to be in big trouble with food supplies, not just the poor. It's going to be all of us by next fall. And a sense of urgency is needed, so I support this. Thank you.
Any other discussion, comments? Representative Gay.
Thank you. I totally agree that this program is a really good way to get people to go to a food market. Say it. A farmer's market who've never been. And I would think that it's a really, really, really good investment. I would like to change it so that it's not non-lapsing, and OLS has been fabulous about fast turnaround. So I really want to support this. I think it's going to be really good for the kids especially the ones who've hardly ever seen vegetables. This will be fun to go. It'll get them in the habit of going. They'll break down their fear of going to an unfamiliar place. But I want to make it so that we evaluate it after the first year.
The chair wants to get a sense of the committee. If the word non-lapsing is removed, would there be enough sympathy for us to push this to 7 o'clock tonight to get an amendment and work on it, or not? Yes.
That should be left for finance. It's a financial question. There's no earthly reason for us to deal with that here. Thank you.
I know. I just didn't want to be the one who said it. Okay, so we'll defer that to finance. Okay with you to get that?
Finance?
If he's willing to do it.
But right now it's ITL, so we have to.
Right.
address
Well,
that.
if ITL's defeated, then we'd have to come back and do something else. But I just want to see where the sense was. Representative Kofold.
So my concern is with the complexity of the program from a vendor perspective. So farmers markets are typically staffed by people who are chief cook, bottle washer, and everything else. If you look at the documentation currently provided for stores by DHHS, it talks about training and certification. It talks about having a lane with a trained person there to accept WIC payment. I understand that this is different. It's not clear to me at this point quite how this is different. And I will relate my experience, although it was quite a few years ago, with paper-based WIC coupons, was that if the official WIC stamp that we put on the coupon was not dark enough, if it was clear, legible, but not dark enough, it would be rejected. If we wrote the numbers in anything but perfect block letters, it would be rejected. There was as I said before, the rejection rate was considerably higher than the acceptance rate, despite all of our efforts. So my concern is that we are potentially burdening small businesses, people who are operating on very low margins, with a program that may not be that may end up costing them money and considerable frustration. And I would argue that the question of lapsing or non-lapsing and the need to reevaluate is therefore not strictly a financial question, but is also a question as to the efficacy of the program and participation rates from farmers market vendors.
Representative Kofold, do you think that if we kind of signaled, and I'm hearing that the idea of SNAP and WIC have merit, and we've seen them have merit, and say that we really want to do more with this, and this got built into the next budget cycle, they've now got additional time to get the act together in terms of coupon readers and training and all of this. But this would be, and this is for Representative Edwards, this WIC thing would be a snap decision.
Mr. Chairman, although I seconded the motion and I don't like the bill in its current form, I do support the intention of the bill. And I think that if we were to do something like that, that might be a good middle ground.
Representative Bohm.
Thank you, Mr. Chairman. Just a comment on people just saying there's going to be a food shortage come fall. That food shortage or vegetable shortage or whatever is going to be for everybody, whether or not they have a coupon to buy it or not. So I don't see how this is going to be helped. I mean, the problem is the food's gonna go as fast as it can by those who can. So not gonna be any food left for anybody with a coupon. So the problem is, we're not fixing the problem, we're exacerbating the problem. Thank you.
Representative Weber.
As to the ease of use of the program, this is not a new program. It's a program that worked just fine up until 2010. So, and secondly, nobody has to participate. The farmers don't have to participate. So if they don't want to deal with it, they don't have to. But if they are going to have produce that they have to chuck away, and they may in any given week because stuff comes in and you have a lot of it, it gives them money for their excess produce. They don't have to do this at all. And we are talking about such a small drop in the bucket. The fact is that if we are going to have food shortages, shouldn't everybody have a chance at having nutritious food? And, you know, some of us are going to get there on the wrong day, and it won't matter whether we have dollars or don't have dollars, but let's have everybody have a chance.
Representative Knurk.
Just a little bit about the size of that drop in the bucket. I was able to find that the New Hampshire agricultural cash receipts per year is about $200 million. So this will represent about 0.1% of that. I don't think it's going to be a high inflationary pressure. That's not something to worry about.
Representative Gay.
Thank you. I'm just contacting right now. I just texted the woman who used to run the farmers market in town to ask how did they deal with WIC, because if they can aggregate it and just let people turn it in and get a slip like you're saying that they do SNAP, it would solve this problem.
Did she text you back?
No, I just sent it.
Oh, okay.
So do we have to vote right this minute?
Yeah, we do. Representative Soloway.
Thank you. Thank you, Mr. Chairman. Speaking as someone who grew up on canned peas and occasional creamed corn for dessert, during the season, I go to 4 farmers markets per week. Every one of them has a SNAP booth. We can piggyback WIC and SNAP and make it work. We're good at this.
So no more canned peas for you. They're SNAP peas for you. Okay. Yes, Representative Acton.
Just a clarification. As far as when I was mentioning food shortages, what I see happening is with $5.31 a gallon diesel, it's going to get too expensive to ship the stuff up from Mexico, from California, or to fly it over from China. We need to build local capacity, and by doing this in just a small way of bringing attention to the local farmers, we're building local capacity. And right now it's still early enough to start new seedlings to improve your yield this year, but we need to improve the local capacity, and that's what I feel this program will help.
Anyone who hasn't spoken before, Representative DeLamus.
Thank you, Mr. Chairman. I would think I've got a friend who's got a pretty big spread, and they have all manner of animals and vegetables. And I think they're fairly aware of the situation with the fertilizer and the food chain supply and the whole 9 yards. I don't know if this is going to incentivize or encourage them to do more than they're already doing. I think they probably are aware of it already. I don't know if this program in particular is going to have any more effect than you're thinking it would.
Representative Leon.
Thank you, Mr. Chairman. I know that the intention of this bill is very good. I think it's a federal solution to what should be, we should have a local solution where we have regulations that are in the way from getting food that's not perfect out to people. That's something we need to stop being in the way of. If we have anything that's limiting some of the bruised produce from being donated out, if we have any, and I would like to see us encourage not just this one-offs at the farmers market, but figuring out some way to have some tax incentives for people to participate in a CSA or do something else that gets people more involved in the process than just having $30 to spend. This is something that I plan to work on to try and find a better solution. I just don't think that this one is the right solution, but I believe that it's true. It needs to be fixed, but I think we can do it better in the New Hampshire way than just this. So that's a big part of where my feeling is, between the economics and also the fact that we're turning over a 50 by 60 plot right now to plant. So, you know, that's where I'm coming from. It's not that I don't want to have this get to people. I think we can do it better.
The motion before us is ITL on Senate Bill 403-FN-A, made by Representative Leon and seconded by Representative Kofalt. The motion is ITL. Would the clerk please call the roll? Or the assistant clerk?
He sure will. Representative Leon,
Yes.
Representative McMahon,
No.
Representative Acton,
No.
Representative Gay, Representative Cushman, I'm sorry, Representative Moody,
Yes.
Representative Folsom,
No.
Representative Bohm, Representative King, yes. Representative Colfault,
Yes.
Representative DeLamus, Representative Weber, Representative McKay, Representative Snow,
No.
Representative Knirk,
No.
Representative Solway, Representative Cannon, Representative Nutter Upham, Representative Shapiro, Representative Woods,
No.
Representative Query, and Representative Pearson.
Changed my mind. No.
Okay, we have 6 yays and probably 15 nays.
The motion is defeated. The chair will entertain a subsequent motion.
Mr. Chair,
Representative Acton.
I'd like to move to OTP 403.
Okay, Representative, well, we've got a tie here. Representative Shapiro, seconds. And I really don't think there's anything more to discuss, but you do get a minute to do it, or less. The motion before us is now ought to pass on Senate Bill 403 FNA, moved by Representative Acton and seconded by Representative Shapiro. Somebody with the chart, please call the roll.
Representative Leon,
No.
Representative McMahon,
Yes.
Representative Acton,
Yes.
Representative Gay, Representative Moody,
No.
Representative Folsom,
No.
Representative Bohm, Representative King, no. Representative Colfault,
No.
Representative DeLamus, Representative Weber, Representative McKay, Representative Snow,
Yes.
Representative Knirk,
Yes.
Representative Soloway, Representative Cannon, Representative Nutter Upham, Representative Shapiro,
Yes.
Representative Woods,
Yes.
Representative Query,
Yes.
and Representative Pearson.
Yes.
And pretty
14
much
to
the same
7.
thing.
The vote is 14-7. The bill ought to pass. Passed. Representative Soloway.
If you intend to continue this session without an extensive interruption for lunch, would you like to order pizza for the committee?
With the proviso that finance pays for it.
That'll be non-lapsing.
I would like to get a sense of the room. Probably not all of you brought a sandwich, so you're going to need to go downstairs to the cafeteria, my guess would be. And that's my guess. And so would this, I don't know if it is or not. I would suggest we reconvene at about 2:15 and pick up from where we left off.
Okay, and
And the majority report, Representative Acton, please write. By the end of the month. Okay, good. And minority?
can I do it as interim study and write it?
What's that?
Is it all right to do that?
Yeah, you are.
Yes.
Really wanted to vote.
Me too.
Well, nobody moved it. Okay. I open the hearing on Senate Bill 444 relative to childhood adverse experiences, treatment and prevention. Flown in at great expense is Senator Whitley to present her bill.
Thank you, Mr. Chair. Good afternoon again, members of the committee. For the record, my name is Becky Whitley, and I'm honored to represent Senate District 15, including the communities of Concord, Henniker, Hopkinton, and Warner. You'll note a trend of the bills that I've introduced to this committee today. I've spent my professional career prior to being a senator committed to the health and wellness of New Hampshire children, and I continue that work in the Senate. So for your consideration, I'm happy to introduce Senate Bill 444. This is another bipartisan bill that builds on the many years of hard work to build a more responsive system to our children and ensure that our children don't slip through the cracks, and ensure also that our families get the support that they need before they are in a crisis. So this bill brings children of all ages into the existing system of care we have established in New Hampshire for children. Notably, it brings our young children, our most vulnerable, into the system of support. This bill represents a missing piece to the system of care because it takes that work upstream and shifts our focus to prevention. Now, I'm often asked, how do we prevent crises before they happen for New Hampshire children and families? I'm asked, how do we identify vulnerable children and support them before they end up in our emergency rooms? So I would submit to you all that SB 444 offers us this opportunity to provide these solutions to these seemingly intractable problems that we have been dealing with in New Hampshire for many years. So you all may know that over the course of the pandemic, we saw soaring rates of mental health challenges among children, exacerbating a situation that certainly existed prior to the pandemic. Children and families across our state have really experienced enormous adversities and disruption. So much so that in October 2021, the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association declared a national state of emergency in children's mental health. And they called on policymakers to advance strategies to meet these challenges through innovation and action. Today, we have the opportunity to heed that call by advancing Senate Bill 444. So again, this bill looks at young children and identifies solutions to better support them to prevent crises down the road. And as many folks in this committee may know, this is critical because childhood abuse and neglect, other traumas, what we refer to also as adverse childhood experiences, ACEs, what those ACEs do is they can interrupt the normal development of a child, particularly in their brain. But the good news is, with the right interventions, the right support, children, we can interrupt that cycle and children can grow up to be resilient and grow up healthy. And I personally think that every child should be given that opportunity. So in addition to building on the work to build the children's mental health system, and this legislature did that in 2018 and 19 in Senate Bill 14, this bill supports the prevention and early prevention and early intervention goals that were identified in New Hampshire's 10-year mental health plan that this legislature worked hard on with the Department of Health and Human Services in 2019. It also supports recommendations from the Council for Thriving Children, which was created by the governor to look at early childhood. This bill aligns fully with the council's 2020 strategic plan for early childhood, and it also aligns fully with the department's existing infant and early childhood mental health plan that they received a federal grant to further build out the infant mental health system. And so this bill does that in many ways. I will admit this is a dense bill, so I apologize for that. But it does all fit into an overall puzzle. So just one thing I wanted to highlight about 4 pieces that were really important in this bill. It builds the workforce capacity. We know that there is really a dearth of mental health providers in New Hampshire to provide these supports for children and families. So there is an appropriation in here and other language to build workforce capacity for our infant mental health providers. It also pilots a new level of care for our young children. We already have an existing level of care for our most vulnerable children that are at risk of hospitalization that has been in the budget for many years. This pilots that level of care for young children 0 to 5. It also expands evidence-based mental health interventions for young children. And I do want to sort of land on that word evidence-based. We don't want to be throwing money at interventions that don't work. And so that's why it's important that we build on those interventions that have proven to be effective with our children. And so that's what this does. And lastly, there's an appropriation to support New Hampshire's primary prevention infrastructure. Folks may be familiar with the Family Resource Center in New Hampshire. This is our first line of defense with children and families. When we say primary prevention, we mean what are those things we can do to prevent child abuse and neglect? And the first line of defense is with our family resource centers. I don't need to tell this group that young children are the most vulnerable members of our society, but they're vulnerable both in terms of risk for abuse and neglect and trauma, but also they're most vulnerable in terms of how that abuse and trauma can impact their brain, and the impact of those lifelong the lifelong impacts of the trauma on their brain. And I will note, what was particularly startling to me, and I work alongside a lot of different providers, what I heard that during the pandemic, there was a dramatic increase in child sex abuse. And that really took my breath away, that we're not doing enough to support our young children. And we're talking about 0 to 5 here. So this is a crisis that we just cannot ignore anymore. And unfortunately, if you have been in this work for many years, you know that system failures have led to certain high-profile deaths of children in New Hampshire. We have come a long way to better support New Hampshire children and families, but there is a missing piece here, and that's supporting young children to prevent child abuse and neglect. So this bill gives us that opportunity to, again, shift towards prevention, to address these issues before they become more expensive down the road. You may know that it's very expensive for a child to be placed out of home. It's very expensive when we need to send our child to a placement outside of the state. It's very expensive for our children to get treatment in our emergency rooms. And it's also detrimental. Children should not have to wait till they are in crisis to get services and wait for services in an emergency room. It's much cheaper and more effective to invest in high quality evidence-based early intervention. It's also shown, again, this is all evidence-based stuff. I'm not making it up. It's been shown irrefutably to have a greater societal impact than waiting till we get these families downstream. So if you don't believe me, you can look to one of our founding fathers, Benjamin Franklin, who so aptly said, "An ounce of prevention is worth a pound of cure." Again, if we don't want to heed Benjamin Franklin, let's heed the experts here in New Hampshire. New Hampshire's child advocate said in a letter to my body in the Senate, Senate Bill 444 contemplates a careful rounding out of the system of care in addressing the earliest, most important years for a child's path to success. In another letter signed by dozens of New Hampshire organizations and mental health professionals in support of this bill, these folks reminded us that primary prevention programs like those supported in Senate Bill 444 prevent and mitigate childhood trauma and provide multi-generational supports to enable families to thrive. Thank you so much for your consideration, and I'm happy to take any questions.
Any questions of the Senator? Representative Shapiro.
Thank you, Mr. Chairman, and thank you for bringing this bill. I think it's really important. I'm well aware of the vulnerability of children and families with young children, and the shortage of people who have expertise to deal with these kinds of situations. And I think they're really incredibly difficult situations to deal with. What I don't understand about the bill, it's probably in here and I just not getting it,
Sure.
is the pilot program for child parent psychotherapy. What are the mechanisms for making that happen? Like, where might it happen? And is it one program, or is it people who are trained who are available around the state? Is it in one of the family support centers? What is the mechanism for actually creating, or what's the vision of a pilot program?
Thank you for the question. So the pilot program is actually not for CPP. This is what we call child parent psychotherapy. The pilot program is for this level of care that we already have in the children's mental health system. And so you may remember that in Senate Bill 14, we expanded the role of our care management entities to provide high fidelity wraparound services. So these are those buckets of services that are paid for by Medicaid. similar to waiver services, we used to call them, but they're a bucket of services paid for by Medicaid to support children at risk of out-of-home placement. But that Medicaid benefit is only for children and families 6 and older. So the pilot program is to expand the contracts for the existing care management entities to include children 0 to 5. And then the other pieces to child parent psychotherapy, there's a couple pieces. One is to look at we have a 5-year sort of plan to expand capacity and build on existing investment. There has been a lot of philanthropic investment by actually all 3 of our health philanthropy organizations that have invested in child parent psychotherapy. We just need to take it to the next level to train up existing providers to do this intervention that is very effective for young children. Does that answer your question?
Yes, I believe so. In Cheshire County, there's a system of care
Yes.
program that's existed for a long time, but I didn't understand that they only served children 6 and over. So this would extend
Correct.
the age down.
Correct.
So that they
Absolutely.
could provide intensive wraparound services.
That's right. So they are one of the existing CMEs, and they had received a grant to do this pilot also. And so this is so the other care management entity can do it also.
Thank you.
Thank you.
Further questions, Rebecca? Representative
Thank you, Ms.
Leon.
Yeah. Thank you, Mr. Chairman, and thank you, Senator. If I can have a 2-part question. The first is looking at page 2, line 7. It says current reimbursement rates are inadequate. Does this bill cover that, or would that be something that'd be asked for in the future?
Yeah, so thank you for the question. So that language is taken directly from a number of evaluations that have looked about what are the barriers. So we know that Medicaid rates are not adequate across the board. And so the piece that you're referring to refers back to the requirement let's see, later on. There is a requirement later on that the department develop a plan to look about how to expand this population. And one of those things that they need to look at is the reimbursement rate.
Thank you. And I think I'd ask for a follow-up.
Follow-up?
The follow-up is with these children age 0 to 6, that's before they're in school. What is the plan to identify these children, and what would you determine would make them at risk for these?
Yeah, well, that's multifold. So sometimes those children are in our schools if they, have been identified as in need of services. They are getting preschool services through special ed. They might be identified that way. They might also be identified by a family resource center if they see a family that needs some more support, or a family goes to a family resource center. We also in New Hampshire have just expanded and brought back voluntary services. So it could be that a family, maybe that there was a call made to DCYF. There wasn't a finding of abuse and neglect, but that family has been identified as potentially needing support. And so voluntary services are offered. So there are a number of different ways that families can be identified. The at-risk part is, in particular, when we're looking at this Medicaid pilot that we're talking about, that's sort of that's defined really in the Medicaid benefit. So it's at risk of institutional placement, at risk of out of home placement. So that's well defined in Medicaid, and in the Medicaid state plan amendment that the state had to request to get that funding.
This would only be limited to those children who are receiving Medicaid or within these programs are at risk of an out of home placement, like the bill that we heard earlier.
So for that portion, yes, that pilot program. And I will say that many families, if a child needs that level of care, this is only for the 6 and above, it is my understanding that if that child has that level of need, they will likely, that would be an eligibility for Medicaid in and of itself based on the needs.
Thank you.
Thanks.
Any other questions for the senator? Representative Gay.
Thank you. On the financial pages in the back,
Sure.
where it says 550,000 for a 1-year pilot program. Wait a minute. Oh, to support children ages 0 to 8.
Oh, I will say this fiscal note is out of date in the Senate. So there are four on the fiscal note. There are 4 appropriations. In the Senate, we cut out 2 of those appropriations. So the remaining appropriations in the bill are number 1. No, that's wrong. Let's see. Excuse me, number 2 and number 4. So 2 and 4 remain. One and 3 came out in the Senate.
Representative McKay.
Thank you, Mr. Chairman. Thank you for bringing in this extremely important piece of legislation. But one of the things that I have advocated for quite a while now is that we use the mental health 10-year plan that the department developed. And I'm very pleased to see clearly that this is what this piece of legislation is doing. So I really thank you very much for carrying on what I hope will become a tradition, that we continue to use that 10-year plan, which was extremely well done. Thank you very much.
Yeah, thank you for that point.
Building on that, Representative, do you have a question for the senator?
That's it. Would you believe?
Yeah. I mean, the 10-year mental health plan had robust prevention and early intervention goals that aligned with an existing infant mental health plan that they had. And so certainly this aligns with that also. Yeah, moving the ball forward.
I know she's new on the job, but has the new child advocate gone through this with you yet?
I don't know about the new child advocate, but certainly the deputy has, and Moira before her worked with that. But yeah, I will certainly continue to work with the new child advocate.
I'm sure you will.
Thanks.
Yeah. Anyone else? Seeing no one else. Thank you, Senator. And the unless I've lost them, I have one pink card, and calling on Emma Savini. I looked up your cousin over the lunch hour. It's quite a career.
She's very talented.
She's that. And so are you. Welcome.
Thank you. Thank you, representatives, for having me here today. My name is Emma Savini. I am here as the Children's Behavioral Health Policy Coordinator for New Futures, a nonpartisan, nonprofit organization dedicated to the education, collaboration, and advocating for the health and wellness of all Granite Staters. I'm here in support of Senate Bill 444 for a couple reasons, as outlined by Senator Whitley. I'll be brief. Essentially, Senate Bill 444 does an excellent job of expanding the existing system of care in our state. It is clear that when children experience an ACE, or an adverse childhood experience, they can have lifelong impacts, negative impacts on children. But when they have the proper tools and support systems in place, those ACEs have less or no impact on their life. So for instance, CPP, or child parent psychotherapy, as mentioned by Senator Whitley, is an excellent way for an evidence-based practice for a provider to treat not just the child, but the family as a whole. And so this would create resiliency within the family to both heal from previous adverse childhood experiences and prevent future ones. Additionally, Senate Bill 444 gives appropriations to family resource centers, which are an excellent first step in identifying and preventing all sorts of trauma within families. I'm happy to take any questions, but the general consensus is that this is a great step for our state, and we urge you to vote ought to pass.
Representative Weber.
So just to reiterate, one of the goals of this legislation is to actually keep families together by strengthening them so that we don't get ourselves into the downstream problems of foster care, residential placement, and all those other things.
Exactly. You'll note in the pilot programs, CPP and family resource centers, the goal is to treat the whole family and not just the child.
Thank you.
Representative Gay.
I was just wondering if this program dovetails into any that's training teenagers before their parents, you hope, you know, that so that you're trying to catch them before this trauma happens and ACEs happen.
Thank you for your question. And I'm sorry if I'm misunderstanding, but are you asking if there's any type of training for children before they become parents? Yes. I'm not aware of any at this point, but I can certainly do that research and get back to you.
Representative Shapiro.
Thank you, Mr. Chairman. Might have been better asked to the senator who presented the bill, but maybe you were took part in creating the bill. So the part of the appropriation for child parent psychotherapy, which is $700,000, do you know how that's intended to be used, or how that, you know, what kind of program there will be to actually train people up? Is that people who are already licensed clinicians who will get additional training? Will the state create trainings? Will the state develop contracts with people to teach people who are already practicing in the state to do that evidence-based practice?
I believe it's a combination of those, and Senator Whitley is confirming. So yes, I believe it's a combination of all of those things that you have mentioned.
Any further questions? Seeing none, thank you so much.
Thank you.
This concludes the hearing on Senate Bill 444. If we could give the Senator Rosenwald, I see you're letting her know, and that gives me a few minutes. We will exec this bill later. This gives me a few minutes to remind the committee that there are 3 bills that I have been presented with where the Senate amended a House bill. They've kicked back to me. I have the right to concur, non-concur, or concur with request of a committee of conference, but I would wish to value your input. So I gave that to you last week, and I heard from a couple of people, and if anyone else wishes to do this, let me know so I can turn in the reports shortly. Also, the fourth floor has been very busy, and they've come out with some fiscal notes, including a fiscal note on a bill we've already voted on. So this is the fiscal note as of today that is on 407. So you can put that with your pile of stuff for that bill. Any extras on what's going around? Yeah. There will be. Now open the hearing on Senate Bill 423 relative to a closed-loop referral system in the Department of Health and Human Services. And this has been studied at some great length. And as the chairman of the Joint Legislative DHHS Oversight Committee, I saw how this took up portions of 3 of our meetings with Senator Rosenwald and Representative Edwards doing an immense amount of work on this. And of course, the main purpose, we hope, is to get good usable data to make good rational planning and at the same time keep things as confidential as we possibly can. And I'm stalling for time. Because Senator Rosenwald is just being brought out of a committee. And Representative Edwards, in the meantime, you want to give some reflections, please.
Thank you, Mr. Chairman. I'm Representative Jess Edwards, representing Auburn, Chester, and Sandown. I was very proud to be a co-sponsor of Senator Rosenwald's bill relative to the closed-loop referral system in the Department of Health and Human Services. The chairman alluded to the genesis of this bill, which was to go back and go into a little bit more detail, the closed loop referral system, for those of you that don't know, is a IT-based solution that connects this community of care that we continue to hear about. That a patient or a family in need oftentimes will need multiple services from the community. And so historically, it's very difficult to coordinate referrals among decentralized vendors.
And I'm going to ask this, the representative to hold the rest of his informal remarks so Senator Rosenwald can introduce the bill, and Representative will bring you back for some more.
Don't forget where I left off.
I won't. I believe it was, thank you, best committee in the House.
For the record, Cindy Rosenwald from Senate District 13, and I am pleased to introduce Senate Bill 423. It will establish in statute certain privacy and security expectations for the closed loop referral systems that may be created for Health and Human Services programs. As you remember, both the House and the Senate thought this topic was important enough to put in their respective versions of House Bill 2 last spring. However, it's only session law. And so the public policy respective to closed loop systems has to be put into the RSAs. Representative Edwards was explaining what closed loop referral systems are. It's probably a good idea to make sure that when a referral is made, it gets followed up on. Somebody answers the phone, somebody picks up the fax. We did briefly have a contract for such a system. However, it expired. The contract was not extended and the system was halted. But there's still a lot of interest in the department and from providers. So I think that establishing the public policy in the areas of privacy and security for people in New Hampshire, as far as their personal health information is concerned, is very relevant. And that is the purpose of this bill. It does several things. First, it establishes the rights of individuals to keep their private health information away from state government if they are not currently receiving services paid for by the Department of Health and Human Services or have not received any services paid for by the department within the past year. And the department is prohibited from accessing individually identifiable information or protected health information, which is a HIPAA term of art, unless the individual affirmatively consents on every referral instance. And we have included in the bill the specific language that the department would have to use to obtain that consent, because we want to make sure that the individual is asked in language that is simple and easy to understand. This bill also closes a loophole in the HIPAA privacy law. Under HIPAA, if a covered entity suspects there's been a breach that exposes an individual's private information, they have to investigate that potential breach, but they do not have to inform the individual that information has potentially been exposed. The entity is under no obligation to ever tell the individual that their health information might have been exposed unless they eventually determine there was a narrowly defined breach. And I say narrowly defined because the way HIPAA defines a breach, in my opinion, is very narrow. So, for example, if the breach did not involve a lot of people or no harm was done to anyone with their exposed private health information, they never have to tell you. And even if they do tell you that there's been a breach, there's no delineated or required timing for the covered entity to notify you that there's been a breach and your personal protected health information has been exposed. So this bill takes a small but I think important step to help the public by saying that the contracted entity running a closed loop referral system, if they do determine there's been a breach as defined by HIPAA, they have to begin to notify people within 48 hours. They don't have to finish notifying them within 48 hours, but they have to begin that process. And the bill also makes clear that people have the right to opt into the system at every referral for services and that they can revoke consent at any time. HIPAA requires retention of protected health information for a number of years. I think it's 7, it might be 10. But some information about human service programs would not be covered by HIPAA. So to the extent allowed under federal or state law, if someone revokes their consent to be in this system, the private information about them has to be quickly deleted. And finally, we clarify that the provider organizations can only access information on an individual if that individual has been referred to them for services and has also consented to allow the provider to access their information through the closed loop system. With that, Mr. Chairman, I'm happy to take questions. Thank you.
Questions for the senator? Representative Gay.
Thank you. I was a little concerned. I'm very glad y'all were working on the security, and we were concerned in the past with the system that had started that we hadn't voted on, and they didn't have experience with this same kind of concern. The only thing I caught that sounds a little awkward is that this will require, if there is a breach, that notifications of the people whose information was breached will start being notified within 48 hours, but no requirements to finish.
So when I draft legislation, I try not to be overly prescriptive. But I think once you start a process, you have to tell the people. If there's been a breach, they have to notify them. If you begin the process within 48 hours, you're not waiting 4 weeks or 6 weeks or 2 months. You start it. That's up to the committee whether you want to require an end date, but that was my thinking.
Start the process.
Any further questions for the senator? Seeing none, thank you, Senator. And
Thank you.
the chair brings back Representative Jess Edwards. He was in the process of going down a wonderful list of the various virtues of this committee.
So when we last left this, we were hearing what a closed loop referral system is for those that don't know. It is a system in which, say, Professor Salloway has a service in the community. DHHS doesn't need to know anything about what's happening in that service, so they don't have access to the personally identifiable information. But if the professor wants to refer to Representative Cannon, they can use this closed loop referral system to efficiently transfer the referral. Now, as the patient, I want the courtesy of being asked before Professor Salloway does this transmission, whether or not I agree. I have to opt in. So there needs to be a checkpoint in every one of these referrals. And the department doesn't necessarily know what's going on at that level. It's almost like you're throwing a big BYOB party in your property, and everyone's showing up with beer and other things, and they're handing each other beers. While you may not know who's drinking what, you're still ultimately responsible for the whole party. And that's why the legislature, through the HB2 process, got very much involved in this closed loop referral system, because relative to the other type of IT systems we've experienced in the state, this one's a little willy-nilly. The personal data has the potential of just moving all over the place. It was under a procurement on a sole source justification. The priorities for purchasing it did not include privacy issues. So we just called a timeout so we could do a privacy audit. The Health and Human Services oversight, led by your chairman, conducted a privacy audit on the closed loop referral system, and that opened up a whole sort of panoply of other privacy issues. So this is one bill that came from it to deal specifically with the closed loop referral system due to its unique nature, and I support it. I hope you pass it. The other one is 1662. It's we've already passed it in the House and sent it to the Senate. So so that gives for 423, it tells the department what it must do. 1662 gave them, if the Senate passes, it gives the department the tools with which to not only do it for the closed loop referral system, but to continue to do it for all of the IT systems handling personal data. So I like to think what this session has brought to the table is an evolution of thought and progress about the department and its obligations under our right of privacy constitutional amendment of 2018. It's actually beginning to push the ball up the hill. So if there are any questions, I'll answer them. I think Senator Rosenwald, from a description of the bill, was dead on and complete.
Representative Weber.
Thank you. I just had one question, which maybe I'm just hearing it wrong as you and the senator explain things. Would the department be involved in any way in collecting data for a closed loop system for people who are not receiving services which are either provided for or paid for by the department? It's not for just anybody's regular old medical relations with their PCP and others, is it? Or is it? Or it might be.
It's more the former than the latter.
Okay.
It is meant to not be a routine source of access to personal information by the department. Right. The department, specifically in the language of the bill, is only able to access the information if they're providing the service. The decentralized nature of how the closed loop referral system works out in the community, that all happens without the direct visibility of the department. The department's not getting back information on those individuals while that referral is live in the community.
So could I have a
follow-up? Yes.
Could you give me, I mean, I know this is hard because it doesn't exist yet, and in a sense it hasn't been invented and defined yet, of what kind of services, I mean, as I understood it initially, this was a system that was only for integrating and unsiloing services that people who were receiving services from government agencies or government contractees. Is it contemplated that it would go beyond that?
So thank you for the question. And the nice thing is the closed loop referral systems, there's at least 3 different vendors that have functioning systems that are deployed all over the United States. I think we have 3 different vendors in the room with us today. And these things are live. Now, if we flash back to what we've heard around public health likes to focus on the social determinants of health, and the social determinants are many and varied. If somebody has mental health problems, they're often associated with having housing problems. They can be associated with having, food deserts in their area. And so each of those can be provided by different support groups in the community. And then as a consequence, because it's community-based, you get this wide diversity in the types of organizations that can be involved. It's not just government, it's not just city or town. It can be, the local VFW food pantry, for example. So all of them, we want them to be able to have an efficient way of handing off a referral. Today's version is very facts-based, and so we're passing a lot of personal data around as it is in the current system. This is our opportunity to really tighten it up while at the same time making that much more efficient.
Representative Soloway.
Thank you, Mr. Chairman. Thank you, Representative. Would you describe this as highly protective of individual privacy rights?
I wouldn't make that assertion. I would say that our attempts under 423 are to make it highly sensitive to privacy rights. There will be an RFP process led by the department, and I don't know that they did it in the sole source justification, but I expect in the RFP, Mr. Wieters is here, he can speak to this, but I would expect that they would have a very robust section on privacy that may not have existed in the first contract effort.
Thank you.
Thank you, Representative Edwards. Chair calls on Senator Bob Guida,
Thank
who's
you.
also a part of the DHHS oversight and listened to a lot of statements while this policy was being crafted. Senator Guida.
Thank you, Mr. Chair, members of the committee. For the record, Senator Bob Guida, District 2. I'll be very brief because it's impossible to better clarify this system or the legislation than my previous 2 testimonials have provided. I just call the attention to the overarching interests expressed by our citizens in the constitutional amendment, I think 4 years ago, where information privacy is paramount. We have a system of care that continues to expand and to incorporate non-medical components, and that is what this addresses. This legislation says, okay, for me to let you know that I, for example, as an airline pilot, would be receiving food stamps or some other, psychiatric care or whatever, I want the right to reserve that information or the sharing of it within the system. I think that that's critically important. There's a difference between or balancing the need to know with an approval to share by the person whose information is theirs. And we say that information belongs to the individual. It may be necessary, but if the individual doesn't want to share it with an entity, that individual has the right and should have the right to keep that information private. And I'll end with that, Mr. Chairman, and thank you for the opportunity.
Thank you, Senator. New to New Hampshire, as I am very often, when I hear people come from a certain town, I conclude, oh, that's north of my district. So the chair would like to call somebody who's south of my district, Aaron Gray from Austin, Texas. That is south of my district. He has written testimony. Thank you very much. And would you please turn on your mic?
I appreciate it, Mr. Chairman and committee members, for letting me share our experience today. My name is Aaron Gray, and I'm the founder and CEO of Find Help. We are the largest closed-loop referral network in the United States. We work with just crossed 10 million users, and we're a public benefit corporation just a little bit south in Austin, Texas. We're proud to say that we've earned the trust of about 400 clients across the United States, including state governments, health and human services organizations, and many that do business here in New Hampshire. For example, AARP uses our network, the American Red Cross, the American Association of Family Practitioners, American Diabetes Associations, and several others. We're proud that we've been named Best in Class, which is the top performer in addressing the social determinants of health by class research, which is the consumer reports, essentially of health IT. We're here in support of the bill that was passed by the Senate. Many are asking, why does this matter? It's new. Much of this information is getting online for the very first time. Most of us are very familiar with what it's like to sit in a doctor's office and to sign a one-time consent if we're maybe at our family doctor's. And if you read the fine print of those one-time consents, what it says basically is that you allow your doctor to share your information with their partners. And these agreements are called business associates agreements, which allows for the transfer of information. And most citizens don't mind doing that because it's related to their health. And they all imagine a situation where they might show up to an emergency room unconscious. And at that point, they very much want that emergency room doctor to know about their medical conditions and their history. So in the healthcare world, they don't mind signing those one-time consents. But this world is very different. What we're talking about is social services that are now being digitized, and those referrals that used to be word of mouth and you would go to your local church and get help, but now they're being digitized electronically. And essentially the federal government hasn't caught up with matching the legislation. And so much of our users in these closed loop referral networks are not governed under HIPAA. So it could be somebody in the basement of a church that operates a food pantry on Wednesday night. It could be any number of affordable housing programs that now have access to information. And so what this legislation does is just allows for a per referral consent. If you think about it, there's a stigma associated in our times of need. So if any one of us have experienced trauma, or maybe we have a child with a criminal record or an addiction to drugs, protecting who that information is accessible to is really what this is about and what our experience has shown. If people don't trust essentially the system or getting help, then they're less likely to ask for help, and that will more often lead to more difficult circumstances, including unnecessary emergency room visits if they don't get enough food. And so I think the expectation is that if I meet somebody that is my social worker and they're helping me and I've built trust with that social worker, I'm more than happy to give that social worker consent to look me up and to see that history. But what we don't want is somebody that we've never met before on the other side of the state who is in a secure system, a valid system, with the ability to look somebody up like you would if they showed up to your emergency room and they're unconscious. And I think the previous speakers, who are far more eloquent and experienced than I am, spoke about that as best that could be. And so I guess just to sort of summarize, there are those that may make the argument that asking for this additional consent may hamper the coordination of care. And in our experience working with probably a couple of hundred hospital systems nationwide and 107 health plans, we haven't seen any evidence of that. It's basically trusting citizens enough to basically ask the question, hey, are you okay if I made a referral to organizations X, Y, and Z, and allowing that individual to basically say, I'm okay with X and Y, but maybe I have a relative that works at Z, and I don't want them to know about my business. And so thank you for the time. I'll keep it brief. Happy to answer any questions that you all may have today.
Representative Shapiro.
Thank you, Mr. Chairman, and thank you for taking this question. I understand why it's really important and good to have a per referral consent, because that protects privacy. But I'm curious, in the systems that you've created and run in different places, people are running in different places, how do how do the clients and how do the people who are referring, how are they become aware of what all the potential services are?
Thank you for the question.
Because you're kind of dependent on the person, the organization that you are dealing with to know about the other organizations.
Absolutely. Thank you for the question. Typically, when you roll out one of these closed loop referral systems, it is coupled with training in which the organization sponsoring the network will bring together primarily social workers and care coordinators within the community to let them know that these systems exist. And most of the systems allow a search functionality that allows somebody to anonymously put in their situation and say, I'm looking for an affordable housing program within 20 miles of my zip code. And so that lists all of the participants in the network. And then the social worker and typically the citizen will decide on which one they would like to be referred to. So that's one way of getting the word out, to let them know that, hey, we all have times of need, and here are some options that are available for you.
Thank you.
Representative Knirk.
Thanks. Mine's a follow-up on exactly what you just said. You said if they want to be referred to it and their social worker refers them. What about if that person initiates the contact themselves? They have not actually been referred, but they are aware of a program and they want to go there and they want to get involved and they've given their consent. Are they still able to participate, even though the language here says referred to that provider?
Yes, there's different use cases that are, thank you for the question, Representative. There's different use cases that allow for that. One is most systems have a public facing use case in which you can essentially put in your zip code and you can actually see which options are available to them. And so if that nonprofit or that agency is okay with accepting what's called an electronic referral, you can choose to connect yourself, which is usually based, at least in our system, I can speak for, it's basic contact information. And that puts you in the queue, if you will. And typically a social worker at that nonprofit will call you back or invite you to schedule an appointment with them.
So basically, self-referral counts as referral.
It does, yes.
Okay, thank you.
Yes.
Representative Gay.
Thank you. And I'm coming to Driftwood very soon. I wanted to ask, it sounds like this service provides much more than somebody's already a client of DHHS. So that was my concept. You're a client of DHHS, and now you need help with housing or some other services. But if all these organizations are part of the system, what if you just went? You didn't go to DHHS, you just went to the people who help with housing. Would you then be, number one, would you be permitted? And number two, would you then go into the system and you would, again, dictate with whom your personal information would be shared?
Thank you for the question, Representative. So let's take a couple of examples here, and we would welcome you in Texas anytime.
From
some
there.
Great barbecue, as you know. So specifically, using your example, maybe you had an interaction with DHHS because you applied for the SNAP program here in New Hampshire. You could have been referred to that program in a closed loop referral system like ours. And at that point, the person that would have access to the fact that you applied electronically to that SNAP program is going to be your care coordinator or your social worker that works with the state. But let's just say that you were denied that access. And for some reason, your income was too high or you didn't meet a requirement of SNAP. And then maybe a week later, you're a citizen and you went and applied for an affordable housing program. If you give that affordable housing program your consent and it's captured electronically, at that point, the social worker that you just met at the affordable housing program can see your history of referrals, but the person applying gave that explicit consent that's there. And I think your question is spot on, because that is why this issue is so important, because there are situations where, let's say, it would be, maybe it's less convenient to at least ask the citizen, hey, do you mind if I see your history? It might be, but it's just a question, so it doesn't hamper care coordination. And it's a trade-off in which you weigh inappropriate access versus, maybe one extra question the first time that you meet with that citizen. I hope that answers the question.
No, it sounds like you control.
Yes, the
person
citizen,
controls.
in a well-designed closed-loop referral system, the citizen at any time can see which organizations have access to their own information, and they can remove that access at any time. So I think that's the principle and the spirit of what the previous speakers were trying to put forward.
Seeing no further questions, thank you so much for your testimony.
Thank you.
Chair calls Carlos Uriarte, and correct me if I get your name wrong. And it also says 217 Broadway, floor 8, New York. So I do have a personal question for you as we begin. Yankees or Mets? Yankees or Mets?
Representative, I don't actually live in New York City. That's just where our office is.
Oh, you
based.
just put this on the card because
That's
it
our
looks cool.
Headquarters office, yes.
Got it. What a great way to dodge the question. Continue.
Anytime. Representative, thank you, and members of the committee, thank you for having me here today. Good afternoon, and members of the committee. My name is Carlos Uriarte. I'm Vice President and Regulatory Counsel at Unite Us. I'm here to express support for SB 423 and to share a perspective that SB 423 should be allowed to move forward without amendment to allow DHHS to begin the competitive RFP process for a closed-loop referral system in the state. In its current form, the legislation strikes a balance between regulating the future closed-loop referral system to protect privacy while simultaneously enabling the information sharing that is necessary to connect people with care. Unite Us, I'll just speak about us for a moment. We are a leader in deploying community-focused coordinated care networks to connect health and social care providers in a common ecosystem. Our goal is to ensure every individual can access the critical services they need to live healthy and happy lives. As was discussed earlier, in September 2020, the Department of Health and Human Services worked with Unite Us to launch a closed-loop referral system to address the impacts of COVID-19 and to combat the opioid epidemic. As Senator Rosenwald mentioned earlier, the contract terminated on its own terms late last year. Our work in New Hampshire has continued to grow despite the end of the contract and includes several hundred active community partners who provide services related to substance use treatment, housing, employment, mental health, and more. By creating infrastructure that securely connects providers on a common platform, we promote efficient and accountable coordination of care, with data showing that 94% of referrals in the state are acted upon within days. Certainly. So the reason I wanted to touch on that is because as some of the other speakers were talking about earlier, can you hear me okay? Great. As some of the speakers were talking about earlier, right, this is a change, this technology is a change from what we've previously done and allows us to much better control the flow of information. It allows us to break down those silos between health and social care. It allows us to get people connected to care and to improve privacy at the same time. So if you allow me just for a moment, I do want to read one quote here from one of our members. Adam Moulton, who's the director at Reverence House in Laconia, shared that in order for a client, or in my case, a resident, to get the highest level of care necessary, there needs to be solid communication and interconnectedness within all of the resources. We are unfortunately suffering from extremely terrible mental health and drug epidemic. So allowing that communication and interconnectedness and really creating a 360 approach for all of my residents is necessary. It has to happen. So with that, I'll just say that we recognize that we appreciate the work that the committee, that the members have done on SB 423, and we think it strikes that right balance to enabling that information sharing while simultaneously protecting privacy, and hope that we can move forward expeditiously to get to the RFP. Thank you all.
Would you take questions? Any questions? Representative Soloway.
Thank you, Mr. Chairman. Mr. Uriarte, welcome. By the way, the correct answer to the chairman's question is, oh no, I'm a Red Sox fan. I assume that you have seen similar legislation in numbers of other states. Is that correct?
Representative, thank you for the question. We have seen a couple of other states consider legislation in this area. That is correct, but no other state has passed legislation on this point. In fact, what we have been working through over the past number of years is the different pieces of legislation that do protect privacy, both at the federal and state level, which does cover a lot of this activity. So, for example, there's current rulemaking at the federal level under HIPAA to address this point, as well as most state consumer protection laws do address certain aspects of information sharing in a closed-loop referral system as well.
Oh my God, Mr. Uriarte, you've indicated that we are ahead of the curve. Thank you.
Thank you.
Representative Knirk.
Just a quick question. This may have been a better question for Representative Edwards, but I didn't think to ask it. You might be able to answer it, though. In the bill itself, on line 15 through 18, it goes into the issue about how the request for permission has to be phrased, and it talks about do you consent to have access to personally identifiable information and so on and so forth. But it never explains the downside if the person doesn't participate. In other words, if they opt out, what are the downsides? And my question would be, when we have a system in place, it allows a rapid transfer of information. If the person opts out, I would presume there may be delays in them being able to access some of the services, and that may cause insurance problems or access problems. Is that correct, that there'll be a delay if they do opt out? And if so, do you think that information should be on this request so that they understand the downside of opting out?
Well, if I could, I can answer that in maybe two parts, right? Because one piece of it is simply the standard consent that is necessary for someone's information to be shared on a closed loop referral system where DHHS is not involved in providing services. And in that instance, there's no reason why the social worker or case manager couldn't use the system to pull up information about the organization that can potentially provide services to the individual, share that information with the individual, and connect that individual with the organization. So that should be minimal additional delay if that's the course the individual preferred. When DHHS does need to provide services, of course, there would potentially be some delay. I would defer to the agent, to DHHS on that, but obviously it would just mean that the information would have to flow to the agency in some other way.
Thank you for your testimony.
Thank you.
Hope you get to Fenway sometime soon.
I appreciate it.
He's good. Chair recognizes State Representative Maria Perez, representative from Milford.
Good afternoon, members of the committee. Thank you for letting me speak. I'm here to speak in support of the bill. This bill will protect the privacy of members of our community, especially when we talk about referrals with people who comes with a different language background, different cultures. It is critical for us to protect the privacy. The information of these individuals get transferred from different individuals, especially when we're talking about translation, especially when we talk about paperwork. It is critical for us to protect the privacy, but it's important for us to have these referrals done as quickly as possible, especially when we talk about mental health, when we talk about food insecure, anything that it has to do with human rights, anything that has to do with critical conditions on a human being. I believe that this bill will help us to close that loophole of information between one entity to the next one. But it is critical for us to protect the privacy of our citizens.
Thank you so much. Appreciate your coming.
Thank you.
Chair recognizes the Honorable Neil Kirk of Ware, one-time Chairman of Finance, and my predecessor as the punster of the House.
Never your predecessor, sir, just your follower.
Ooh.
Good afternoon, Mr. Chairman, members of the committee. For the record, I'm Neil Kirk. I live in Ware, and I'm representing myself. I'm in strong support of this bill. The Senate worked hard, Senator Rosenwald especially, to get this to where it is now. The bottom line on this bill is that it puts the individual in charge of deciding which medical and social service providers get to see his or her personal information and medical information. It does it in 5 ways. Number 1, the individual can decide which information goes into the CLRS and is given to a particular provider. Number 2, the individual must on each occasion decide whether or not this information is to go to a provider. It's not a single consent that covers everything. Number 3, the service providers, the members of the system, cannot access an individual's records unless 2 things happen. Number 1, they're providing a service, and number 2, the individual consents to give them this information. Again, the individual is controlled. Fourthly, it gives the Department of Health and Human Services access to personal and other information for the clients for whom they are financially responsible, for example, those on Medicaid. But no other state agency, no other state organization can have access to this information. Hence, this is perfectly consistent with and an example of how the legislature should interpret the Constitutional Informational Privacy Amendment, Article 2B. I can't think of a better bill, a better way to protect personal privacy, consistent with that amendment, which, as you know, was passed by over 80% of the people, than has been done in this bill. The individual is in charge of his information, and that's the way privacy should work. Thank you very much, Mr. Chairman. I hope the committee will approve this expeditiously. I understand you do have some deadlines.
We do. Any questions? Thank you so much.
Thank you, Mr. Chairman.
And this concludes our hearing on Senate Bill 423, and I kind of think we pretty much, if I may assume, let's honor what he said, and I'd like to open the exec session on 423, and the chair moves ought to pass, and Representative Soloway, who is also on oversight, is seconding it. Any discussion? Representative, no, I know that, but Representative McKay, your job is first to turn on the mic.
No, it's
It's all done. Well done. I
All
like it
done.
when a plan comes together. Representative Snow.
Yeah, I was hoping one of the speakers would at least talk about how this service is paid for. Is this a charge that goes to the individual looking for the referral, or is it paid for by the various agencies that are participating in it? I don't have any idea how that works.
Senator?
Thank you. The individual would never pay for it. The original contract was paid for using CARES Act funds. I think it was $750,000 maybe for that contract that later expired, but the individual would not be responsible for the costs of this system.
Any further discussion in the committee? Representative Mooney.
Thank you very much, Mr. Chairman. I apologize for coming in the middle. I was testifying on a Senate bill, but was a timeline discussed at all with regards to this bill and implementation of the program?
Yes, the bill is effective on passage, but it doesn't actually address the issue of whether or not the department will contract with a closed loop referral vendor. It just sets privacy and security parameters around such a system if the department chooses to move forward.
Thank you, Senator.
Thank you.
Any other discussion? Seeing none, here's the question. The question before us is ought to pass on Senate Bill 423 FN relative to a closed loop referral system in the DHHS. The motion OTP made by the chair and seconded by Representative Soloway. The clerk, please call the roll.
Representative Leon.
Yes.
Representative McMahon.
Yes.
Representative Acton.
Yes.
Representative Gay. Representative Mooney.
Yes.
Representative Folsom.
Yes.
Representative Bohm.
Yes.
Representative King. Yes. Representative Kofalt.
Yes.
Representative Delamus. Representative Weber.
Yes.
Representative McKay.
Yes.
Representative Snow.
Yes.
Representative Knirk.
Yes.
Representative Salloway.
Yes.
Representative Cannon.
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro.
Yes.
Representative Woods.
Yes.
Representative Query.
Yes.
And Representative Pearson.
Yes.
It's unanimous.
I move consent.
Absolutely. Consent. And I get to write the blurb. 21 to nothing.
0.
And this ends the exec session on House Bill 423 FN. And we now open the hearing on Senate Bill 283 relative to membership of the Council on Autism, Spectrum Disorders, and the Developmental Services Quality Council. And I lost the pink card stack, but I know that Grant Bossy will be speaking for Senator Avard. And Mr. Bossy, I miss your column in the Union Leader.
Thank you very much, Mr. Chairman. To anticipate your question, the Sox just went up 4-3 in the 8th in Detroit.
Thank you very much.
Good afternoon, Chairman Pearson, members of the committee. My name is Grant Bossy from the New Hampshire Senate, here on behalf of Senator Kevin Avard, the bill's prime sponsor. He appreciates the courtesy in letting me introduce the bill on his behalf. This bill, slightly less complicated and probably less time-consuming than closed-loop referral.
Your lips to God's ears.
SB 283 revises the membership of the Council of Autism Spectrum Disorders and the Developmental Services Quality Council. Both councils have been having trouble meeting their statutory membership requirements due to changes in the autism landscape over the last decade. Some organizations no longer exist. Some exist under certain names. There were 3 members coming from the Department of Education, and they generally just send one. SB 283 will address those needs. The committee amendment clarifies that additional members are nominated by the councils, but in fact appointed by the governor. Further clarifies the quorum requirements for the councils, which are not currently in the statute. SB 283 cleared the House Health and Human Services Committee on a 5-0 vote and the Senate on the consent calendar. And if the committee thought it appropriate, we would anticipate possibly similar treatment on
To
this
correct
side of
for
the
the
ball.
record, it passed the Senate committee.
Senate,
5-0.
I'm sorry, yes.
That's okay.
So,
We have more of us.
There was no opposition to this bill in the Senate. We would not anticipate any opposition and would ask for your support of Senate Bill 283.
This is what used to be called I won't say the term that may not be uttered, kind of, but it would be one of those. Yes. Any questions? Chair recognize. Thank you,
Thank you.
Mr. Bossy. The chair recognizes Sarah Aiken-Kotrubis. How'd I do? Close? Oh, good. From Concord, the Autism Council, NHDD Quality Council. Welcome.
Is that better? Good afternoon, members of the committee. For the record, my name is Sarah Aiken-Kotrubis. I too am still learning how to say it. But
the way you pronounce Sarah was very well practiced.
Thank you.
You're welcome.
Thank you. My mom and dad would be very pleased.
Well,
I am here representing both the Quality Council and the Autism Council. I currently sit as the chair or co-chair of the Autism Council and the immediate past president of the Quality Council. And Mr. Bossy did an excellent job, so I will not bore you with any further details, but I am here to answer any questions. This really just cleans up everything and allows us to fulfill our meetings in terms of a quorum.
Representative Nutter Upham.
Thank you for taking my tiny question. How often do you meet?
We meet monthly. Both councils meet monthly.
Okay, and do you have to produce a report for anybody?
Yep, we produce an annual report and gets submitted to the governor's office, typically the leadership of both the House and the Senate, as well as the Health and Human Services Oversight Committee.
Okay, thank you very much.
Anyone else? Representative Bohm.
Thank you. If I'm reading this right, as amended, the bill also quotes what a quorum will be.
Yes, sir.
Thank you.
Good, thank you. And that's all the cards I have. So I close the hearing on Senate Bill 283 and open the executive session on the same. And the chair, since I work a bit with Regions 9 and 10, happy to, would like to move ought to pass. And looking for a second, Representative Cannon. Any discussion? We might get on, nope, not going to say it. No, that which must not be uttered. Call the question then. The bill motion is ought to pass on Senate Bill 283 relative to membership of the Council on Autism Spectrum Disorders and the Developmental Services Quality Control, moved by the chair, seconded by Representative Cannon. Would you please call the roll?
Representative Leon.
Yes.
Representative McMahon.
Yes.
Representative Acton.
Yes.
Representative Gay. Representative Mooney. Representative Folsom, yes. Oh, I didn't hear your answer. Sorry.
Mooney votes yes.
Thank you. Sorry.
Mooney Blue.
Got a little excited there. I have to do this each session.
She's gotten rusty today from.
Rep Bohm.
Yes.
Representative King.
Yes.
Representative Kofalt.
Yes.
Representative DeLamus. Representative Weber. Yes. Representative McKay. Yes. Representative Snow.
Yes.
Representative Knirk.
Yes.
Representative Soloway.
He would say yes if he were here, but he isn't here, so.
Okay. Representative Cannon.
Yes.
Representative Nutter Upham. Yes. Representative Shapiro.
Yes.
Representative Woods.
Yes.
Representative Query.
Yes.
Representative Pearson.
Yes.
20-0. Passes.
20-0. Consent, unless there's an objection, and thank you very much. Now, a handout that these things are just sort of dribbling down. This is for another bill that we've already passed. This is a amended fiscal note to the closed loop system.
First we
for
get it now.
your records. We've also just been given a amended fiscal note for 430, which is what we're looking at next. I think I got a few more of these. 430 is coming along to you. In addition, there is a side-by-side report on 430 provided by our friends on the fourth floor. I've only got one. I think I may have given you too many. I'm not sure.
Mr. Chairman, could you explain the side-by-side, given that we haven't done anything with it yet? It's a side-by-side what and what?
I'm not quite sure. I don't. It isn't a side-by-side. It's a DHHS summary with amending of the RSA and footnotes. So thank you for that clarification.
We're very short on that on this side.
We may be very long over there. This is what they gave me.
You can come up. Come on, fight.
In a minute, we're going to be introducing in a minute, we're going to be introducing 430. So get your materials on 430 ready. Nope, I just introduced it. All right. Open the hearing on Senate Bill 430 and thank you, Representative Weber.
Thank you, Mr. Chairman. I am here this afternoon to introduce to you Senate Bill 430 FNA relative to Health and Human Services as a courtesy to the sponsors, and I fervently hope that no one will ask me any questions.
Thank you. Seeing none. For the benefit of everyone, we're going to use the procedure that we did with great success last year when DHHS had a bill with multiple parts. We had John Williams, the liaison to our committee, walk us through. It's also important to know, as it always is, we get emails sometimes about a bill and the bill's already been changed. And so while the emailer is very earnest, the email is now speaking about past events. There are a few items in the bill, as we will be walking through it, that will almost assuredly not be in the bill that we vote on by not only wide consensus, but also by the department. And that may mean that there are a few of you who have come here to testify against certain items that will most likely not be in the bill anyway. I just want to let you know that this is how the process works. You jumped in when you jumped in, and things continue to evolve. And I'll tell you, I've been confused by that many times. And since I'm confused right now, I'm going to call on John Williams to walk us through the bill.
Chairman Pearson and members of the House Health, Human Services, and Elderly Affairs Committee. For the record, my name is John Williams. I'm the Director of Legislative Affairs for the New Hampshire Department of Health and Human Services. And for those who are in the gallery, Section 15 of the bill that is in response to a recent New Hampshire Supreme Court decision as it related to one of our program areas, the Division for Children, Youth, and Families, but a whole host of other interested stakeholders, that we're respectfully requesting that that section of the bill be removed from legislation so that we can work with key stakeholders over the summer on that language. There are references to Child Protection Act throughout the bill. This is specifically Section 15.
No.
This does not involve.
So that
Mr.
page
Chairman.
5, line 6.
paint.
Page 5.
We're
line
getting
6.
ahead of ourselves here. That's just the tease.
And thank you, Chairman Pearson. The reason why I mentioned it, I'm aware that people were very concerned about that section. I just wanted to clarify that. And Senator Bradley, had he been here to introduce the bill, he would have made note of that as well. So, starting as we did last year, and I will be asking committee's indulgence, I have, for the clerk's purpose, included all of the department representatives that will be assisting me today to go over the sections. I am available to answer questions, but it may be, unless there's something extremely urgent, please direct and let me know to stop, and we can answer and respond to questions by grouping of the sections of the bill. So starting off with sections 1 and 2, this involves our department's administration and oversight over the opioid treatment programs in the state. And what we're looking to do is to allow those fees collected from those entities to be used by the department to actually to fund that portion of the program, or at least contribute that. Currently, those funds go into the general funds and not seen by the department for administering this important program, so we think that it's actually a good thing. And it would create a non-lapsing special account for that. That takes us to sections 3 and 4 of the bill, respectfully, that deal with a pilot project under our Bureau for Developmental Services to provide for those specific individuals who receive developmental services between the ages of 18 and up to 21 who do qualify for services but are no longer under the ability to receive funding through school districts. It creates not only a pilot program, but it also provides for a general fund appropriation of $2.8 million for the state to do this. We cannot qualify for matching federal funds because there is a cap and limitation of the numbers that can be served, but certainly the Senate saw the value, and we're here today asking you for your consideration as well on this important pilot program, because there is a gap currently for that age group and for those kind of services for those 18-year-olds to 21 who are no longer receiving services directly from schools. So that now takes us to sections 5.
Do we have any questions thus far? Representative Gay.
Thank you. On section 1, why is this, is everyone going to say non-lapsing or lapsing? Because this one says non-lapsing, so is that a new service that we want to put in the budget for continuous providing?
The short answer to the question is yes.
You may continue.
So that takes us to sections 5 and 6 of the bill. This is part of the department's ongoing inventory of a review of our reporting requirements. One of the when you're reviewing something like this, the problem is you're seeing a repeal, you don't see the underlying language. So I certainly understand if the committee has questions as to what we were trying to accomplish around those sections. Under the first one, under Roman 1, under section 5, which is on page 3, line 7, it would repeal RSA 126A 4A relative to the health care plan report. And the reason why the department's looking to repeal that, because you may recall that the legislature passed the state health assessment, the state health improvement program group that is earnestly working on this issue, and their assessment in the report actually goes broader. It includes what is in the scope of this report, but it's actually broader in the scope of this report. So it's a duplicate reporting requirement. So we're just respectfully asking that you allow the current one under RSA, I want to say 126A 87, around that area. I'm probably only off by one number, I bet. But there is a very robust reporting requirement around that under the Shaw ship, not to have any redemption. So the next one under
Come on.
So section 8 of the bill, Roman 2, 2019 chapter 346 colon 348, that is actually part of HB4, which was a trailer bill to the budget back in 2019. There was a reporting requirement for Henry Lippman's shop that actually we've complied with the reporting requirement, but there's still, even though we've complied with the reporting, yes.
Could you hold for a second? Yes, please.
Did we skip sections 6 and 7? Because we seem to have gone from 5 directly to 8.
I was referring, I apologize. I was referring to line 8 in section 5.
Oh, I'm sorry. Thank you. I appreciate
Please
that.
continue.
So this here is a chapter law from HB4 as part of the budget, and it was a reporting requirement regarding Medicaid rate increases. We've already done the rate increases, but because of the fact that there's a quarterly reporting requirement, we would have to have legislation to actually remove that provision. Section 6, you'll see what is in current law relative to Medicaid and family planning. This was established well within about at least 5 to maybe 8 years ago. And what we would like to do is at least remove the annual reporting requirement, because we really have fulfilled the underlying informational providing to the legislature. I do have Mr. Lipman here, although this also falls under Director Tilley's under public health, their provisions under the bill. We respectfully kept the underlying provisions around family planning and wanted to maintain that. We did not want to touch that, so that's why we treaded very lightly with only removing the annual reporting requirement. Section 7 of the bill involves the Child Protection Acts and issues of notices. And at this time, I'd like to bring the wonderful, if she is in the room with us, Attorney/Director Rebecca Ross. Whoa, okay.
Good afternoon, everyone.
Closer to the mic, please.
Yes, thank you. For the record, Rebecca Ross, the Director of the Division for Children's Behavioral Health and previously General Counsel to DCYF, and here for Joe Ribson today on this portion of the bill. Section 7 and 8 look to amend the notice provisions and bring them in line with other family division notice provisions to allow service when we're unable to locate a parent and provide them either in-hand service. So the court could use its discretion to provide other means that are commonly used in other forums to provide that necessary service for due process.
Continue.
All right. Yeah, so moving on to sections 9 through 14 are relative to foster care. New Hampshire does not specifically define kinship or have a process for licensing for relatives and kin. And where we know that there is a shortage of appropriate foster homes, it seemed reasonable to set up a licensing process that is tailored to family and individuals known to a child or youth, and starting by defining what kinship is in New Hampshire consistent with federal law, so that we can provide the same supports and services but in a way that's tailored. So for example, a license could be issued specifically for one 17-year-old child versus a generic license for 6 unknown children to a family member.
Is the bringing in of fictive kin a broadening of what's on the books now?
Yes, right now fictive kin could do it by way of the current licensure process. We're looking to make it easier to do that.
Thank you.
Fictive kin would be someone who seems like a family member, is close to the child and known to them, but not actually legally related. So that family friend that you call auntie, that all of a sudden you're living in their home.
Representative Shapiro.
Thank you, Mr. Chairman. Could you give an example of how licensing for relatives might be expedited?
So we still have to issue the same license under federal guidelines. We can't make it a lesser license, but we can work on the process. So making sure that the forms are appropriate to someone who knows the child that's moving into their home, and really works on licensing specifically for that child. So tailoring it to narrow the extraneous parts that are unnecessary.
Representative Gay.
8.
Yes.
Grants the department guardianship of a child following surrender of parental rights. I've been contacted by a person who wants to adopt or at least take care of a child that she's been taking care of for several years because the parents just aren't there. And she's extremely concerned that instead of her being placed in line for official guardianship, that the child's guardianship would be given to DHHS.
So that is an extremely specific question and scenario. I think that what this is looking at is specifically to if a parent chooses to surrender or both parents choose to surrender, what is left, not necessarily looking at the process of who else is involved in that.
Could you be more specific?
I think respectfully, that doesn't go to the language that's in this statute. I'm happy to have a conversation with you online, but I think it's probably a lot longer offline. It's probably a lot longer conversation than we can do right now.
Is that an honest
Would you wish to
summary?
follow up?
Yes, thank you.
Please.
Yes. Is this accurate? The summary grants the department guardianship of a child following surrender of parental rights under RSA 170B.
Yes. And prior to this, what was in the statute or what's currently in the statute is care, custody, and control, which is something that doesn't exist anywhere else and is short of guardianship. So the child is without all of the same supervision or someone with the rights to take care of them. So they're left almost without someone caring for all of the parts of the person. So this just aligns it with that it's guardianship once the parents have surrendered, not something else that isn't otherwise defined.
Any other questions? Please, Representative DeLamus.
Thank you, Mr. Chairman. Just to follow up on that, because it does seem, it looks to me on the first page, grants the department guardianship of the child, that's the first choice, that's what happens first, and then you go to kin after that. And I don't know whether or not that is true, and if not, why has this been put in here in that way?
So these are two separate and distinct provisions. When a parent chooses to surrender their parental rights to DCYF, they've made that choice. They haven't identified another family member or guardian through the private guardianship process. So that would be specific to when they're already at that place that they're surrendering to DCYF by choice. DCYF would always be looking even the next step to find that appropriate relative if they've gotten to that point. Right. Hopefully before, if not, continuing after. You're welcome.
Representative Weber.
And just so we're really clear, that first page is just a summary analysis. It does not actually say what the bill says, which we will get to in due course.
That's correct.
You may continue.
And Representative Pearson, we've already addressed the issue of Section 15 that the department respectfully is requesting that this committee come forward with an amendment to remove that section of the bill. We'll work with stakeholders over the summer.
I have an amendment in hand to remove 16.
Okay, so we have 15, and I understand also Section 16 as well. But 16 is in here, and if we could just indulge you briefly with just
Sure.
a overview on the why we requested it, and this is dealing with the addition of guardianship of the person as it relates to RSA 170B11 and issues of surrender.
This is where I was going to after kinship, and truly is looking to change it from care, custody, and control when we get to that situation to legal guardianship, so it's consistent with other parts of the law, and DCYF can act in the best interest of the children if the parents so choose to do that. And that's what would happen under the termination of parental rights statute. And it's essentially the same circumstances, and the department's requesting that they read the same and operate in the same way.
You may continue.
Thank you very much. And
yes, Representative Weber, sorry.
Just so I am understanding what the intention of the chair is, my understanding is there is an amendment coming which removes section 15, which is lines 6 through 11 on page 5. Is that correct?
That is correct.
And are you explaining that there is a further amendment coming which will also remove 16?
That is also correct.
Okay, thank you very much.
You're welcome. I'm sorry, I was off on a daydream.
Point of it, do we have the amendment for removing 15 already in hand or not? Be-
This is a process issue, and I'm going to.
We're gonna, I don't know how to answer that right now.
No, but I mean, we don't have it in hand.
You don't. But we're not in exec session.
No,
just
I know,
yet.
but my question was, should we be doing something about that? So we can get, before we get, when we're still young, we can get this finished.
I'd like us to move on, please. I'm not prepared.
Thank you so much.
Could I ask just a quick question about that section?
I would rather we defer. We have other people who are going to speak to that. Section 17, please. I may have spoken too soon.
And Chairman Pearson, thank you very much. Moving along to section 17 of the bill, this is at the request of the Division for Medicaid Services, and it involves a multitude of our program areas. What it does is it identifies as a policy statement, I'll repeat, as a policy statement, the importance of preventative health care. And you'll see that the effective date specifically on this section is for June 30th of 2023. The reason why it was placed at that date was to address the cost issue as part of building our budget for state fiscal years 24 and 25. So therefore, because it doesn't take effect until the next biennium, it would not have a fiscal implication for this biennium. We were very careful to work out the wording around the effective date, knowing that this would have to be the policy articulation first by the legislature, and we're going to follow it up with a budget request in the 24-25 budget. If there's no other questions regarding that section, we're now up to sections 18 and 19, dealing with very important programs that serve disabled adults who are employed, and they receive medical assistance in the form of Medicaid from the state as to help offset some of the costs that allow them to be employed. So this is a very great population of people who want to work, and this is a program to assist them on the medical piece of it. I do have with me attending today Meredith Toulouse. She is a director within our program on integrity and improvement. If I could just have her come up to respond to questions why this essentially from a policy position might make some sense to you, but also from a budgetary consideration might make some sense.
Good afternoon, Mr. Chair and members of the committee. My name is Meredith Toulouse. Not sure if I'm close enough to the mic. Thank you, John. I am the Director of Program Quality and Integrity for the department, and we have the responsibility of collecting the premiums for these two programs currently. The two programs are MEAD, I think you said this, John, which is the Medicaid for elderly adults with disabilities, and MODE, Medicaid for older adults with disability programs. There are approximately 2,700 people on the MEAD program and about, I think 130 on the MODE program. Out of the, so for a total of around 300,000, out of that total, only about 180 qualify to pay a premium. So we have not found it to be a cost-effective part of the program. We're capped by CMS. There's some very strenuous limitations on what we can charge for a premium. So the average premium that we charge is around $70 a month. And when you do the math, that works out to about $120,000 a year of total funds. So that would be $60,000 of general funds that come to the department. Meanwhile, I have 4 individuals who have to touch this program at various points. And those 4 individuals, we believe, would be much better, their time would be much better spent. We'd get a lot more value out of this if they were actually doing oversight of our managed care organizations who are in charge of third-party liability, which makes Medicaid the payer of last resort. The managed care organizations are responsible for ensuring that our Medicaid population, Medicaid's the payer of last resort. We have not had time to audit the MCOs. We do oversight. I don't want you to think we don't. We do a lot of oversight of them, but there's more we could be doing with these same 4 individuals if they were not spending time billing people and receiving invoices and processing payments. So we just haven't found it to be a very cost-effective part of the program, and that's why we suggested the language as a policy change. Happy to take questions. Okay, Thank you very much. Oh, there might be one.
Representative Snow.
What did you say? Excuse me. Me and my microphone. Under the MEAD program, which is Medicaid for employed adults with disabilities. Now, when that was originally put in, the reason it was put in to have a premium charge is so that as their premium gradually increased, to kind of phase them once they grow out of the program, being used to paying premiums for health insurance like all the rest of us do. And it seemed to me to be a good idea. We used to run a sheltered workshop, and it worked very well for us when we were doing that by moving. As they moved up and earned more money, they paid higher and higher premium and weren't so shocked when suddenly they had to pay for health insurance. But you said there was only 4 people now that are receiving benefits under this?
No, I apologize. About 2,700 people are receiving benefits under the MEAD program.
But how many are paying a premium?
About 130
Okay.
are paying a premium today. So I think I understand the question, but as it turns out, because of the way the premiums are structured, we have to deduct all of their other medical expenses and any other premiums. Many of these individuals are also on Medicare, and once you include their Medicare premium, there's not a premium left for them to pay in this program. Does that answer the question? I hope
Well,
that
it does.
answers the question.
There's still a benefit to doing it, but I can understand why it apparently isn't terribly there are problems of doing it. I do understand. I still think it's a good idea.
Chairman Pearson and committee, moving along, we have sections 20 through 24, which relate to the same issue. We have occasions where individuals are seeking long-term care, and the institutionalized spouse is placed in receiving benefits from the state to support their medical assistance. All these sections do is provide the department with an opportunity upon motion to the court to provide them with information. That's solely, it doesn't change anything else about the underlying statutes, but for us to provide information, we may have information over exploitation of the spouse that is in the institution and other information that the court could benefit from in terms of making appropriate orders. So it was something in the House that at least the attorney who was sitting on the Senate committee was fine with this recommendation and understood it. And that's really mechanically all it does. It doesn't give us standing, it just allows us to provide information to the court, which we think is helpful. As to the next section, we're dealing with section 25 of the bill, which I have brought Mr. Director Lippman, and I'll have Henry review that section.
Good afternoon again. For the record, Henry Lippman, Medicaid Director. This technical difficulty. Thank you. Can you hear me okay? Okay, good. Okay. As I think folks are aware, that there's a significant healthcare workers shortage in providing home and community-based services, particularly personal care. And as a result of that, we had many approaches by family members who were difficulty lining up people to come into the home. Sometimes it was because they had compromised individuals that they didn't want to have exposed to outside purposes. So we had the opportunity through the public health emergency to apply for what we describe as an 1135 waiver to allow personal care to be delivered by certain family members, and to be paid for that service. Right now the system kind of depends on that today in terms of the workforce shortage, in terms of meeting individuals' needs. When the public health emergency ends, this type of waiver goes away. The department is applying for a different type of waiver to be able to try to continue at least some of what we're able to do today, but getting that in place and whether we'll get that is an unknown at this point. We ask that money this $700,000 be put into the this legislation in the event that we're unable to secure an alternative because it'll be a great cliff for family members that are relying on personal care if we don't get those other waivers. And so what we're asking here is to have this money available to the extent that nothing from the federal government is able to be in place so that we don't have this cliff of personal care occurring. I don't know if that's helpful. Happy to take any questions.
Any questions on 25? Representative Soloway.
Thank you, Mr. Chairman. Thank you, Mr. Lippman. Could you tell us, do other states have successful programs to do this?
I'm not sure how many states have this option that we had. I know that we were early in terms of getting this in place. It is allowable under this part of the federal act for public health emergency. I would mention that in order for someone to be able to be paid for these services, they have to go through a process to be screened like any other individual to make sure that they wouldn't be excluded from participating in the program. And there's certain training so that, for example, a parent who may be caring for a event-dependent child doing the personal care, that there has to be some competencies shown to be able to do what they're being paid for. I think it's really, without this, we'd have a lot of families in trouble.
Thank you. Next section.
Section 26 of the bill deals with the current look-back period for assets as it relates to eligibility for long-term care. The bill, as introduced in the Senate, actually had a provision for a sliding starting at 36 months and then going out to 60 when the department thinks there are facts needing to pushing it out. Respectfully, the Senate's position, as reflected as the bill came to you, is current law, which is the 60 months. So it doesn't change anything about current law. They could have taken the section out, but they didn't. Respectfully, they did leave at least for us the bold italics 1, 2, 3, 4, 5 words in the introductory, but it does not change the current status of law. And with that, I'd like to invite, thank you very much, Director Lippman, and I'd like to invite Michael Holt up for the next sections, unless there were questions on Section 26. Sections 27 through 31 deal with our department's therapeutic cannabis program, and as you know, Mr. Holt is the head and charge administrator for that program and is here to review those respective sections with you.
Thank you, John. My name is Michael Holt. I am the Therapeutic Cannabis Program Administrator for the Department of Health and Human Services. This bill would do two things. First, it would remove the criminal background check requirement for designated caregivers. And second, it would modify the criminal background check requirement for alternative treatment center agents. So the first part regarding caregivers removes the criminal background check requirement to become a designated caregiver for the therapeutic cannabis program. The criminal history records check requirement for caregivers is an undue administrative burden and cost. The cost is $48.25. Previous federal background check results, regardless of how recently they were taken, cannot be transferred to a different purpose. This past summer and fall, it was taking up to 6 weeks to schedule a fingerprinting appointment and receive the results. The cannabis program has a 15-day statutory deadline to approve a designated caregiver application. The preferred method of getting fingerprinted is an online appointment payment portal administered by the Department of Safety. This is a technological barrier to some of our clients. The proposed legislation would eliminate all of these problems. There are about 600 registered designated caregivers in the state, serving approximately 13,000 registered qualifying patients. Patients are not required to undergo a criminal background check for this program, and there's no practical purpose for a different standard to be applied to their caregivers. Most caregivers are a patient's spouse or family member. Most caregivers are caregivers because their patient is too sick or incapacitated, or they lack transportation. Essentially, they cannot make it to a dispensary on their own. It's unclear what practical protection the current felony prohibition to be a caregiver is. New Hampshire law statutorily prohibits any semblance of a business model to be a caregiver. Home cultivation is prohibited. Selling cannabis is prohibited. The number of patients per caregiver is 5. A caregiver cannot charge a patient more than actual costs. These are all provisions in the current law. Fewer than 20 caregivers have more than one patient. There's not a business model here. This proposed statutory change supports the 2019 LBA performance audit recommendations by reducing the administrative burden for client applications to the therapeutic cannabis program. This proposal maintains safeguards that are in the law. It maintains the felony prohibition on caregivers. It just removes the background check requirement. It adds the requirement for an annual attestation of no felony conviction for caregivers. It maintains the requirement for immediate notice to the therapeutic cannabis program upon conviction of a felony. I received written testimony from a New Hampshire resident who could not be here today. Jennifer Deslodges, Plymouth, New Hampshire, applied to be a caregiver for her husband. Her husband was unable to use his registry ID card because he was too ill to travel to a dispensary to purchase cannabis products. It took Jennifer a month to get a fingerprinting appointment, and then another month for the results to be processed and sent to the therapeutic cannabis program. She finally received the caregiver card in October. Her husband had passed away the previous September. The second provision in this section is regarding ATC agents, Alternative Treatment Center agents. These are the entities that cultivate, produce, and sell therapeutic cannabis to patients. This bill would maintain the felony prohibition and state and federal criminal background check requirement for these agents. However, it would allow the option for conditional employment while the criminal background check process is being conducted. Again, during the summer and fall of 2021, the time to secure a fingerprinting appointment and receive results was up to 6 weeks. ATC has reported that they lost viable candidates for employment due to this delay. A conditional employment clause in statute would protect against such delays in the future and allow ATC agents to hire qualified candidates in this tough employment market. The proposed legislation would maintain the following safeguards: maintain the felony prohibition and background check requirements for these agents, require an attestation of no felony conviction upon conditional hiring, and require immediate revocation of the conditional employment upon receipt of a records check that shows a felony conviction. I'm happy to answer any questions.
Representative Gay.
Thank you very much for taking my question. What do ATCs do besides purchase for the people, and who pays them?
ATC stands for Alternative Treatment Center. That is the name given by the New Hampshire law to cannabis operators. New Hampshire law allows for a maximum of 4 licenses. So there are 4 licenses, ATC licenses. And these entities cultivate cannabis, manufacture cannabis products, and dispense cannabis products to the patients.
Follow up.
They are called the first section of this bill deals with these people. The law calls them designated caregivers. And so a qualifying patient, someone who's eligible and has received a card, has the opportunity to designate a person called a designated caregiver with respect to this law. That person would separately apply to the program for their own card, their own cannabis card. With that card, they are permitted to legally possess cannabis, not use cannabis because they're not a patient, but legally possess cannabis and purchase cannabis from the ATC on the patient's behalf. They are not paid. There is no payment for this. Like I said, those caregivers are permitted by law to only charge the patient actual costs for their services, meaning the actual cost of the cannabis product itself, and perhaps gas money to get to and from, perhaps tolls.
Any
There's-
further questions?
This is a volunteer program.
Representative Bohm.
Thank you. I got a question on why is it taking that long to get a background check when I'm normally in the education committee and the DOE and the schools are doing it a whole lot faster than that. So I'm just concerned why it's taking your group that long to get a fingerprint check.
As I said in my, thank you for the question. As I said in my testimony, this was the case last summer and fall, post-pandemic, that drastically increased the time that it was taking to get these results to us. That process has stabilized, and and we are no longer getting complaints due to perceived lengthy periods of time. I don't know right now the length of time that it takes because we, the department, have no visibility into when a caregiver gets fingerprinted or tries to set them up an appointment. I do know that we're not getting complaints from caregivers that it is taking an inordinate amount of time. But that period of time was the impetus for this legislation, but the process at Department of Safety has stabilized.
Representative Acton.
Thank you, Mr. Chair. And thank you, Mr. Holt, for the question and for years of dedicated service you've put into this program. By removing the background check, that removes the $48, but it leaves in place the $50 administrative application fee. Is that correct?
There is a $50 application fee for patients to apply to the program. Last year, the department went through administrative rulemaking and removed the $50 application fee for caregivers.
Okay.
Right now, there is no fee for a caregiver to apply to the program to the department. However, there is a $48.25 fee for the background check.
Okay. Thank you.
You may continue.
And Representative Pearson, thank you very much. That takes us to section 32 of the bill, which is at the bottom of page 9. That involves our lead protection program involving children. And under current law, and this is by law, not because it's a medical standard, that there are, by law, 2 venous blood tests that are done. Only one is necessary for administration of the program. This does not affect payors. In other words, if you have a commercial payer or other payer for these tests, this bill has nothing to do with that. It just doesn't require physicians, pediatricians, to doing 2 blood draws when one is sufficed for purposes. And this is supported, my understanding, by at least the physicians on the committee that we were before. That's a physician of one, Senator Sherman. And so hopefully that's not going to be a controversial item as well. If there's no questions, I can move along to the next section.
Any questions on this section? Move along.
Section 33 of the bill is legislation to address the HB4, in other words, the budget provision back in 2019. They transferred from environmental services to our agency the oversight over summer camps. And they did that because we also administer the child care licensing, so it made sense to moving summer camps over to us. We worked out a provision here because there is an outdated reference to a statute that does not exist anymore because it was a cross-reference back to environmental services that we're seeking to have removed out of the statute. In addition to that, we worked with the YMCA, who was represented by Henry Vahue, on some additional language regarding the number of days before and after when serving food that we would be involved with oversight, which is reflected in that section of the bill. I have no questions. I can move to section 34. Section 34 of the legislation is our perennial cleanup. For those of you who have been around since 2016, you may recall around 2017-18 that we worked with Senator Reagan to clean up a multitude of positions within our agency that did not align the working and the legal titles. In other words, we had somebody who was our information systems officer who was identified as a dentist or vice versa. So now our titles correctly line up with our legal titles. And so as we go through the process every year, we have 1 or 2 or 3. This one that's reflected in section 34 of the bill is our current iteration of just getting those titles aligned with what the actual positions do. Section 35 of the bill is remedial legislation in response to a financial audit that was done by the LBA regarding a shift differential payment that was paid to certain clinical staff at New Hampshire Hospital and Glencliff Home. As it turns out on the financial review, the department, although well-intended to giving a stipend of pay to certain employees, it was identified that we lack the authority. So what this does is to remediate the situation, because there were certain of those positions, the clinical positions, that weren't paid, and out of fairness to them, we were seeking a general fund appropriation of $29,000 to make whole for those individuals and to start anew, understanding that those persons have been made whole. So if there's no questions on that section, and I do feel Joe Christie behind me from New Hampshire Hospital, their CFO, I'll bring him up at this moment in time, actually. So section 36, but I could have brought Joe up, but I think I'm keeping us moving along as promptly as I can. So section 36 of the bill identifies 6 unclassified positions within the department to manage inpatient treatment of child behavioral health. We recently, in tandem with this effort, we went before the fiscal committee and have actually established 6 non-classified positions, which are kind of unique animals, and apparently you can do them through fiscal. So what this does is it allows us to create these unclassified positions to administer the Hampstead Hospital, and then when we are able, assuming this legislation passes, we will then eliminate those other 6 non-classified positions as part of the process. In some sense, because it has to go through the Joint Employee Classification Committee, it is somewhat budget neutral, but I do know there were questions from the committee regarding the positions that were identified. I have Mr. Christie, our Chief Financial Officer for New Hampshire Hospital, Glencliff Home, another place as well in the department. He's very busy, and soon to be, I'm sure, some level of a resource to also the Hampstead Hospital. So if you have any questions for us, Mr. Christie is here to address them.
Well, Hampstead is my district, and I run a small medical facility, and I see how many people you have in beds at Hampstead Hospital, and if you're able to get adequate staffing, there'll be more. And I look at this, and for 35 or maybe even 55 people in residence there, the CEO and salary, the COO and salary, the CFO and salary, a compliance officer and salary, looks like a full-time lawyer and salary, a contract manager. Really? I mean, I run a business. That's a lot of heavy staff for not that many people in the beds.
Sure. So
that was not a question. That was a rant. Would you believe? So, why should I accept this?
Sure. So for the record, Joe Christie, Chief Financial Officer for New Hampshire Hospital, Glencliff Home, and the Path Center. The department has, I would say, worked quite diligently in trying to understand the needs of Hampstead Hospital. They're currently operating around 45 beds, and the department does hope to increase that census over the next 12 months to help with the emergency room waiting list for children. The leadership team that is here today is actually very similar to what we have at New Hampshire Hospital, and to your point, New Hampshire Hospital has a lot more patients, but the hope is that we would be able to increase census at Hampstead Hospital to take care of more children who are in need of those services. I would say additionally, there's within a hospital system, there's a lot of varying responsibilities that fall on that entity. Joint Commission accreditation obviously being a huge portion of that. And so, having roles that really have a dedicated responsibility to ensure that those types of things are maintained and standards are continued to be maintained is important. I would also add the contract manager position that is in here. As some of you may know, the department is hoping to contract with a third-party organization to assist with the clinical operations of the facility. And given the size of such a procurement and the importance of the services that they'd be providing, we really wanted a dedicated individual to oversee that contract, make sure that the services that are being required are being rendered, that invoices are appropriate. I think this contract, you somewhat think of it as a much larger version of the Dartmouth contract than New Hampshire Hospital has today. So, I hope that helps provide some clarity or some reasoning as to why we're requesting these positions.
And in addition to that, just for point of clarification, when the bill was introduced, and of course we were assessing during the LSR filing period in the fall, our lens was looking at potentially 8 positions. Because of the diligent work that was done by the department, they actually reduced it from 8 to 6 positions. So there is an effort to be very lean and efficient in terms of the staffing organization that we're having, and I just wanted to point that out. Additionally, even though you are a brand new group, this bill is totally in your hands, but it was heard by the Joint Fiscal Committee, at least as it related to the 6 positions. They're the same positions, they're the same labor grade that was approved by the Joint Committee back in February.
You need a full-time general counsel for Hampstead Hospital.
So the legal counsel position, there's a few responsibilities that are really important from a legal perspective in this facility. One of them being any potential involuntary admissions that might occur to the facility. So New Hampshire Hospital does have a dedicated full-time attorney within our organization to assist with involuntary admissions. That's certainly one part. Providing general counsel and oversight to the executive team on any legal matters. I would say certainly probably acting as a legislative liaison on any potential legislation that might impact Hampstead Hospital would likely be a part of this role. And then I had a train of thought and I just lost it. So,
Representative Weber.
Just so I'm clear on what's happening here, it sounded to me like, am I understanding correctly that 6 of these 8 positions already exist within the department and we are just transferring them from classified to unclassified?
we are, so what we have approval for today is non-classified positions, which is a very unique and somewhat rare type of position. We are hoping to transfer them to unclassified positions, which would be established through statute in this process.
Follow up?
Follow up.
So for those of us who once sat on eDNA and do understand what an unclassified position and what a classified position is, could you explain to me what a non-classified position is and how many people actually occupy those non-classified positions as of right now?
So that's a great question. I would say that non-classified positions have been a learning curve for the department as well. It's not something that I believe we have any experience with up to this point. My understanding is they are positions that can be created under the authority of the governor's office. I do not know how many individuals in the state of New Hampshire are non-classified, but that is my understanding up to this point.
Could I have one more? I don't need to know how many there are in the state of New Hampshire. What I'm trying to find out, because this says 8 full-time positions, and Mr. Williams made reference at one point to 6 full-time positions, if I'm in the right place, which I may not be.
So I just need to, I believe, if we're actually looking at the legislation itself, the fiscal, you are looking at it. And
I'm
it was
looking
amended
at
to 6
page
positions.
10, line 32. Am I in the right place? I have 8 on that line, but I don't know if I'm in the right place on the legislation.
It says clinical.
It does read on line 33, 6 full-time positions.
Could I just find out where you are, because
I'm going to have to jump in just for a
Yeah,
second.
please.
Everyone here should have an amended version as passed by the Senate.
Yep.
There are 2 amendments that were done in the Senate. 0642S, that was done by the policy committee, and then coming out of the Senate Finance Committee was 1273S. If that's the version that you have, that's the correct version that we're working from right now.
What I have is what was handed out to us. And what I have in front of me says 8 full-time unclassified positions. And what I have says on the very front of it, 0642S, but it does not have a reference to another amendment. So perhaps we don't have the right version of the bill in front of us. I don't need to see it. I just need to know, all I really need to know is, are we talking about 6 current employees or 8 current employees?
6 current employees, that is what is
And they're going to be
reflected.
transferred from one to the other.
Correct.
And the final ought to have been voting on says 6 rather than 8. Thank you.
Yes.
Representative Shapiro.
Thank you, Mr. Chairman. To figure out how to ask this as a question, given the fact that we are paying, we're making 6 positions for top administrative positions at relatively high salaries, although pretty low compared to what it would be in the private sector. And given the fact that either it already happens or there's a plan to contract for clinical staff, so there'll be more expenses in terms of a middleman or a middle person in that situation. I'm wondering how all these things are going to affect the actual eventual salaries for clinical people and the ability for Hampstead Hospital to actually find clinical people who will work for that amount of money.
Sure. So I think a key part of the reason the department chose to pursue a third-party contractor is to assist with some of those types of recruitment for roles that historically the state has struggled to be able to recruit for. So the third-party vendor would be able to offer a wage and benefit package as they saw fit.
Any further questions on this, Representative Gay?
Thank you. I'd really be interested in seeing how many patients live in the other 2 hospitals that you administer. One of them has a nice name, starts with G, and one is the state hospital. Could we get an idea about the administrative costs for them and how many people are they administering?
Sure. So New Hampshire Hospital has a fairly comparable leadership team. New Hampshire Hospital has a total capacity of 184 beds. We currently operate around 156 or so due to staffing challenges. And then Glencliff Home is a long-term care facility. It's a psychiatric nursing home. I would say that is quite a different type of entity than Hampstead or New Hampshire Hospital, but they have a maximum census of 120 beds, and they do have they have an executive director, they have a finance director, they have deputy positions and so forth. So slightly different titles, but fairly similar functions.
Follow up?
Follow up.
I'm also kind of holding my breath at how many leadership people it takes for right now 45 people, and that would be per year per person over $17,000 of administrative costs for them, and that's not counting the people actually treating them. So I guess it would mean a lot more to me how much the people who actually give them services, how much is being budgeted for that, and how much is going to be reimbursed on a per patient. This is just such a small part of the whole finance, and it's high per person, but the real issue is the treatment.
Sure.
And what's that cost?
So the contract with a third-party vendor is still in negotiation, so I can't really speak to that significantly. What I can say is on Friday's fiscal committee agenda, there is an item to request an operating budget for Hampstead Hospital. And there is a contract line, class 102, in that. I believe the number was believe the number was 27 million, but don't hold me 100% exactly to that number. I would encourage you to look at the fiscal item that is currently on that agenda. And so a part of that 27 million would be for the third-party contractor, but that would also represent additional costs for other contracts that would be necessary for the facility.
Representative Weber.
And just so to be clear, so that perhaps we could move on, if we were to remove this section, those positions would still exist. They would just be non-classified rather than unclassified.
That is correct. I don't think it would be ideal. That the department has kind of viewed those non-classified positions as a temporary way to establish them quickly to assist us in getting Hampstead up and running in the time frame that we need to. But yes, technically those positions could still exist.
All right, move on.
So that takes us to Section 37, and Mr. Christie's still with us. Under current New Hampshire law for unclassified positions, there's a mechanism that allows for recruitment of important staff. So for New Hampshire Hospital, they can actually utilize it for the unclassified positions like physicians and other level folks, higher level folks, for recruitment and retention. There is no mechanism for classified positions like nurses. And so what we're trying to do here is create the same type of incentive where the market is very tough for us for recruitment and retention, to having this as a tool. You'll see that there's a threshold of $10,000 for us to be able to do that, or otherwise we have to go to governor and council. The reason why that threshold amount is there, one is we're not anticipating large sums of money for the retention recruitment, and we need to be light and mobile to hiring people, because as you probably know, the governor and council process does take some time to go through. So that's kind of the overall big picture. And I'm going to pause with that because I see Representative Gay either has a question or I've completely lost her. And it's the latter.
Questions?
I was understood. Okay, so moving along, if there's no questions on Section 37, we want to thank you very much. That then takes us through Sections 38 and 60. That is to remove all the references to the Anna Philbrick Center and the Laconia State School, because you well recognize in terms of system of care for children, we're on a statewide application. Those services are not limited or nor being provided at those particular, on a bigger picture, for those entities that are out there. So that actually takes us to sections 61 and 62 of the bill. We're getting there, which and that takes us to page 16 of the legislation for page 16. So if you're having a different pagination, what's happening to me is very clear. Some of you have the correct, most updated version of the bill as passed by the Senate. Some of you do not. By way of example, today, Ms. Dyer, your committee researcher, assisted me across the hallway because I identified that we were having a hearing on a very important bill. And unfortunately, they had the wrong version. It was the bill as passed by the Policy Committee in the Senate, not as passed by the Senate. We could have had this confusion as well with them, but fortunately, we caught that one. I was not aware that you were provided with obviously some that said 8, some that said 6. The other thing I need to mention, if you're online electronically, the LBA working with us has updated the fiscal analysis on this bill. There's a fiscal note that's updated as of today's date. If you look at the bill, it's in its current iteration, as well as your side-by-side comparison. There's actually 1 or 2 pieces. It's nothing to get too confused about, but there's a couple of pieces that have in fact been removed from legislation. Like, for example, the Centene settlement that we'll get to is not a part of this bill. It's only part of.
Would that be the revised fiscal note I passed out at the beginning?
That is wonderful. I did not catch that. Thank you very much, Chairman Pearson. So with that, that brings us, as I had mentioned, to sections 61 and 62 of the bill. This is to reduce the fees for employment eligibility as it relates to child care licensing. It's fairly self-explanatory in terms of the reduction, but it's meant to assist the workforce and also the employers over child care licensing. It's a very small amount of money that we're talking about, but we think it will be helpful to them for their facilities.
And what sections are those again?
Those are in sections 61 and 62 respectfully of the
Okay,
legislation.
that does not appear in this document that I have. We jump from 60 to 63, so.
It's not on the fiscal note. It was.
If you're referring to the fiscal note, that's going to be problematic. I think you have to look to the actual legislation. This is a helpful document, but unfortunately, it's slightly outdated.
Okay,
It's a good, it's saving this part right here.
okay, it's not on this, where
Right.
this is all printed out by the research people. It's,
Yeah.
we missed that one. Okay, I see that. Thank you. It's not on the, well, the side by side. No, I don't see it there. So go ahead.
So Chairman Pearson, that takes us now to sections 63 through 69 of the bill, which is revising certain definitions that for licensing and child care program. And again, we don't anticipate there'll be a fiscal impact for those sections, but if there's any questions, you can let me know. Also related to Section 70 is the transfer and discharge of residents in residential care settings is an issue that came up, and the attorneys with our child care licensing brought forward this to help bring greater clarity to the law around transfers and the dispositions. And then that takes us to Section 71 under the camp recreation license. So you may recall earlier there was a outdated reference. This is the piece actually that we worked with the YMCA on to clarify the language. There's also around the confidentiality for investigation sections that you'll see in the legislation in Section 71. That takes us to Section 72 relative to the department increasing its Medicaid reimbursement for facilities. I would like to invite Mr. Director Lippman up to rejoin us. Procedurally, this was part of Senate Bill 401 in the Senate. The Senate amended 401 to creating a bill that was going to create greater infrastructure for bills. It's a really good, well, I can't qualify. You're going to determine whether or not you think it's good or not, but it's certainly one that's helpful to municipalities. And so they took the birthing centers piece of that bill and placed it into the department requested Senate Bill 430. Mr. Lippman is here to explain what this does in providing a 25% provider increase as it relates to those birthing centers for underserved areas of the state. So, Mr. Lippman?
Thank you. For the record, Henry Lippman, Medicaid Director. We have had 10 hospitals out of our 26 close their birthing facilities. We know of others that have, particularly in the North Country, that are fragilely maintaining these services. The department supported increasing the payment levels for birthing facilities at hospitals. This is what this section pertains to. If we lose one or two more hospitals, we're going to really have some access, network access issues with respect to serving Medicaid beneficiaries and at large the greater public. And so Medicaid is not the entire solution, but this is a part to at least buy us some time to work on a greater degree of effort to preserve birthing services. And it's not just about payment to hospitals for the services, but there's also staffing and other issues that need to be worked on. But absent, I think, putting some money in now, similar to the psychiatric problem, it costs us a lot more to, once things close, to open them back up or find another way to do them. And so I'd encourage you to support this section.
Questions? Representative Leon?
Thank you, Mr. Chairman, and thank you, Mr. Lippman. I know that Medicare rates essentially set a floor and then increase the price for everybody else, or it's set below it. So if it ends up being higher, it would increase it. Does that happen with Medicaid reimbursement? Does that peg anything to what's being done in the private market?
So in terms of the private market, we're substantially below the rates for these services have really, other than probably in the late 90s and then the recent 3.1% increases, there haven't been rates to improve the inpatient reimbursement for these services. And I think there probably would be less than half of what commercial is paying, and I think that really that we're at one of these inflection points where if we don't do a little something now, we're going to find ourselves in a much bigger problem to solve future.
Follow
and
up.
So I guess the question is, even if they are mandated to be 6% below other payers, I don't know if they are. If we're already half of what other people are paying, then that wouldn't have an impact on the price of others.
No, I think that there, in terms of the equity of payment rates by commercial payers around different sections, I think that's an issue that needs to be studied further, which isn't really part of this this piece. But I think that at least with respect to serving Medicaid beneficiaries and making sure that that's one of the primary areas that when hospitals are looking at whether do I continue or not, looking out how poor the payment rate is for delivering babies. It's just something we need to do now to prevent a bigger issue and a more expensive issue to solve in the future. I don't know if that's responsive to your question.
I guess if the response is that the difference isn't going to be enough to change what's happening in the private market, I'm good with that.
Yeah, I think that the private market for at least for a period of time is okay. I think there may be some areas where we see where it's where hospitals may be paid the most might be where there's a lesser need, and that's why in this legislation the commissioner was given a little bit of discretion as to where to apply the rate increase. There's a minimum floor of 20% that would be received by any hospital, but to maybe those hospitals that depend more on Medicaid than others, that she has some room to provide a higher increase in those most vulnerable areas.
So patch the bleeding. Thank you.
Yes.
I'm wondering why this isn't all bundled up and gotten ready for the next budget cycle where there can be long hearings. And I mean, I really am quite angry that we're getting this as late in the game as we are, because these things could have hearings. We could work on amendments for several of these sections. And,
401 was much earlier in the process. The fact that 401 was stripped of all the birthing and made a property tax relief bill wasn't something that the department
we were politely said yes to adding this too. But it's a good piece, and it came with bipartisan support from both Senators Hennessy, who saw to it that we would get an appropriation as for the 2.4 million, as well as Senator Bradley and Senator Rosenwald. So it did have a full public vetting, but as Mr. Director Lippman says, it came in the course very quickly during the executive session at Senate Finance to move. They had to find a home for this, and it just happened to be we were there that day on our bill. And we're gracious as we can be, recognizing we're an executive branch agency and not the legislative branch.
But we're here now.
And we are. And we're almost done, by the way.
Well, we're almost done your presentation. Any further questions on 72? Representative Bohm.
Thank you, Mr. Chairman. And to follow up on the chair's comment and question, would you believe back some years ago, many years ago, I've been here a while, finance had a problem with the same issue. And one of the problems they had, they couldn't get the private hospitals to show them their profit and loss statements. And which is why some of the problems we now have, they say, no, unless you show us that you really need this money, we're not going to give you an increase.
From my standpoint, in terms of responding to that question, is that during the past year and a half, 2 years here, that we've come very close to losing one of the hospitals in the North Country, were it not for some ARPA funds that became, or not ARPA, but CARES Act money that became available. I think what I'm trying to share with you is to avoid a much more expensive problem. If we let these fragile hospitals go, we're going to have a much more expensive problem to fix. And I regret that we're coming forward in this session to do that, but I'm just trying to share with you that it's not just Medicaid people that'll be affected by this, but the whole general public. And I think we've also had support from the economic development standpoint that you know, the North Country's finally seen some positive demographic shift come as a result of people taking advantage of more rural living. And I think this would be a big setback to those, that progress. And also in terms of municipalities, you know, my home community let go of obstetric services. And I know that the fire service, which provides ambulance services, and now having to transfer patients. So there's externalities imposed upon business in terms of making it harder to recruit people, on municipalities in terms of moving ambulances around. I think it's a lot of money, but in terms of what this would mean in terms of if we don't do it, I think we're going to be tackling a much bigger problem.
Representative Gay?
Thank you. Thank you. Coming from experience just with Medicaid with Mama when she finally ran out of all her savings and had to go on Medicaid in the nursing home, I'm quite aware of how difficult it is to pay the bills when you're a facility, no matter if you're a nursing home or a hospital, if you're trying to depend on Medicaid payments. If you want to show us what it cost, maybe the hospitals in the North Country would be glad to show you just every cent they have to spend and how precious, how much they need more payment, rather than a hospital that doesn't really want to tell you how much of private pay insurance are getting. I'm thinking the ones whose backs are to the wall would be the best at giving you real cost analysis so that you can plead your case. We don't want to close any more hospitals, and I think Representative Knirk would probably have access to some real solid information.
I think.
Well, actually, I'm trying to find something. If I recall, is it not true that one can, that there is a site that actually does give the financial reports for all of our critical access hospitals, which are the hospitals that are most at risk with this?
The New Hampshire Hospital Association publishes something that includes sort of the financial status of hospitals. And if you look at, I think the latest information they published, a lot of the hospitals were in the red as a result of the public health emergency period, where a lot of the elective procedures went away. I think, you know, as a former hospital CFO as well, I know that in certain the business decisions, when they're looking at how do they maintain a facility, some of the decisions as to whether they do services such as obstetrics or psychiatric services depend on the sort of the net effect that service is contributing. And I think that it's obstetrics and psychiatric services and some other services that are not sort of procedurally oriented tend to be the ones that go first and so the hospital may remain, but the access for women to be able to deliver their babies safely, if you look at what the travel times will be if we lose Littleton Hospital as an example, we're going to be in trouble.
A follow-up? And is it not true that we have seen an increased number of births by fire officials and in ambulances and in police cars in Laconia after the closure of their maternity services?
If Trish Tilley was here, she would have more specific information, but in the 401 hearings, she did testify to the fact that more unplanned out-of-hospital births have occurred as we lose more facilities.
Yes.
And Chairman Pearson, Representative Gay actually had a question, and it got switched over before Mr. Lippman could answer your question earlier, and my timing of maybe she does no longer have a question.
She's chewing. I think we're ready to move on to the next section, please.
And that takes us to the final substantive section, other than the following section, which is the effective dates for the legislation. And it's section 73 of the bill, which deals with access to telehealth telemedicine. It was requested by the community mental health centers through the DuPont group, and it was worked through with the executive director, Lindsay Courtney, at the Office of Professional Licensure Certification. Originally, when the bill was introduced, it was only directed to physicians and surgeons, and it was expanded to all clinicians under the OPLC statutes that deal with telehealth, telemedicine, and it creates a greater access, as you can see by the wording of the legislation. And certainly, we think it's a good idea, and that rounds up our presentation, Chairman Pearson. Thank you.
Wow. Thank you so much. Representative Knirk.
Just a quick question on section 73. So these other providers would only be eligible for telehealth if the patient had already received the services previously from that person out of state. Is that what I'm reading? In other words, they cannot initiate a new relationship.
And I suspect there will be others in the audience who may be able to answer that question better than us, where it was requested by a different entity than HHS, but we are glad to have this piece in here. But I think that's a fair reading, Representative Knirk.
Representative Weber. We're not there yet. I have a plan that I'm going to be following. Anybody else with a question? Seeing none.
You've been very gracious. Thank you.
Thank you. Now here's where we are. We have just heard that presentation. I have a stack of pink cards. We're going to have to go into an executive session on this and 3 other bills. So there we are. The chair recognizes Paula Minahan to come on up, and from the New Hampshire Hospital Association, and you have stuff to hand out. Thank you.
Good afternoon, Mr. Chairman, members of the committee. For the record, Paula Minahan, Senior Vice President, State Government Relations with the New Hampshire Hospital Association, representing all our hospitals. We are in support of the bill, but I'm not actually testifying on that entire bill. I'm just here to testify on the section 72 that we just heard on page 21, lines 3 to 15. And I may have the wrong version, I apologize, but it's the OB section. It's the language related to Medicaid reimbursement rates for hospital billing services, which, as John Williams and Henry just explained, it got pulled out of Senate Bill 401 and was a separate bill until it made it through the Senate, and then it was stripped out of that and put into 430. So, and as Henry said, or Medicaid Director Littman, sorry. Currently, we have 16 out of 26 acute care hospitals that provide obstetrical care, and only 5 of our critical access hospitals, which is 5 out of 13, and I list them there. A total of 10 hospitals do not offer obstetrical care, as Medicaid Director Littman indicated, and those include Parkland and then two larger hospitals, Parkland and Concord Hospital, Laconia, as well as 8 critical access hospitals. And we, as I'm not going to repeat what Henry Littman indicated, but hospitals have had to close their obstetrical units for a number of reasons. Usually it's due to low birth rates, number of births, excuse me. But the hospital does also need to have more than 1 obstetrician on staff to provide sufficient coverage 24/7. Hard to maintain that with those low number of births. Also, low reimbursement rates has been another contributing factor. And we appreciate that Section 72 is an attempt to at least address the Medicaid reimbursement rates for labor and delivery. While the cost for providing obstetrical care is quite a bit greater than the proposed reimbursement rates, our hospitals continue to offer these vital services and are very appreciative of the proposed increase. And on behalf of our hospitals that do provide birthing services, we support this bill and urge you to do the same at specifically that section. So thank you.
Thank you. Any questions from Ms. Minahan? Seeing none, thank you.
Thank you.
Chair recognizes Nancy Vaughn from the American Heart Association. She's got handouts as well. If you could get that, you are.
Good afternoon again. I'm Nancy Vaughn, Government Relations Director for the American Heart Association. And I am here today in support of the bill, and in particular one section. It is the section 17 found on page 5 on preventative benefits. From my appearance earlier today, you probably know that the American Heart Association is big on preventative benefits to try to keep cardiovascular risk factors under control, to reduce the disease progression that can end up costing a lot of money in the healthcare system and to families. So I'm not going to go through all of my testimony that I just handed out, but I just want to make some key points. While our smoking rates in this country and in New Hampshire are always declining every year, we're still at about 13.9% of adults in New Hampshire smoke. And just to let you know that twice that amount within the Medicaid population still smoke. And as we know, nicotine, which is in cigarettes and other products, like youth who are using a lot of vaping devices, about a third of kids are now using those products and also becoming addicted to nicotine. It's a very hard thing to quit, but there is evidence-based pharmaceutical products, and there's also counseling, and these things have not firmly been in Medicaid in the past, and this would establish that. And there is a return on investment on investing in nicotine cessation. So I urge you to support that section of the bill when you're doing your deliberations.
Any questions for Ms. Vaughn? Seeing none, thank you so much.
Thank you very much.
Chair recognizes, I hope she's still here. I don't see her. Audrey Gherkin from Brentwood. I think she left. Yeah, she works with the developmentally disabled, and I've worked with her on a number of occasions. Okay, not here. Now the chair recognizes J.R. Hole. Now we are moving into some negative testimony. You've heard some positive testimony, and the Honorable J.R. Hole, once a member of the House of Representatives.
Thank you, members of the
And you
committee.
have some handouts.
I do. It's a long day, so I want to
Get 'em
make this
going,
short.
please.
I'm going to do 2 handouts. I'm going to hand out something. Start again. For the record, J.R. Hole, former state rep, never on HHS, on children and family law and education. I want to hand out 2 things. One is some testimony from a former HHS member who was a social worker who ended up being a whistleblower relative to family law issues within DCYF. That's not my testimony. I'm handing this on behalf of Anna.
Okay.
I am going to testify to the family sections part of this bill. It'll be quick. Omnibus bills scare me. I think that's a fair assessment. 21 pages worth of legislation all ring railroaded through is probably not good and prudent government. I have that in my written testimony. I do want to talk to the sections that address children and family matters. Okay, there's a lot of other spending matters, a lot of other things relative to the hospitals. I'm not going to comment on that. The word child shows up 123 times in the latest version of the bill. This clearly impacts children and family. As many of you may or may not know, I've been through a recent legal battle with one of our state departments. I've spent in excess of $50,000 protecting my family from this department. That would have paid for a couple years of college if I sent my children to community college. All over false medical allegations. And I'm going to say that again. A simple false medical allegation cost me $50,000. The question is the punishment just the process? I would like people to understand all of this happens behind the scenes, and you guys have an opportunity to fix it. You have an opportunity to fix it because nothing within the Department of DCYF is monitored by an outside agency. It is time to start exposing, whether it's Harmony Montgomery on one end, okay, where there's inadequate effort, where there's 14 dead children tied to DCYF last year per the Office of Child Advocate, or whether it's my family where they overreacted. Clearly, the lack of transparency is creating a problem. Lastly, there's a section that makes the state a parent of a child. I can't imagine anything more problematic. Hey, Johnny, guess what? My dad's the state of New Hampshire. Who's your dad? I understand that there is a need to make sure that children have a guardianship. I get that completely. But what I want to make sure is we just don't turn them over to be wards of the state as the first thing. That should be the absolute last response when there is no other option. And I have to believe, as a parent who loves my children immensely, that there are other options before we get to making children wards of the state. With that, I'll close my testimony. Take any questions.
The sections that you find most difficult are sections 15 and 16, correct?
15 and 16 are the biggest problems. There's some concerns even about the language within 7 and 8, but 15 and 16 is what I'm speaking to, and I understand 15 has been removed. I don't think 16 has been added.
No.
Has been addressed yet in testimony. So.
And you know, if we had been given adequate time on this, I think we might have come up with some rewrites and alternatives, but
Understood.
any questions of the Honorable Mr. Holt? Representative Gay.
Thank you. Thank you. Section 8, VIII, grants the department guardianship of a child following surrender of parental rights. I asked this question earlier because it just seems like if a child's parents, the other question I didn't get asked was, what is the condition under most parents lose their rights? I'm under the impression that they are terminated by court, not they usually walk away. I've only heard a couple of people ever say, I gave it up voluntarily.
I would concur with your statement that most parental rights are terminated by a court and they're not given up voluntarily. Speaking, obviously this is a confidential case, so there's a limit on what I can say, but I can tell you I walked into a courtroom in a preliminary hearing back in December and someone handed me a form and said, you need to sign this. And that was the first time I'd seen this form that would have told the state and authorized the state to take my kids. I didn't sign the form. My children matter to me an immense amount, which is why I was willing to go to battle to protect them. So yes, Section 8 has some problems. I can understand why I think the state is looking to make the change, but I'm not sure that is the best way. And if that section could be removed and later on addressed in a separate piece of legislation, I think there is a way to solve what they want to do.
Perhaps over the summer, a group of people could rewrite something that both looks after the children who unfortunately are in terrible situations and situations like yours, which you know is not unique. And maybe that could happen. This bill will be voted out of this committee one way or the other today.
I understand. Thank you.
Any further questions, Mr. Hall? Seeing none, thank you so much. Please pass the stuff around. Chair recognizes Diane Cody. And you have some handouts too. Could you give us about 30 seconds and then start your handouts?
I
around?
already handed them out with the pink slip.
Oh, you did?
Thank you,
Okay,
Mr.
well
Chairman.
done.
Yes.
Well done.
Your Honorable Committee, my name is...
Okay, would you hold on
Yep,
for a
sure.
minute, please?
Oops, I got unplugged.
In the interim, Mr. Chair, can I just tell Representative Gay something? Representative Gay, I'm a CASA. I have done 5 cases. I have never done a termination of parental rights by the state, but of those 5 cases, 2 have involved voluntary surrenders by parents. It happens. It happens regularly.
Mr. Chairman, it's coming around. Mr. Hole gave his testimony to me.
And there is cheap on Staples Ice. Oh, no, this is something else.
different person,
This is,
but
I,
he's standing for
I
it.
ask his
Okay.
forgiveness. Coming around.
These are extra. No, I think we're. I've done.
All right, everybody in good shape here? Chair recognizes Diane Cody.
Thank you, Mr. Chairman, and your honorable committee. I am Diane Cody, and I'm a member of the public here representing myself. I heard, and this is the first time that I've ever done this, so I had heard that 15.3 and 16.2 not yet, but 15.3 is being removed. What I heard was temporarily until it can be reviewed. So, and after listening to this bill today and going through this the first time, I see that it was couched in a bunch of things that were not even related to anything here. So from there, I want to read you my statement and my
I'm
testimony.
going to ask you to paraphrase it and not read it. We're on
Sure.
the clock.
Sure. So I flew in from Illinois for this hearing today on my own dime. And it was specifically to talk about 15.3 and 16.2. I am a CEO of a Realtors Association in Illinois, and I am the great aunt of 3 siblings. 2 who are in custody of New Hampshire Department of Child, Youth, and Services, and 1 who tragically lost her life, despite several family members alerting DCYF that the children were in danger. I have spent more than 15 months and $100,000 trying to gain guardianship, secure guardianship of a minor, my great nephew. And rather than working with me, DCYF has worked against me in every step of the process. I've learned how DCYF works in New Hampshire, and in all the ways that it doesn't. And these 15.3 and 16.2 will require them to have less oversight. More oversight, I mean. So I'm here asking for your help today on behalf of my great niece and great nephew who are still living. I never imagined that I'd be here before you sharing our worst nightmare, which was on November 16th, 2020. My innocent 21-month-old niece was in a car with her parents at the TMZ truck stop in Londonderry, and she ingested fentanyl and died of acute fentanyl intoxication. Her parents, Shauna Cody, my niece, and her father, Mark Jeremiah, and another adult, Dana Dolan, were in the car, while those 2 kids were fending for themselves. Thankfully, her oldest sister survived it. Several of my members have been contacting DCYF since 2016. This was when the first child was born. And we continued and continued after the second. And then the third was a surprise to all of us because the death of Adeline in 2020
early 2021, our family, unbeknownst to us, was informed that my niece had a baby. And the baby was taken into custody by DCYF, and my niece called me and asked me if I would raise him and keep him from going into DCYF. I contacted DCYF immediately, informed them I was ready to care. I was living out of state. I do live out of state, but I would be there within 24 hours. They said, no, you are out of state. You're not considered as placement. He's going into foster care. So between then and now, to summarize, I wrote everything out here. You have the testimony. Basically, I have gone from submitting petition for guardianship, DCYF filing petition to dismiss it, family court dismissing it, taking it up for appeal to the Supreme Court and winning. The Supreme Court decided that I could hear be heard on the guardianship merits of my great nephew. Now, they are couching this legislation because what we argued on was, in this law, guardianship and custody are defined separately. And so DCYF has been conflating, saying as soon as they gain custody of a child, no one else can come in and change that order. And what happened was we won the argument that guardianship is specifically defined, custody is specifically defined. So with 15.3 and 16.2, I won the guardianship. I had the hearing for guardianship for my baby nephew, and I won guardianship of him as of March 17th, 2022. It's been a long journey, and I'm still in it because I love these kids, and I want to be able to look out for their best interests. We have Harmony Montgomery, who, had she had someone advocating for her and been, if they were able to have the funds and the wherewithal and be a guardian for her in her family, maybe she wouldn't have gone missing. Maybe she wouldn't have been placed with a father who is a reported abuser. I am trying to be a guardian and work alongside DCYF while they go through their process of determining, helping the parents, whatever process they have. That's all I've been trying to do, and they have been fighting me every way. And so that's why I came here today, to tell you that 15.3 and 16.2 is a direct retaliation to my Supreme Court win.
Thank you. Would you take questions from the committee if they have any?
Yes.
Any questions from the committee? Well, thank you so much for coming. Yes.
Representative.
What?
The end of the story. Do you have custody of your great nephew?
I do not have custody. DCYF does have custody because that is the law. What we argued is guardianship and custody is different. DCYF does not have the capacity. Guardianship, you act in a parental role. Medical, legal, emotional. I have a relationship with these kids. These are my family. I love them. I know them. DCYF is overburdened, overworked, all the things. We know all, that's the current tragedy is Harmony. But there's so many you don't know about. There's so many people like me that are going through these things, and it's lack of transparency, and I really don't understand any of it. I don't know why this has been so difficult, and that's why I'm here.
Thank you.
Thank you so much. Any other questions? Yes, Representative DeLamus.
Thank you, Mr. Chairman, and thank you for coming here, and thank you for your testimony.
Thank you.
So just to be clear, you would want to see 15.3 and 16.2 dropped.
Just the inserted language that they're trying to, the new language they're trying to insert.
Okay. And follow up? Give myself follow up. So, and also to clarify, you do not have your children in your possession.
I do not, and I cannot speak to all of that. But I have guardianship of one.
So what's it going to take? We don't know, right? For you to have them.
I can't speak to that.
Okay. Thank you.
Thank you.
Anyone else? Representative Gay.
Yes, ma'am. Would you like to see a review of family court and DCYF and something that lots of people could come and testify and be heard?
I would. I would.
I have a bill in the Senate that we
Anyone
passed.
else with a
Thank you.
question? Okay, seeing none, thank you so much.
Thank
and
you very
again,
much.
Sorry for your loss.
Thank you.
Chair recognizes Judy Anderson from Guilford, New Hampshire.
Good afternoon, Mr. Chairman, committee. My name is Judy Anderson. I live in Guilford, New Hampshire. I worked for DCYF for 24 years, and I came today to support Diane Cody, and I thank her for her courage. I'm here to just briefly say that we have to right some wrongs with DCYF. DCYF is in crisis. Despite the lawmakers' best efforts, you've done many wonderful things that should have worked but have not. Hopefully with the new Office of Child Advocacy, the new direction, we'll see some good results. You've strengthened the language of the law, but still we don't have best interests of children at heart. And I just want to express my outrage at Diane's situation and the situation of Harmony Montgomery, and also, you know, the list goes on and on. So I know that if you will turn your attention to those tragedies happening at DCYF, I think you'll come up with a solution. And I think transparency is key.
I may have been distracted preparing for what's next, but as a result, you would be comfortable with our deleting of sections 15 and 16, so these things could be rethought and rewritten?
That's correct.
Thank you. Any questions? Representative McMahon.
Mr. Chairman, just what you just stated to Ms. Anderson, the previous Madam Cody referred to the changes in 15 and 16, not the elimination of 15 and 16. Now, that being said, there's a much bigger issue happening here, so we can, that's another matter. But were you just stating that then we should consider eliminating the total language of 15 and 16?
I will be suggesting that when we move into exec session, yes, so that people can rewrite them. Because we don't have time to do that. We have not been given time to
No,
do that.
point taken.
Yes. Yes, thank you.
Okay.
Thank you for the
That's what I wanted to
clarification.
clarify.
Appreciate that, both of you. Thank you so much. Any further questions?
Thank you.
Thank you. And I have no more cards on this bill. So this will close the hearing on Senate Bill 430. And now I will open the exec session on the same bill. And I move ought to pass on Amendment 430, Amendment 1406, and that deals with 3 sections. And this will be next. I have these. No, after 14. Yeah, so it won't undo what I'm doing.
Okay.
Yeah.
Gotcha.
Okay.
Somewhere.
Does everybody have the Amendment 1406? Take a few minutes to read it, please. Does everyone have 1406? No, we need, I mean, we need two 1406s. Would have had them. Good to go. Does it? Okay. So that would be 2812, huh? Time, no, it wouldn't have. No, there's other amendments coming. This is about this and only this. There'll be others. I have moved this amendment and would like a second. Okay. Moved by the chair and seconded by Representative Folsom. Any discussion on this? Representative Weber.
I just want to be sure that I understand what this amendment does, having only just been provided with it.
Understood.
Are you going to walk us through it, or would you like me to ask questions?
I can walk you through it. Look at line 9 and 10. It deletes two sections. We've been speaking to this. They might be rescued, but not now. So let's take them out and work on them and get them back in a way that protects straight across the board with the new child advocate we met today. Under line 7, the word misdemeanor is changed to a violation. And I would like to ask if Mr. Hole would comment on why you believe this is important, because we've had a discussion on why misdemeanor should be lowered to violation.
So that language allows a parent, right, potentially to share what's going on. I am forbidden, even though my court case was on the front page of the Concord Monitor above the fold. I will gladly show that picture if anybody wants to see it. I'm forbidden from sharing what's going on in a case that was dismissed clearly. Okay, so this allows someone to say, you know what, I don't want to go to jail potentially to talk about what's going on and bring some level of clarity. It also allows, on the other side, the parent who keeps on emailing DCYF to say, I'm asking for help, I'm not getting it. Okay, the chance to expose what's going on. It still maintains the confidentiality that the state is not going ahead and sharing information, which would be detrimental to person's privacy. But I can think in both cases where someone is asking for help and they're not getting it, or someone feels like they're being wronged, both ends of the spectrum, a level of greater disclosure could be good. Okay? And I think the important part, the violation makes it clear that there could be a penalty if they start disclosing too much information. If anybody takes a case to the Supreme Court, a fully redacted case is already available in the public domain. So we have the provisions in court filings to make this happen. Let's hear if we can do that ahead of time. Okay?
Follow up?
I'm just asking you, this is a special new provision that's been put in for the benefit of Mr. Hole, is that correct?
For the benefit of people like Mr. Hole.
And others similarly situated?
Yes.
But nothing we've seen or talked about before?
This is correct.
And nothing that the public has been given any notice of?
This is correct.
Okay.
And I've been given the right to rule this germane.
You have absolutely that right. I just want to make it clear that people who might have wanted to comment have had no opportunity to do so.
That is correct.
And then my last question would be about the new we are replacing all after 71, and I'm sorry, I'm working off my computer here. So oh, that's right, because of the new
renumbers.
numbering. I got it.
And
Okay,
this-
thank you very
you
much. I
won't.
just wanted to see.
I appreciate that.
I wanted to be sure that there wasn't something else being taken out, but it isn't because you renumbered.
I don't
Thank
want
you.
any of us to have voter regret later for not asking the question. Thank you. And under, if you look at line 17, 18, nothing in this section can be construed to prevent a parent, guardian, immediate family member, or their counsel from releasing any records with the name of the child redacted. Again, we're whistleblowing here. We're looking at things that went wrong so they can be fixed. Representative Shapiro.
Yeah, I have a question about under number 7, what's really intended here. I understand, I mean, I don't think we should be litigating specific cases here. I don't think we're capable of doing that. So I'm a little uncomfortable with this being case specific. But aside from that, I'm trying to understand what this intends to do. And it says, it shall be unlawful for any person present during a child abuse or neglect hearing to disclose any information that may identify. And anybody, okay. And then it says, any person who knowingly violates the provision shall be guilty, and it changes it lowers it from a misdemeanor to a violation. But are we also talking about like state officials who are present at those hearings?
Mr. Hull.
Thank you, if I may. So yes, it does reduce the penalty from a criminal offense to a violation, okay, as you pointed out.
Even for a DCYF worker?
There are other provisions under 170G8A regarding disclosure of case materials that would still remain a misdemeanor, okay, for the employees of the state. So if I may, and I'm not an expert on this, I've just gone through this once. Once was more than enough. Okay, there are provisions within the child protection statutes under 169C, and there are provisions regarding confidentiality under 170G. Okay, it leaves in place the provisions in the 170 that affect the state employees. It just allows, the way this is being done allows any parent, and it's not just to Representative Weber's comment, it is about me only. No, I just happen to be the one who realizes there's a fundamental problem. I sat on Children and Family Law for a term, 2 years. And in the case of disclosure, and it doesn't matter whom, okay, the mom of Harmony Montgomery, whether good or bad, if she went and said, you know what, I've sent all these emails, here's all this information, they're doing nothing, we might not have lost a little girl. What about the 14 parents that the Child Advocate's Office has outlined that are now dead? So my point is, allowing parents to bring some greater level of concern to the public is a good thing. That is some of the transparency that I think's needed. You heard this other lady that I only met yesterday that I heard about. Okay, this is not an uncommon problem, unfortunately. And I would argue it's true both for underreaction and overreaction. Both problems exist. Okay. Did I answer your question?
Representative Knirk.
Thank you. I think I'm just still a little bit bothered by saying any person sorry, this is in line 6 of the amendment. Yet you're specifically wanting to make it so a parent, for example, could say something. Why would we not say a parent would just be guilty of a violation, and somebody else who is, just kind of giving names out would then still have a more higher level of violation?
Thank you, Representative Kirk. That's a great question. If I could see that putting any parent right in there would be a prudent thing. I was just getting rid of what is a criminal penalty. And the issue is, it doesn't say Class B only. It's a misdemeanor Class B. It says misdemeanor, which would be presumed to be a Class B in the criminal statutes, but it could be elevated under 625 up to a Class A if some judge or some prosecutor wanted to push for a higher level, and that's a year in jail. And that's a pretty harsh penalty, okay? Because again, right, I'm going to use me as an example, right? A parent faced with jail time or protecting their family, right? That's a tough choice. That's a choice we shouldn't ask our citizens to make.
Follow up?
Follow up.
Yeah, I appreciate that for the parent. I'm concerned about some other person who would reveal information that should not be revealing it.
Well, it's a good point. I don't know how the chairman runs this committee, right? Because this, and that's not a bad thing at all, right? This bill's being, right? There's a lot going on in this bill, but if the committee agreed to changing a word, I know there is a way to get that done. When I sat at the House, if we're all in agreement that this word should not read person, but read parent, what they do is adopt it, and then the numbers get
It
filled
would
in
have
later.
to be a floor amendment.
Okay. Okay.
Parliamentary response? Then statement?
Well, my parliamentary response is I don't think somebody ought to be testifying in our executive session, but I
well,
understand that
we
there
do
was.
allow it sometimes, but yeah.
There we are. I'm very troubled with those two extra pieces of this amendment. I understood that there would be an amendment simply deleting 15 and 16, which I agree need more discussion. Just as I think they need more discussion, I think that the concept here, which is an important one, also needs more discussion. And so for that reason, because we have only heard from one person, and there may or may not be other people affected who want to say different things, I am going to vote against this amendment because I am concerned about consequences of which we have no knowledge. And this is the Health and Human Services Committee. This should have gone to Child and Family Law, but we don't have that option, so I know we are here. But had I known there was going to be more verbiage in this amendment, I would have asked for an amendment just removing 15 and 16 and not including this. So I'm going to vote against this amendment.
Thank you, Representative. Did Representative Kofod, did you have your hand up earlier?
I didn't, but I would like to speak if
Okay.
you want to recognize someone else first, that's fine.
I'm recognizing you.
Okay. Yeah, I guess the statement that was just made was that we need, in essence, time for further deliberation. My concern is that as we spend time deliberating on this point in particular, that is, if we kick the can down the road, there are lives and families at stake that are adversely affected. This is a small change. I think it comes from someone who has been through this and who has seen the ramifications of this sort of confidentiality shield that protects the courts. And I think it's really important for us to act on this sooner rather than later.
Thank you so much. Anyone else? Representative Gay.
Thank you. At VII on the amended analysis, is that number 7 in the new paragraph, Child Protection Act, which is page 3, number 25, line 25? Because I'm very concerned about this after finding out what happens or has happened to several people with the department taking guardianship of a child and then not wanting to let go of it. I really don't want whatever section is referred to under VII 8.
Are you
I mean,
speaking to
8.
the bill or to the amendment? We are on the amendment.
I think, Mr. Chair, she's concerned about Roman 8, which is grants the department guardianship of a child following surrender on the amended analysis, but those are the paragraphs that are removed by the amendment. That's the deletion of section 15 and 16 in the amendment.
Then
So
she
the
is.
amendment
Then
takes
you are.
care of that particular issue, because that was the one that we were all alerted to quite some time ago, and this deletes those two, 15 and 16.
Representative Shapiro.
Yes, I would like to piggyback on what Representative Weber said, that I would be glad to exclude 15 and 16, but I think in this amendment to number 7, I think we are really at the very last minute taking information that someone's brought who is very dissatisfied with their experience with DCYF and generalizing And I think that I mean, we haven't heard from people from DCYF talking about this issue or talking about what the consequence will be. And I'm just really uncomfortable with that. So I will vote against this amendment.
Anyone else? Representative Knirk?
I'm still a little bit baffled, also still trying to put it all together, because it seems like the amendment, lines 3 through 7, which replace section 7, means now we're taking out the Child Protection Act issuance of summons and notice, which was section 7. So we've actually removed some of the meat of this bill that none of us had any objection to be able to put this new number 7 in. How does that fit with what the DHHS would like, since that's something they'd requested? Yes, it is, because it's replacing section 7. Section 7 of the bill is page 3, lines 25 through 35. And that, which is all about the location of the parents and so on and so forth, that suddenly then disappears.
Representative Weber?
So what we're doing is we're taking a relatively innocuous section which speaks to notice when the location of the parents is completely unknown, and we're deleting that entirely, and we're putting in a section that we don't know anything about. I wanted to ask the chair, is OLS still available to us for drafting?
No. You can call them, but I think they've gone home.
Okay, thank you.
Representative Knirk?
Then could I suggest that we might reach some sort of straw poll agreement and then bring a floor amendment that would just remove 15 and 16, but would leave the other part out, and that could be taken up as a new bill another year, because it is quite different, even though I know you've ruled it germane, but it is quite different, and this would allow us all to be able to comfortably agree.
Let's take the straw poll. If we ditch this amendment, are we comfortable with taking out 15 and 16? Okay. Those of you who are not, and could you give me a few reasons why? Representative Leon?
Thank you, Mr. Chairman. For me, right now, it looks like we're trying to balance something. We've had the tragedy of Harmony. We've had other tragedies of overreaction. If we may open up some small window where some people would be guilty of a violation and not a misdemeanor, when we get more information and more transparency, I think that the difference in how somebody is charged, if that means a child's life, is worth it, because we can come back and add the language in the future to say not just any person, but it would just be somebody with a direct care. But if you look at this too, the other people are necessary too, because we looked at this woman who came here from Illinois in order to care for her great nephew. If this said just parents, she wouldn't be able to speak up about what was happening. So I think that being a little bit broader and who's only charged with a violation instead of a misdemeanor right now, while we're dealing with our current crisis, makes sense. And if it needs to be revisited later, that's what the legislature does.
May I suggest this? We vote the amendment. If it loses, a bell rang, and that means we can do a floor amendment, and that moves us on, because we still have another hearing. Yeah. So I would like to move this amendment, and the amendment is 1406 on Senate Bill 1430, as moved by Pearson and seconded by Folsom. And would the Assistant Clerk please call the roll on the amendment? Excuse me, hang on 1 second. I want to get... She's calling to see if we can get an amendment done now, if they've gone home or not. Have they gone home or not? Have they gone home? No. They haven't? Okay, so this may be moot. So suspend.
Mr. Chairman, if this amendment passes, then we don't need another amendment, because clearly people want this amendment. So, I mean, we might as well just take the vote.
Okay, stay in the room, call the roll, and say yes at the right moment, if you wish to. Well,
Okay.
Representative Leon,
Yes.
Representative McMahon,
Yes.
Representative Acton,
Yes.
Representative Gay, Representative Moody,
Yes.
Representative Folsom,
Say
Yes.
Representative Bohm,
Yes.
Representative King, yes. Representative Kofal,
Yes.
Representative Delimas, sorry. Representative Weber, Representative McKay, Representative Snow,
Yes.
Representative Knirk,
No.
Representative Soloway,
No.
Representative Cannon, Representative Nutter Upham, Representative Shapiro,
No.
Representative Woods,
No.
Representative Query,
No.
and that is,
Chair. Chair. I get
oh.
to vote.
I did it too. I'm sorry. Representative Pearson.
Yes.
All right. 1, 2, 3, 4, 5, 8. That makes it 13 to 8.
13 to 8, the amendment passes, and may I suggest to the folks, Representative Weber and other, we can verify this, that.
Thought it was
sorry?
10 on our side?
What I'm suggesting is, if there's a difficulty with the language in 7, you can get a full amendment
Well,
too.
here's the thing, 2 things. First of all, I counted 10 noes.
No, I had Representative Snow and Representative Nutter Upham.
Oh, they voted the other way? I'm sorry. Okay. Sorry,
Okay.
my
Nope,
my
no
bad.
problem.
I was also, let me just tell you, Mr. Chairman, that I received, the reason that I missed the count was that I received 2 texts from Ann Fitzgerald saying, please tell them that OLS is staying just for HHS tonight. OLS is here.
Tell Ann Fitzgerald she's on my Christmas card list.
That's who I was on the phone with, and she said that.
Okay, so the amendment 1406 passes 13 to 8. There is another amendment.
Point of order, sir.
Yes, sir.
I'm just kind of wondering, out of courtesy to the people, whether we might consider recessing this executive session, because we've had people waiting here now for a couple of hours to testify in the next bill, and it'd be kind to them to let them do their job.
Chair recesses this exec session on 4:30 and thanks the honorable gentleman, and now opens a hearing on Senate Bill 290. And we will get to that. Turn in the folder. And Senator Reagan had to get to something else. So is it permissible, parliamentarian, for the chair to open this hearing? Do I have to go over there?
I'll introduce you.
That'll be lovely. Please do.
As long as she's not exempted from being able to make any questions. Because she still can ask questions then, right?
Yeah.
Yeah, thanks.
She did the last time, you know, I'm a good guy on this. Okay, the hearing is open on 290. And I have 1 pink card. If you want to testify and your name is not Senator Reagan, I don't have a pink card, which means you either didn't fill it out or I've lost it. And that means you get a second go at it. So pink cards, name, information, for it, against it. Oh, Dr. Woods.
Full deck.
That's the first time this week I've been accused of having a full deck. Representative, would you please open the hearing?
Mr. Chairman, my name is Lucy Weber, representing Cheshire 1, and I bring to you on behalf of Senator Reagan and without prejudice as to how I might vote on the bill, Senate Bill 290 FN, relative to the practice of auriculotherapy, and ask that the committee defer the questions to all the people who have far more expertise than I. Thank you.
And thank you for not saying you can stick it in your ear. Chair calls and recognizes Bob Best from the New Hampshire Acupuncture Association. And you're all asking for about 2 or 3 minutes. Thank you so much.
Thank you, Mr. Chair and members of the committee for the opportunity to be here. My name is Bob Best. I'm an attorney at Sulloway and Hollis, and I represent the New Hampshire Acupuncture and Asian Medicine Association. There are quite a few members here, although a couple of people had to leave, who want to speak, and the association opposes the bill. And they ask that you vote no. I put in my card without knowing who would be first or who would be second. I just wanted to speak to one little narrow piece of the bill. As you may hear later in testimony by folks who support the bill, and as the Senate heard by folks who support the bill, that this is, in their view, important and urgent, and it ought to be something that we embrace for reasons which they will offer. And I want to speak to that specifically because if you look at line 9 of the bill, you see that the people that are going to provide this unlicensed auricular therapy, which is acupuncture provided to the ear, that the people who are going to provide this unlicensed therapy do not purport to treat any disease, disorder, infirmity, or affliction. And so weigh that as you hear from folks who might think that this is important for some reason. You might hear testimony about how the Army is providing this as a treatment to soldiers in the field for certain things. That's not what this is about. You might hear that this is urgent and in need for the opioid crisis because auricular therapy is useful for a detox and addiction therapy. But keep in mind that the kind of auricular therapy that's being proposed here does not purport to treat any disease, disorder, infirmity, or affliction. And keep that in mind as you weigh the testimony that you hear from folks who might tell you that this is urgent and urgently needed. That's my whole testimony. I hope I came in under my 3 minutes. Glad to answer questions. I'm sure everybody is eager to see the next person come up and speak.
Any questions? Thank you, Mr. Best.
Thank you, Mr. Chair and members of the committee.
The chair recognizes Adam Lerner, also from the New Hampshire Acupuncture and Asian Medicine.
Adam left already, but I have his written testimony here, which was also emailed to the committee.
Thank you. Would you pass that around? Are there 23 copies or?
There's more than that.
Good. Thank you. The chair recognizes Amy Odell Wilson, and she is in opposition to the bill. And you represent New Hampshire AAMA, which is what?
Good evening. My name is Amy Odell Wilson, for the record, and the answer to your question is New Hampshire Acupuncture and Asian Medicine Association.
I'll get it by the 5th card. Thank you.
Thank you. I'm the vice president of NAHAMA. That's how you said that. And I just have 3 brief points to bring to you this evening, sorry.
Is it still Tuesday?
I think so.
Thank you. Sorry.
Thank you for your time. I do stand in opposition with NAHAMA and offer 3 more points in addition to what you just received from our official position statement. The first one is I understand laws and rules to be long game, not short, and that New Hampshire General Court spends valuable time deliberating to ensure that laws are sustained and are in the public's best interest. The acupuncture and detox specialist rule, ACP 700 to 705, was only in effect from July 20 of 2018. It's not given enough time to find itself to see if it actually works. This detox specialist bill allows lay people who are trained correctly in the NADA protocol or its equivalent to offer the auricular therapy to the public. Those in support of 290 will tell you that this is not working, that there's not enough specialists out there, that there are not enough supervisors, and I don't believe that this is the case and that there is something inherently wrong with the law and rules you've already enacted. Instead, please consider that there's been not enough time or education to the general public and then the acupuncture community to implement this program. A new law is not needed. Time to educate the public and recruit the acupuncture detox specialist and the acupuncturist to supervise them is required. I'm new to acupuncture. I began practicing privately in the state in just the fall of 2019, and I knew nothing of this program. And then I've served on Hama for 2.5 years, and in that time, no one has ever come before the professional organization to ask for help. They never came to ask for recruiting help or even to let us know that there was a shortage. In a recent meeting, 10 acupuncturists has raised their hands to supervise and to provide care, and even on a volunteer basis. Let us remember there's also 2 years of COVID, and nothing goes as planned, and you will hear that possibly there was an employee shortage and people can't get the acupuncturist. I don't know of an industry right now that can get enough employees to do the work that they need to do. And this is just a fledgling program, and we do not need a new law. We just need time to educate, recruit, and implement the existing law that we have on hand.
Are you willing to take questions?
I just have one more.
One more point.
Just one more point. Thank you. Promoting training, certification, and supervision provides anyone who desires this in their toolkit to be more accurate in needling the prescribed protocols and more aware of the contraindications and potential adverse side effects, making it more effective. I would argue that taking training out of this does not serve even the peer-to-peer counselors. I would advocate that giving someone training gives person of confidence to be able to do the protocol correctly and to promote the desired outcomes. Yes, I will take questions.
Any questions? Thank you for your testimony. Chair recognizes, is this Paul Mosier? And you have written testimony. If you could circulate that around, you have one copy.
I'm sorry.
That's all right. That goes to the clerk when you're done, if you would, please.
I have emailed the testimony as of last evening, so
Okay.
it may be in your possession already on some.
I think I've been
some
here
server
since
somewhere.
last evening, but thank you.
P. Mosier, P-M-O-S-I-E-R at amherstwellness.com. Good evening. My name is Paul Mosier. I'm a licensed acupuncturist. I work full-time at the Manchester VA Hospital practicing acupuncture. I'm also responsible for running the auriculotherapy training programs that are there. I am speaking on behalf of myself and not the VA today. However, because this impacts my job, I would like to speak to how that is going to be impacting. There has been testimony offered to the Senate that specific ear protocols are available for military personnel, but they're not available to the public. I would like to clear this point. The VA and the Department of Defense do offer specific auriculotherapy protocols, such as battlefield acupuncture or NADA, which are terms that you will hear. However, these protocols can only be performed by existing personnel who have gotten additional training already in the medicine. Once the AccuDetox law has been passed in 2018, equity and access between military and civilians was achieved. Any testimony to the contrary is currently false. To the point about medical treatment, this bill does state that auriculotherapy does not purport to treat any disease, disorder, infirmity, or affliction. The process of the medicine is that there is a map of points in the ear that you can select from to treat particular parts of the body or conditions. There is no reason to move a needle from one location to another unless you are treating a specific disease, infirmity, or affliction. When that happens, every medical treatment has a time and a place where it is helpful. Determining that time requires clinical expertise. For example, abdominal pain. Is it indigestion or early onset appendicitis? Is shoulder pain a musculoskeletal issue or the beginning of a heart attack? People have to have training in order to understand this question and to be able to answer it. Now, this bill presumes that any person on the street can make that determination without any additional training. That's absurd. Now, there has been testimony provided to the Senate stating that auricular therapy should be deregulated because it is safe to move a needle from one portion of the ear to another, and that is the only risk. That is not. That is a gross misrepresentation of the risks present in this bill. In fact, there is no defense that can be offered to say that no one would treat potentially life-threatening conditions, that diagnosis may be made by other means, or that education clarifying red flags could be taught, because this bill does not require any of that. Lastly, concerning the VA, new services and the expansion of service are assessed for what liability they may have. Our administration uses a combination of national standards and state law to determine who should be able to provide a service and what training they require in order to do so. The trend in national standards currently is for increasing regulation to bring acupuncture in line with other medical service currently offered. Regarding state law, the current AccuDetox bill, again passed in 2018, provides the best guidance currently available. If this bill passes, that guidance goes away. Our administration then has to reevaluate who can provide service. Because they cannot determine if a person has been adequately trained, the most likely outcome then is that they will say that either no one can perform auricular therapy, or they will only limit it to existing medical personnel who have it already in their scope of practice. This would introduce a disparity, limiting access to care for veterans that the public is available to get. Now, I believe that medical service should be given to underserved people. This is a good goal. But a better goal is to deliver competent care. This bill does not do that. Please vote no. Thank you. I will take questions.
Representative Acton.
Thank you, Mr. Chair. Thank you, sir, for taking my question. Is a licensed acupuncturist able to make diagnoses?
To my understanding, and you can ask the Board of Acupuncture Licensing about the specific legal wording, yes. That diagnosis is done by East Asian medical principles, I will say that.
Okay, thank you.
Any other questions? Thank you so much. The chair now wants to hear from some people who are in support of the bill and recognizes Laura Cooley.
Hi. My name is Laura Cooley. I live in Orford, New Hampshire. I am the reason we are here now. This is my bill that I initiated. The reason we're here is because I promised Representative Peter Schmidt I wouldn't file a complaint on the licensing board with the governor. So this was the alternative. I have a few things to let you know. I do not have a handout. The thing that I actually respected the request was I brought one other person. But now Elizabeth Ropp is here, and she may want to testify. Okay, so New Hampshire is a constitutional carry state. We want to open carry needles and not become criminals because we're doing it. Needles, acupuncture needles and guns, both are meant to protect people. Ear acupuncture is backed up by science. This is a little point finder gizmo. This is a book that came out of UCLA research, tons of research. You can find points, okay? Some people say this is acupuncture. Other people say it's not. In New Mexico, we're not allowed to call it acupuncture. If we do, nada. I've been doing this for 30 years. I've been training people. I have passed many laws, Louisiana, Texas, unanimously, Rhode Island, unanimously. Once people learn how to needle the 5 points that we did pass, you can safely insert the needle in any other point on the ear. There's no other, we're not moving one needle from one spot to another. We're just doing other points. So when we went to Katrina, we would do the 5 points. And then if somebody had a shoulder problem because they've been chainsawing for 13 hours trees to clear the roads, we could put a shoulder point in. Vermont did this very thing. It deregulated it. And the lawyer for the state did it. They do not have a state board. The lawyer said, this is folk medicine. This is safe. It's a wellness treatment. You try it, you get better, you go back. You don't get better, you don't go back. It's as simple as that. And that's why In Vermont, we can train people to do the full ear. There are many points on the ear. Again, there are tons of research by the Germans, the Chinese. There are many acupuncture trainings. This bill does not recommend somebody doesn't get trained. It says appropriately trained. There are many trainings across the country. I can list them. I know of at least 10 training programs myself. I have a training program. Denmark has trained 20,000 people. Now, you should understand that the trainers for this ear acupuncture, for NADA, that we have already passed, half of them over 60 are not acupuncturists. So there is not a very good understanding in the acupuncture profession about what we do. We are the public health stepchild in the acupuncture world. So there's not a lot of familiarity. Some schools don't even teach ear acupuncture at all. I've had to train acupuncturists how to needle the ear myself. So this is not necessarily well known in the profession. The VA, I am on the curriculum training team for the VA. I am writing the curriculum to train people in the VA. We do 70 hours here in New Hampshire. The VA is going to do 32. Battlefield acupuncture, another protocol, is a 4-hour training in the VA. The people that get out of the VA or the military that know battlefield acupuncture, they cannot practice that in New Hampshire because all that is approved is these 5 points that we use for addiction and trauma. So, you know, why do we not have the freedom to do this? I just don't understand why we want to withhold. We're saying medicine. The context we're trying to set is we're not saying we're treating anything in particular. This is a wellness treatment. You can try it. If you get better, great. That's all we're saying, because we're not making any claims. It's true. You don't know if the shoulder problem is a muscular skeleton problem. Probably the person that has it does know. But
Going to give you 30 seconds to wrap it up, please.
Okay. So we want practitioners to have their choice. There is a workforce shortage. New Mexico thinks they lost half their acupuncturists through COVID. I've tried to get my own training approved by the board. It's been a very laborious process. People asked about safety. Here's 2 safety reviews. I myself have treated about 10,000 people in disaster situations after Katrina, the Gulf spill. And so a person might get a little nauseous. I've seen about 8 people almost faint out of 10,000.
Thank you for your testimony. Will you take questions?
Yes, I will take questions.
How much of this have you done in New Hampshire? You're talking about all the people you train in?
I've trained about 60 people in New Hampshire that live in New Hampshire, and about 42
for auriculotherapy. You've
just
trained them.
for the 5 points auricular therapy.
Okay,
yes.
so you've trained them and they're doing it. Why do you need the bill?
Because they can't do a shoulder point. Because there's a guy who comes to Hope for New Hampshire Recovery Center who has a partially amputated foot. When I come and I put the points in his foot, he has no pain for a week.
I thought this was about the ear.
Yes, there's points on the ear for the foot.
Okay.
Okay. If I
So
had
you're
more
do- are
time,
you
I
doing-
could do a much better explanation, but
No.
we are where we are.
And you talked about addiction, and this helps with addiction, but it does not purport to treat any disease, disorder.
It's an
infirmity.
adjunct treatment. So we're not saying we're treating addiction. We're doing something that helps people who have addiction issues get their life together much faster. And this was started by community members, not professionals. Community members in the Bronx.
Does anybody else have a question? Representative Shapiro.
Yes, thank you. You mentioned that it doesn't say that no training is needed, but it says that appropriate training is needed. But it says on line 7A, has appropriate training in clean needle technique. There doesn't seem to be any other reference to training. And I wonder if you are saying that people should be able to do a greater number of points on the ear without any additional training.
No, that's not what we're saying.
That seems to be
That's
what the bill is saying.
I didn't write the language.
Okay.
What we did, they took the language from Vermont's law.
Okay.
So they put it exactly in New Hampshire's form from Vermont.
I would suggest that anybody, including yourself, who comes to testify in favor of the bill, testifies in favor of the bill and not what you wish the bill was.
Okay, so then we could have an amendment that specifies about training?
Representative Knurk.
Yes, I'm a little troubled because you keep talking about it. It almost seems like we're talking about semantics about what treatment is. The person who has phantom limb pain, the person who has a shoulder pain, and you're going to do something to them to help them with that pain, which I think pretty much everybody would agree is treating their pain. So I think it's quite disingenuous to say that you would not purport treating disease, and yet in addiction, I think even you use the word treatment there, that it's not the treatment, but it's a treatment, or it helps the treatment. That's treatment. And so this doesn't this line C, or well, line 9, just makes absolutely no sense whatsoever.
Okay, so again.
Oh, sorry, that was a question. Would you believe?
In addiction treatment, we do not say we're doing addiction treatment. We say we have an adjunct treatment to addiction treatment.
Follow up isn't adjunct treatment? Treatment. You've just used the word treatment. That is treatment,
Well, you're
is it not?
placing a needle, so.
But did you not use the word treatment? Adjunct treatment? Whether you put an adjective adjunct or not, you just said the word treatment, did you not?
Nobody has ever claimed that we were treating addiction. Just that we had something that people who have addictive issues seem to benefit for, which is the same with all of the rest. I can tell you about many, many positive results people have from ear acupuncture, but it's not going to happen for everybody. It's more that a lot of different things happen. Some of it happens for most people, but some people have no response. And that's why I'm not saying we're curing your shoulder issue, not even remotely. It may help. It may just relax you so you don't have anticipatory pain.
Okay. Representative Acton.
Following up on that, are you not allowed for liability issues to be able to say that you're treating something? So it's sort of like an herbal therapy that can't say, well, yeah, we do this because of the FDA or something like that.
Not really. It's really because I don't know if it's going to help you or not. So I'm not claiming that I'm going to fix this for you. I don't know. I can try this and see.
Any other questions? Seeing none, thank you for your testimony. The chair recognizes Elizabeth Kopp, and we're now in the 3-minute rule, and get the egg timer going, and you get to speak for 3 minutes, as does everybody else afterwards.
Hi, it's
Hi.
Elizabeth Ropp. Hi.
Rob, sorry.
It's okay. I didn't know that I was testifying today because we've been doing an acupuncture day, and we were
Well,
told only
you filled out a pink card.
I did. So I did bring my testimony. I don't have a lot more to add from what Laura has. I can just speak from my experience. I'm a licensed acupuncturist. I worked on the ADS law in 2017. And then after that, I volunteered for Hope for New Hampshire Recovery. I ran a free weekly treatment on Tuesday mornings for the next 3 years until the pandemic hit. And I treated a lot of people with the NADA protocol. Occasionally, I would add additional points because I'm a licensed acupuncturist and I can do that. And then in 2019, when Vermont changed their law, then Laura Cooley arranged for Dr. Tom Corbin, an auriculo specialist. He's an acupuncturist. He's a physician's assistant. He's a PhD. He came up and gave a training in German auriculotherapy for pain relief, stress disorders, and addictions. And so a number of us gathered. Jeff Davis, who's here, who's planning on testifying, he's a a licensed drug counselor who's not a trained. He joined us for that training, and a number of other people from Vermont, New York, Canada came down. It was a wide variety of practitioners, acupuncturists, massage therapists, social workers, nurses, doctors. We had we had a PhD anthropology candidate who joined us, and we learned more protocols and more techniques on the ear. And, coming back to New Hampshire, Jeff Davis now has this training but he can only use the 5 NADA points. And so one of the things that we learned in that training from Dr. Tom Corbin is there may be some auricular protocols that could be more effective for certain types of substance addictions. Like, for example, an addiction to crack cocaine might respond better to some points in the ear than, say, the NADA points. And honestly, I even want to give some pushback on, Dr. Tom Corbin's claim, because I think the NADA protocol works really well, but I also want to test that out and see how that works. We did have someone who got NADA trained here in New Hampshire. She was in the military. She was practicing on a base in Hawaii, and she kept asking us, okay, can someone needle the master oscillation point on me? And we said, no, in New Hampshire, you can only use the NADA protocol by law. We can't use the master oscillation point. And by the way, where is that one again? Is what I asked her, and I looked it up, and I use it a lot now since. But she has that prior
You use
training.
it a lot in what state?
Well, I personally can use that point
Oh, you
because I'm an
can.
acupuncturist.
Sorry, yes, you're right.
But that military person who got trained in the military in Hawaii could practice it, but here in New Hampshire could only practice the 5 NADA points, even though so that's training that she can't use here in her own community.
Thank you so much. Will you take questions? Representative Weber.
Isn't it true that when you were testifying, though, you were still talking about using these extra points to treat something that is a disease, a disorder, an infirmity, or an affliction? And when you say that, you are violating the terms of the bill that we have in front of us, which is, perhaps for most of us, the concern we have here is not the concept, but isn't it true that the wording of the bill forbids you from ever saying that? Not you, because you're an acupuncturist, you may say it, but anybody else who wants to practice under this. And frankly, isn't there a contradiction in the bill itself, because the very word auricular therapy implies that you're treating something? So isn't it true that this needs to be reworded with appropriate language on training and on what you can claim, so that people can actually be trained in and use techniques that might be helpful?
Sure. I mean, and I think that Representative Knurk made a really good point. It could just be, a lot of semantics. When I'm in my job as an acupuncturist, I talk about treatment. And then when I'm volunteering doing, not auricular therapy, I'm just saying I'm here to just support people with all stages of, addiction recovery. And so sometimes I might not take the hat off at the right time.
Any other questions? Representative Kofalt.
Yes, so thank you for taking my question. So, terminology aside, and there are potential concerns there, I don't mean to dismiss them, but I guess I'm trying to understand the distinction between, I see a parallel that Representative Acton brought forth with the idea of supplements. The FDA, for example, does not permit makers of supplements to make specific medical claims that they treat certain diseases and so on, except in rare circumstances. So there's a specific prohibition against making claims, and I take vitamins and supplements. My family does. Sometimes they work for some people. Sometimes they don't work for others. So I guess I'm interested in your opinion on that, and do you see a parallel there to your experience as an acupuncturist?
Yeah, I could. I mean, we have people who come in all the time who say, I don't know if I believe in acupuncture. And then I'll just say, well, you just have to try it and see if it works for you. We can't claim that your back pain is going to go away. You just have to try it and see. And we give them a recommended treatment plan, and from there we see what happens.
Follow up.
Thank you, Mr. Chairman. Are you aware of any safety statistics that would point to substantial risks or lack thereof around the passage of this bill?
That's a good question. We don't have a lot of data in auricular therapy in this country. Laura did provide some studies that have happened in other countries. What we can really only fall back on in this country is that there are not there are not very many malpractice. I don't know how many malpractice claims have ever been filed, but it's not very many. As of 2016, there was not a single malpractice claim for auricular therapy for 30 years from the largest acupuncture malpractice insurance company in the country. I can say that.
Representative Gay.
Thank you very much for coming. And are you comfortable with the wording so that it has the same kind of, we're not claiming to cure you, just the same as the vitamins? I'm take lots of vitamins. I don't find any threat to auricular therapy at all.
I am open to working on the language some more, but I'm also okay with it as it is. It's just a matter of saying we're not claiming to treat, we're claiming to support. This might help if you want to try it.
Thank you so much for coming. The chair recognizes.
I had a question, sir.
Okay.
Yeah, just, would you believe that there really is not a strong correlation between complications and malpractice? I had many complications in my practice and not a whole lot of cases against me. Yeah, so would that perhaps not be valid data for the rate of complications to look at the malpractice rate?
We have had this conversation. I think you make an excellent point.
Thank you.
Thank you. The chair now recognizes Jeff Davis to come up, and we are in the 3-minute rule. He is in support of the bill.
I am. Hello, my name is Jeff Davis. I'm an MLADAC in the state of New Hampshire, also an ADS.
What is that?
An acupuncture detoxification specialist. I'm
Thank
one
you.
of those people that is trained and can do just the 5 points. I have seen this practice be very helpful for a lot of people in supporting their recovery. My experience is that most people find it relaxing and reducing their stress levels, allowing them to work harder in their recovery. A lot of people, where I volunteer at Hope to do this because nobody makes a living out of it, a lot of people just keep coming back and come specifically to Hope for that, and then spend time working with others. This is a practice that supports people's efforts in recovery. I'm not going to say it treats their substance use disorder, but as Elizabeth said, it would be great if I could also needle points for stimulant use disorder, because the NADA protocol was developed around an opioid epidemic. So being able to add points that could help people with recovery from stimulant use disorder would be awesome. There are also points that help people manage anxiety more effectively, and points that help people focus their attention more effectively, points that make people less emotionally reactive. And I personally would like the opportunity to use some of these additional points with people who have substance use disorders and mental health disorders that they're struggling to recover from every day.
Questions? No questions. Question, Representative King.
Thank you, Mr. Chairman, and thank you for taking this question. And it's just a clarification question. We were talking about 5 points, and you just mentioned additional points. So is this beyond the 5?
Yes, the NADA protocol, the thing that I'm allowed to do now in New Hampshire, thanks to training and giving money to the state to let me do it, those 5 points are the only ones in the year that I can officially needle, and I don't do any other points except in my years. Sometimes I do other points because I'm not going to sue me.
Yeah. That's good.
So there are additional points on the ear that can be supportive in recovery from stimulant use disorder, that can be supportive in recovery from anxiety disorders, that can be supportive in recovery from attention deficit disorder, trauma. That there are a host of points that we could use to help people in their recovery. And that's all I really want to do. That's been my whole life, is helping people in their recovery. And anytime I find a way that I can help people do that more efficiently, I want to do it.
Follow up.
So that would, that's not what this bill is about. That's the way I understand that. Is that correct?
This bill is about allowing people like me to use additional points in the year, like the points for stimulant use disorder or points for helping with anxiety problems.
Thank you.
Representative Weber.
But isn't it true that this bill would also allow people unlike you who have not taken the NADA training or any other training except for clean needle technique to insert needles into any particular part of the ear without a specific requirement of any training at all, even the NADA training that you took?
In looking at the language after listening to these conversations, I do see that that might be a problem. I believe that the intention of what was put forward was to allow people like me to be more helpful. So,
Thank you so much for your testimony.
thank you. Hopefully it was under 3.
It was. The chair recognizes Diane. Pronounce it for me. That's the one. You said it much better than I would, but you've had a lot more practice.
Thank you, everybody. My name is Diane Chase. I'm a licensed acupuncturist in the state of New Hampshire. I've owned my own practice for 7 years, and today I'm coming just to address a couple of points. Most of them have been addressed by other acupuncturists that have been here. This past winter, my clinic actually hosted an acupuncture detox course. It was a 2-day course. I was there as one of the students, but also as an assistant. And some of the things that I did learn about this course is that, which was previously mentioned, sometimes fainting, bleeding. But one of the things I did not know is that, and I actually observed, is that I saw a number of the students, because you're not supposed to hold the ear because of potential for blood-borne pathogens. So you're not supposed to hold the ear because the needle could easily go through the ear. So what I did witness on a few occasions that the needles were going through the ear, because some of the students, you know, because they're still learning, had not the best control. So therefore the needles were going through the ears on, you know, if we had approximately 18 students, so I'm going to say it probably happened about 4 or 5 times. So that's one of my concerns. Another concern of mine is my previous career as a registered nurse for 23 years. I worked in mostly acute care settings, but I also taught nursing for 10 years. So I was very much in the teaching position. So also in my practice as an acupuncturist, one of the things that I recognize as both a nurse and acupuncturist is that when somebody says they have shoulder pain, it can mean many things. I've had clients who have shoulder pain, and if it doesn't respond fairly quickly to acupuncture, I usually refer them to the doctor, because shoulder pain could be a torn ligament, it could be cancer, it could be a number of things. So my concern is people who are doing this untrained, especially untrained in anatomy, physiology, untrained in, you know, Western medicine, diagnosing, you know, any sort of condition which this bill doesn't really address. So those were my biggest concerns that
We're going to give you another 30 seconds.
That's pretty much it. That's all I want to put out, is mainly just side effects, not knowing or understanding what other conditions could be present outside of just pain.
Any questions? Representative Gay.
Thank you very much.
Welcome.
Do you have to, is there really any harm in putting a needle in, if you keep the needle clean, if you handle it properly, is there any harm that could be done, like putting the needle in not exactly a 5-point?
Well, there are some exceptions, such as pregnancy. And there are a number of points that are contraindicated in pregnancy. There may be, actually, I found a study which I don't have in front of me, but I did find a study where there are some points actually related to the heart, and there was testing to show that it could actually change the heart rate, which could be concerning if somebody had cardiovascular disease. Hypertension, it can be it's contraindicated. And so I guess my biggest concern is that, you know, if people are untrained and randomly putting points in people's ears without really truly knowing the human body and understanding disease, anatomy, and physiology. So yeah, there can be harm.
Any further questions? Representative Knirk.
Just a quick one. Does the cartilage of the ear, does that represent any specific risk in terms of infection or other things?
Well, I would imagine just like ear piercing, which can cause infection, and I've seen a number of times. But yes, cartilage, there are points along the cartilage on both the back and the front of the ear that can be needled. That there's like at least 200 or more points on the ear.
Seeing no further questions, thank you so much for your testimony.
Thank you.
The chair calls David, and I cannot read your last name. Okay. Could you spell that for me, please? N-A-G.
Bagel with an N.
Okay. Thank you.
I do have written testimony that you should all have.
And you are from the New Hampshire Medical Society?
I represent the New Hampshire Medical Society and the American Academy of Medical Acupuncture on this.
Thank you so much.
So I'm ready. Thank you.
3 minutes, go.
Yay. So I'm a physician. I've been practicing pain management and physical medicine and rehab in New Hampshire for the last 32 years. I actually helped create G28, RSA 328G. That was one of the things that I helped do because we thought that it was important that New Hampshire people had increased access to acupuncture. I will argue everybody on this side of the table all united that this modality has a lot of value, and we do want to increase access to that. In my other life, which is my more important life, I've been advocating for the rights of people for chronic pain, mental health disorders, and addiction for the last 32 years. I've written a book on this, and I also chaired and have the lead author on the NFL Players Association statement on this subject. We believe that acupuncture is really important. The issue that we're discussing here today is not, does it have value, should it be done? It's who should do it, and that's what the whole point of this bill is, and that's why we oppose this bill. I would like to draw your attention to line 1 of the bill where it says, an unregulated practice, having helped author whatever number that was, G28. I would take issue with that auricular acupuncture is in fact regulated, and that should be changed, and that's not accurate. Secondly, I would also say that I have a couple big issues with the rest of the bill. Number one, we've already talked at length about education, and I don't think we need to get into that anymore, but I will say that this is not fair. And the reason why I will say that is, as a physician, for me to say that I can do something that I've really not been properly trained to do is basically unethical, and I brought all the oaths that we swear to that say that I can't do that. So why should they be able to when I can't? The second thing has to do with line C that we've already talked about, and does not purport to treat any disease, disorder, infirmity, or affliction. The most common reason doctors are sued for malpractice is lack of providing informed consent. That whole line there says a person with virtually no training, and you guys are really well trained, I'm sure. So are you guys. I'm not so well trained because I'm a doctor, but I mean, you know, for me to do that, to not inform a patient what I'm doing, why I'm doing it, how I'm doing it, what the risks are, that is not just unethical, it's malpractice. And just because somebody chooses to not sue me for it doesn't mean it right. And this codifies that in New Hampshire state law. And frankly, that line has to go. The last point I did want to make is I've been involved in the whole CBD discussion, the whole magnet discussion, the whole supplement discussion, all this thing. You know, as you said, Representative Kofalt, if you try to say that something, for example, an FDA supplement, if you try to make a structure function claim, that's totally illegal.
The reality is everybody does it every night on late night TV. That line there is frankly unenforceable.
We've hit the 3-minute mark. Would you take questions?
Sure.
Representative Acton.
Thank you, Mr. Chair, and thank you. What's the worst adverse reaction you've ever seen from acupuncture gone wrong?
I'm really glad you asked that question because we've been trivializing acupuncture as just sticking needles in people, you know. And so we've been focusing on risks from adverse effects from placing a needle. Like the worst one I ever saw was a pneumothorax when somebody put a needle in their chest and it punctured their lung. Yeah, that's a bad one. But that's not the issue that we were all, and to be honest, this was a discussion that we had back when we were looking at our SA 328 was guy comes in, you know, to see an acupuncturist with backache, you know, he's thrilled because he lost about 28 pounds. He's got night sweats. He's not sleeping at night. His pain is worse at night. And he goes and sees the acupuncturist, and the acupuncturist says, oh, I can stick a couple needles here in my ear, whatever, I'll make you all better. And they miss prostate cancer metastatic. So I think you'll read in Dr. Gendron's statement that he gave to you the importance of acupuncture being a holistic practice. It's not just sticking needles. It's us working together as a team of professionals. And my big concern is you're now allowing anybody on the street who's not willing to be part of my team, and I'm not willing to allow them to be part of my team either, to put people at risk because they're going to miss important diagnoses. And I think that that's the issue that nobody ever talks about, but it is the most important issue.
Any other questions? Representative Knirk.
Back to this issue of the line 9C does not treat. And we've had this comment about the semantics and adjunct treatment was not treatment that was curative, but is it not true that many of the things that we do in medicine, particularly you and I in back pain, are not curative, but they are still a treatment? Is that not correct?
Well, that's you because you're a surgeon, but I'm a physiatrist. We cure everything.
The word to say to that I can't say in public.
I'm sorry. I really couldn't resist that. I've been wanting to have a public forum to say that. I really agree with a lot of what you said, and this is what I hope comes out of this. Number one is this really shouldn't pass, and I think you're almost kind of saying that, but with the way it's written. But at the same point, this is what I really think, this is what's really been great about this, is you've brought us all together to talk about this issue. Because I'll be honest, the biggest thing that we're working on, even in NFL players and retired NFL players, is access to care. And right now, with the way things are, is we pay for pills and procedures. We don't pay for this kind of thing, or we don't have access to this thing. So there's very little incentive for somebody to want to be an acupuncturist. So I think that's the one good thing that came out of this, is that.
And this could well be that the discussion could continue, and maybe next year you could come back with a bill that answers all these objections. The chair would now like to call, thank you, Doctor. The chair would now like to call Cindy Thoreau Light, or someone whose real name is similar to that.
I look like her and I am her.
Right.
Hi, Chairman Pearson. My name is Cindy Tiru-Jetty. I know, it doesn't look like that. Theroux-Jettee. We French people, instead of saying Thoreau, will say Tiru-Jettee.
Thank you for pronouncing it right.
So no problem. I won't test you on that later. So I just first want to say I am the chair of the Acupuncture Licensing Board for New Hampshire, and I hope this doesn't count too much against my time, but it was really a pleasure speaking with all of you. I don't do this often.
Compliments are never deducted from your time, but start the clock.
I looked at your backgrounds and your bios, and I was really, really impressed. I'm glad you're all sitting on HHS because we need qualified people doing that. So that's all about that. Thank you very much for what you're doing.
Give her another 20 minutes.
That wasn't meant to get more time. My background is I serve as chair. I am a licensed acupuncturist, 20 years of experience. I'm also a licensed occupational therapist with 30 years of experience. As you know, the licensing board does oppose this bill. Online, you have lots of opposition as well. My last check, there were 57 people opposed and 3 or 4 people in support. So we don't need a new law. There was a law enacted in 2017 to certify acupuncture detoxification specialists, and they're out there and they're working. We have had some interruptions with the pandemic, so obviously that law has not been given full enough time to see the outcome. This is most definitely acupuncture. I've heard some testimony that it's not acupuncture. This goes back to the Huang de Neijing, which is an ancient medical text in China. It was mapped out on the ear, the acupuncture points. It has been modernized by other, some doctors and whatnot, but it's most definitely acupuncture. Deregulating this practice is not the answer. We have a law that works. And I don't care what's going on in Denmark. I don't care what's going on in Vermont. My job as chair of the Acupuncture Licensing Board is to enact things that protect the people of New Hampshire. That is my interest, and I think probably most of us want that. I don't think this law works in that, this bill would work in that effect. Competency is key in delivering any type of care to the public. These acupuncture detox specialists that we have out there, they actually have 30 hours of classroom training. The other 40, there is a total of 70 hours. The other 40 hours are actual needling time where they're out needling people in practice hours and they're overseen by a licensed acupuncturist. So I don't believe that the training is excessive. The board has 2 training programs that it's already approved. We were waiting on a 3rd program to be approved. Sent lots of emails trying to help the person get it approved and never heard anything back. So NADA, National Acupuncture Detox Association training, is automatically approved by the board. Anybody who comes with that gets approved. If NADA standards have changed, then the board needs to know that. We have a set level of competency, and we use the 2017 NADA training manual as that level of competency to turn out qualified people. If NADA's training standards have dropped, we need to know. There is a shortage of people to provide healthcare and acu-detox and ear acupuncture. But the answer is not to turn out unqualified people. There's a shortage of truck drivers too. So what do? Say, okay, let people just drive trucks with no training,
10
no
seconds
supervision?
more.
All right. I'll get there. 5 points are sufficient to do what we need to do with this population, to cause calm and relaxation. We don't need more points that are under the purview of other people like licensed acupuncturists who are licensed and able to diagnose East Asian medicine diagnosis. There's a tiered level of care in healthcare.
Going to
Doctors,
stop you
nurses.
now, and will you accept questions?
Absolutely.
All right, any questions? Representative Weber.
Could you continue to make your point about tiered care in medicine?
Sure, absolutely.
Well done.
Thank you, Representative Weber. So in medicine, some of you may know, there is a tiered level of care. So you have, at the top with the most training and the most education also carry the most risk in terms of delivering care to the public are physicians and DOs. Below that, you have nurse
You mean
practitioners.
MDs and DOs?
Yeah, MDs.
Thank you.
Medical doctors
DOs
and
are, I know, I
doctors of
employ one.
osteopathy.
DOs are physicians.
Yes, MDs and DOs. Thank you for the correction, Chairman Pearson. MDs and DOs, and then there's PAs and nurse practitioners, and then below that are master's level nurses, and then bachelor's level nurses, and then licensed nurses aides. So within all of that, what these people are able to do is dictated by their level of training. So that exists here. With the law that is in existence now for certified acupuncture detox specialists, they are allowed to do certain things, the 5 points, which are effective in causing a relaxation effect and helping sleep and whatnot. Anything beyond that really goes into the more education and training for a licensed acupuncturist. Does that answer your question, Representative Weber? You're
Wonderful
welcome.
question. Any other questions? Thank you so much for coming and sharing your testimony.
Thank you for your time.
And this ends the hearing on 290. And it doesn't have to be out the door today, so it's not going to be. But we have a few others, and I'm not going back to the big bill right now because my vice chair has been working with OLS and the fourth floor to fix that .7 concern we had earlier. So it doesn't have to come from the floor, it can come from the committee too. So I would like to open the executive session on 275. We heard this last week. It has to be exec today. 275, an act relative to the opioid abatement trust fund. Senator Rosenwald brought this bill to us, co-sponsored by Senator Susi and our very own Representative Acton. So if you have that material handy or your computer can find it, we're going to do 275. The testimony from Wendy Piper, the president of the New Hampshire Association of Counties, says this bill would ensure that allocations are distributed to the litigating parties based on the 2020 census data rather than the 2010. It's important this change is made to ensure that funding matches the population allocation to ensure that the funds are available to those in need. I'm not saying I agree or disagree. I'm just trying to refresh our memory. Also, we got something from our friend Kate Fry from New Futures, who said, we've heard time and time again, the prevention and early intervention strategies can reduce the impact of substance use communities. So we're in exec session, so it doesn't have to be a question you can share. Representative Leon.
Thank you, Mr. Chairman. This is one of the areas that touches my town because dairy is one of the ones that filed. But with the testimony that I heard, since I went back and watched the whole thing, and the fact that I haven't been reached out to from my town council, makes me think that makes me think that my town is not specifically asking me to bring home money this time. So I just wanted to put that in out there.
Wow. Representative Shapiro.
Piggyback on Representative Leon. My city manager did contact me and asked me to assert that we should, increase the amount for towns that had filed suit to at least 30%, if not 40%. But I would say that I was so convinced by the testimony here that that would be an unfair and inadequate way of using the monies that I was able to get back to her, and she agreed that leaving it at 15% was the right thing to do.
Representative Leon.
And I think probably another good point is that allocation can happen in that next committee. And I think probably moving it towards them makes sense.
Right.
Representative Edwards is not here to hear that good news, but this is coming to you too, boy. Anyone else? Representative Acton.
There's, thank you, Mr. Chair. There's several bills winding their way through. One was, there was a bill that specifically dealt with the portions and who gets what, and that was sent to study. This bill here actually changes some aspects of the law that we felt was important. First thing it does is it makes the change based on census. That's pretty straightforward. Then there's some language as far as timing and so forth. But the big changes here are the additions to the points that are made in the law that stipulate how the money can be spent. And there was originally 14 points in the original law, and there was no reference in those 14 points to any kind of preventive uses. It was all about after the fact, once treatment and so forth. So I wrote up an addition, which became point 15, to allow a variety of uses for prevention of community services and so forth, with the express intent of allowing anyone to create programs, whether it's a community center or something. It wasn't specifically within the government, and certainly wasn't within the schools. Then what happened was the representatives from the school system came in, and they had language that would allow any school to create a mental health program and then bill the cost of that against this the opioid fund, which we realized would use most of the money right there. And so the decision was made to add the information related to prevention. Then point 16 was created that narrowed down what the schools could do to treat specific drug addicted individuals or drug affected individuals with specific programs, not just this wide open thing that could create it. And so that was agreed to, and so we came forward with that, and that's what we're looking at. We're not changing the percentages really here. We're changing some of the language.
Would it be appropriate to make a motion at this point?
Well,
I move that Representative Acton make a motion.
Thank you for
All in
reminding me.
favor
It's been a
of,
long day. I
the
haven't
honorable
eaten
lady?
since 12
Thank
hours ago. Yeah, I would like to move to pass HB 275.
And could we have someone from over here? And we do. So motion is ought to pass, made by Representative Acton, seconded by Representative Weber. And we still have opportunity for further discussion lasting 3 seconds. Would the clerk please call the roll?
Okay. Representative Leon.
Yes.
Representative McMahon.
Yes.
Representative Acton.
Yes.
Representative Gay. Yes. Representative Mooney.
Yes.
Representative Folsom, yes. Representative Bohm.
Yes.
Representative King.
Yes.
Representative Kofalt.
Yes.
Representative DeLamus. Yes. Representative Weber. Yes. Representative McKay. Yes. Representative Snow.
Yes.
Representative Knirk.
Yes.
Representative Soloway. Yes. Representative Cannon.
Yes.
Representative Nutter Upham. Yes. Representative Shapiro.
Yes.
Representative Woods.
Yes.
Representative Query.
Yes.
Representative Pearson.
Yes.
21 to zip.
Consent. And Representative Acton is going to be the proud.
Point of information while we're getting that together. Just to let everyone know, we're getting about $110 million in over the next 15 to 18 years. The companies that were sued, like Purdue, used every trick in the book to try to get out from underneath this with creative bankruptcy techniques and so forth. And then they spread it out over 18 years. So I consider this blood money. This was money that we're being paid back for incalculable human suffering. And so it's going to be an effort to make sure that this money is spent with the laser focus on opiate eradication and not get pulled off into other things. So that's our goal. Thank you.
Thank you for your work on this. Representative Soloway.
Mr. Chairman, we've been in this room with a brief break for lunch for 10 hours.
Uh-huh.
Is there a way to recess this meeting so that we can go home to our families and our dogs?
The deadline for us is today. We have 4:44, and then we pick up the big one. Hurry up. So if someone needs to leave, someone may leave, but I don't know a way around this. Representative Shapiro.
I'm reluctant to say this, but I will say it. I think that people can take responsibility by just limiting how much they comment on every.
I would agree, and have
I
been
think
saying
that we're not necessarily that disciplined about doing that.
No, we're not. We all have
Some of us more than others, but
very high IQs and great speaking skills. So whatever that was, that is closed. And now I open the exec session on Senate Bill 444, We heard that while we were young this morning. Thank you, Representative McMahon. Relative to childhood adverse experiences, treatments, and preventions. A whole lot of Democratic senators and Republican senators, Hennessy and Carson, co-sponsored this and came over to us with a couple of Senate amendments attached, and what we've got is the bill before us. 444. And I'd like to start with the discussion.
I'd be glad to make a motion.
You can. Well, so can you. Anybody can make a motion.
I defer to Representative.
She gets to write the blurb.
Thank you. Then I would move ITL on the bill.
Okay, Representative Leon moves ITL. Do we have a second from Representative, nobody over that way, Kofalt? And discuss your motion, please.
Thank you, Mr. Chairman. I appreciate that this age group is one that is definitely impacted, but it seems that we're having trouble even serving those children who are older at this point. I did speak to some people who have children that experienced severe issues during that time period who were Medicaid families, and they were able to get the care. I know that's not everybody, but I would rather make sure that we're dealing with as tight a weave as we can to catch as many of these kids within a certain range before we start spreading it and opening up those holes for more people to fall through.
Representative Folsom.
As part of one of the many commissions I'm on, I can't remember what, I had a chance to be a part of the team that interviewed Ms. Sanchez. And we also heard other things about some reports that are coming out and then some of the things that she might like to do. I would like to not plunk this down on her. I would like her to have a chance to get her feet on the ground and then figure out which of these parts she wants to put together and move forward with, rather than come up with a bill that might not even be part of their overall plan that they've come up with, which we haven't seen yet.
Representative Weber.
I want to point out that this bill is not for the implementation of the Office of the Child Advocate. This bill is a part of the 10-year mental health plan, which has been developed and refined over years and years and years. And it is the policy of the state. And this is implementing another part of the 10-year mental health plan, all of which we need to implement. And picking winners and losers doesn't seem to me to be a great way for the legislature to be behaving. I think adverse childhood events affect all of our children, and perhaps more than we understand with the youngest of our children. And I will be opposing the ITL. I sort of thought we'd had consensus on this one, so I should have jumped in quicker, but I will be opposing the ITL.
My thoughts on this is if it's part of the 10-year plan, it could have been in the budget we did a year ago, or it could be in the budget we're going to do a year from now. And I get a little concerned when we get lots of little mini budgets popping up in the middle when we do a 2-year budget thing. That's just my piece. Representative Shapiro.
Yes. A couple of years ago, I served on a legislative committee that studied ACEs. And it might seem to some people like this is just coming out of the blue, but I think this is part of many years of study and many years of recommending specific solutions to specific problems. And I can speak specifically about our local mental health center, Monadnock Family Services. Community mental health centers have a lot of difficulties. They're tremendously underfunded. They have a hard time recruiting staff. They have a hard time paying market value salaries. But one thing they are able to do sometimes is provide people with expert training so people grow in their careers and people feel competent at working with very difficult people. And part of this bill would do just that, the money that would train people around the state in child parent psychotherapy. So I think it has incredible value. And so I would vote against ITL.
Let me respond to that. I agree with everything you said, except for one thing. If it was that valuable and it's been in the pipeline this long, why didn't we do it as part of the big budget a year ago, if it's that important? And I still kind of, I don't know, think the budget process is very, very important and don't like a lot of little mini ones coming up in the way. Even if they're good, they'll be good next year. I think you may have an answer to that, Representative Weber.
Well, in response to that, I would say that we have now a far better understanding of how much money we have available to deal with these things. And
You're talking about the
because-
huge surplus we're generating.
Yes, we have a huge surplus and we have a huge need. And now that we know we have a huge surplus, where it might have been prudent when we were discussing the budget originally to not fund certain things that we were very much in favor of, which we do every year, we have to pick and choose. Now we know that there might be $700,000 lying around somewhere that we could use for a very important purpose.
Would you believe I find you very convincing sometimes?
Oh, I would hope so. And it's mutual.
Thank you. Representative Shapiro.
Yeah, I would just, I don't want to beat a dead horse, but I will just give the example of the dental bill that was passed in 2020. Everyone thought it was a great idea. It passed the House, it passed the Senate. There were no exceptions like there are now. Governor Sununu vetoed it, and to his credit, he said that he supported it, but he was thinking that there were going to be COVID-related budget shortfalls, and he couldn't support it then. And hopefully he will support it if it makes it out of the House and Senate this year. And so I'm just piggybacking on what Representative Weber said, that we're in a different place financially to be able to spend money to do things that we should be doing.
And thank you for not throwing in my face the fact that I worked really hard with you on that and spent a lot of money even though it wasn't in the budget. So thank you for not saying that. Representative McKay.
Thank you, Mr. Chairman. People have heard me say over and over again that we should be using the 10-year mental health plan as a guide. And that is available to us, and I got a copy from every single person in this room to use it. And there is information in there about this subject. I thought it was going to go the other way. I was very surprised to get this motion. And I'm not going to hurry. I don't like that when somebody's telling me to speed up. And I know that man from way back. This committee, I think, has been very cognizant of the importance of mental health issues. Here's one that is perfect to activate and get moving. So I'm going to vote against the ITL, of course.
Representative Leon.
Thank you, Mr. Chairman. This unexpected surplus, we also need to think about what might be driving it and what might catch up with it as well. We had higher spending, which led to higher taxes, but we also have over 8% year-over-year increase in inflation. And the state has to pay for gasoline. The state has to pay for heating. The state has to pay for a lot of these things that are also increased by these increasing prices that drove the higher taxes. Starting up a new program and having this commitment to do something that we might not be able to afford come next budget, if inflation does come and hit us hard, I think would cause, well, if, but it probably will. When we look at this, it just might end up starting something up that we can't continue. And I want to make sure that our program that we have is what we already have going is solid, because we have workforce issues. Yes, I know there's money that goes to it. Why aren't we putting it to some of our existing programs to make those more resilient at this point, as opposed to spreading thinner?
Representative Weber.
And I would just say regarding the financial aspect that we should render unto Caesar that which is Caesar's and render unto the finance committee that which is in the purview of the finance committee.
I've heard that.
And we have little tiny people who need treatment, and that's what I'm going to vote for.
Representative King.
I know I'm on the other side, so I'm a little surprised by this too, and I'm very active within Milford, and Milford has a very good ACEs program and a very good Milford Thrives program, which serves the kids that are between the ages of 0 and 5, and there's a lot of support within my community, so I'm going to have a hard time voting for the ITL. Sorry.
Representative Cannon.
Thank you. I don't say a lot, but I'm on the Somersworth School Board, and we spend a lot of money on paraprofessionals and IEPs for young students, students that have come from families that are challenged and have special situations. And that area, our area over there, we have ACEs programs already, especially in Dover, and it's used in our city as well. So I will not vote for the ITL.
Thank you. Representative Knirk.
I'd like to go back to what was said during the hearing. I think it was on this, and that was the Ben Franklin issue about a ounce of prevention is worth a pound of cure. The issue is that this is extremely critical because it changes people's lives forever. The first time I ran across ACEs was about 20 years ago at a North American Spine Society meeting in which we had a paper presented that the most common correlate for people with chronic disabling low back pain, which is an extraordinarily expensive problem in our country, was the presence of adverse childhood experiences. Yes. It didn't fit with the x-ray findings. It didn't fit with anything else. ACEs were most predictive of somebody having chronic pain later on because of the psychological changes that came up. This was people who couldn't cope with it and chronically disabled. So this is a lifetime ruining experience. The goal is to intervene early, fix it while we're still young, as Charlie would kind of sort of say. So I think this really, I would vote definitely against the ITL. This bill should pass through.
Would you have access to that paper that was presented?
Yes, I can still remember I'd have to go dig it up because it was quite a while ago, but I'll see if I can find it for you.
I appreciate that.
Yeah.
No rush. I'm busy the next
little
while. Yeah. Thank you. Anyone else? Representative Gay.
Yes, I'm just wondering who's been paying for the ACEs programs right now. I'm glad there are some. And a person who has 4 out of the 10, they narrowed down adverse childhood experiences. They started with 50 and narrowed it down to 10. People who have 4 or more, their life expectancy is 12 years shorter than the rest of us.
Anyone else? The motion before us on the bill 444-FN relative to childhood adverse experiences, treatment prevention. The motion before us is ITL, made by Representative Leon and seconded by Representative Kofalt. Whose ever turn it is, please call the roll.
Representative Leon.
Yes.
Representative McMahon.
No.
Representative Acton.
No.
Representative Gay.
No.
Representative Mooney.
Yes.
Representative Folsom.
Yes.
Representative Bohm.
Yes.
Representative King, and that will be a no. Representative Kofalt.
Yes.
Representative DeLamus.
Yes.
Representative Weber.
No.
Representative McKay.
No.
Representative Snow.
No.
Representative Knirk.
No.
Representative Soloway.
No.
Representative Cannon.
No.
Representative Nutter Upham.
No.
Representative Shapiro.
No.
Representative Woods.
No.
Representative Query.
No.
Representative Pearson.
No.
All right, we have 6.
15 to 6, the motion fails. Somebody who wants to write the blurb will be recognized for a motion. And you're all pointing at Representative Shapiro. What is your motion, sir?
I guess I'm the person. I move ought to pass on Senate Bill 444.
And second by, would be helpful for me if a Republican wishes to. Good politics, Jim. Yeah, okay. Thank you by Shapiro and McMahon. And the motion before us is ought to pass on Senate Bill 444-F, and the motion ought to pass made by Representative Shapiro and seconded by Representative McMahon. Next up, call the roll.
Representative Leon,
No.
Representative McMahon. Yes. Representative Acton.
Yes.
Representative Gay.
Yes.
Representative Moody.
No.
Representative Folsom.
No.
Representative Bohm.
No.
Representative King, yes. Representative Colfault.
No.
I'm sorry.
No.
No. Representative DeLamus. No. Representative Weber.
Yes.
Representative McKay.
Yes.
Representative Snow.
Yes. Yes.
You only get
You
one.
only get Representative Kinner.
Yes.
Representative Salloway. Representative Cannon.
Yes.
Representative Nutter Upham. Representative Shapiro.
Yes.
Representative Woods.
Yes.
Representative Query.
Yes.
And Representative Pearson.
Yes. 15-6, the motion ought to pass. Passes. Close the exec session on Senate Bill 444. We only have 2 items left.
Minority.
Oh, I'm sorry. Let me get my chart out here. Representative Shapiro will write the committee blurb. Who is going to write the minority report? Well, no, but I'd like to give him a chance in case.
I'll let you know before we walk out of the room.
Okay. All right, before Leon goes away. That's good.
Do we know what motion that would be?
I'll let, if we're gonna do one, I'll let you know what.
Okay.
Okay. We've got only 2 items left, and both have to do with 430. So we reopen the executive session on Senate Bill 430. Still coming to us is the patch job, which will honor the concerns that former Representative J.R. Hole brought for item 7, and honor the thing that we saw that we didn't want to drop out. That's in the process. But the one we have right in front of us now, and it's big, is an amendment 1476, which amends the bill after section 14. Fasten your seatbelts.
It's coming around.
430.
You want me to walk?
Let them all get a copy in front of them and then walk them through it. You see how John Williams does it so well, huh?
Don't freak out until we actually go through it, because something's just moved.
You reserve the right to freak out at a later date, however. Yeah, okay. I know. I mean, how many committees have 3 chairs and 2 clerks? You know, this is why. We have an extra one. If there's an extra,
We have extras down there.
okay, I'll go find an extra. Anybody else need amendments? I could use one. Anybody else want one?
I'm using the restroom.
Um, okay, yeah. And we might want to do what we did before where I'll go through side by side. Yes.
If you explain it, because otherwise
Yeah.
we're all going to be sitting here trying to annotate, and
Right.
my outrage at receiving something that looks like this at this time knows no bounds. Yep.
We started working on it much earlier today.
It's moving things around, but we don't know because we have to be able to compare.
Well, and I can do that for you easily and show you where the numbers come out and what goes, what happened to where and.
Just getting rid of it.
I'm waiting for Chair.
Could I ask if our chair isn't here and everybody else, does anybody other than me need a potty break at
Yes.
this point? Yeah.
Sounds good.
Oh. This is true. I wouldn't point that out.
I got a lifetime of.
We might have gone, but that was the thing to put it. It was just, I told them that. And they didn't make.
So, Jason, you, Josh, once again, another long day of coming on.
I'm bad at saying
Jeremy calls me, I went.
Well, yeah, Lucy asked me at our last house session. She's like, we need to stop at 12. Can you do it? Yeah, oh, quick. So, I didn't realize it was going to be almost 11 hours. But you know what?
That's why I voted.
Oh, right. I am much, Jim said it earlier about how only checks every 6 months for mileage reimbursement. When we had it at the sportsplex, I was the closest to the sportsplex.
We are back to the exec session on SB 430, and Representative Folsom, you've worked with a couple of people here, and walk us through slowly. Representatives Weber and Knirk quite rightly said we want to make sure that in the process of this, with renumbering, important things don't get dropped out. So let's look carefully as you walk us through, please.
Okay, this amendment doesn't touch anything until you get to section 15.
But the question is that section 15 of the original bill, or is it section 15 as we renumbered the bill, which is section 17 of the original bill?
It's section 15 of the original bill.
But we can't do that because we already passed something that renumbers the sections.
And
One at a time, folks.
yeah, and OLS knows about this, and they're trying to figure out exactly how to fix it so it works. But we wanted to make sure you all knew what we wanted to change before we told them to change it again. So,
But this is it.
yeah,
This is it.
Yeah.
It's up or down tonight, and then we go home. Representative, what we passed earlier, my amendment, stands.
this amends replace all after 14.
And 15 and 16 are out
So
anyway.
that replaces all off the amendment. Does that? Hold up. Can you wait till I get started and I'll be answering each one of those parts? Okay. Okay. It has amended out 15, 16, and 17. So now could we go through and you can number them and then we can discuss all the things we took out at once? Would that? You have now. And we'll come back and talk about each section, but I think if we keep jumping in and out of this side by side, we're going to get real confused. So let's just do the side by side of numbers, write the new numbers by them, and then we'll come back and talk about each one. How's that? Okay. So we removed 15, 16, and 17. So now public assistance to the blind becomes number 15.
It was in the original bill number
18.
18. Got it.
Number 19, public assistance to the blind, aged, disabled, is now 16. Number 20, domestic relations, medical assistant recipient. I'm just going to say the first few words. I'm not going to read the whole title. Okay. What was 19 is now 16. Okay. What was 20, domestic relations, is now 17. What was 21, new paragraph, domestic relations, is 18. What was, okay. Okay. What was section 22, guardians and conservators, is now 19. What was 23, new paragraph, guardians and conservatives, is now 20. What was 24, new section, is now 21. What was 25, Department of Health and Human Services, is now 22. Um, 26 has come out.
Old 26.
Oh, old 26 has come out. Yeah, we'll come back to those. What was 27 is now 57 because there was a mix up and they took the whole marijuana cannabis area out. And so we called and said, no, put it back. And it was easier for them to put it at the end so they didn't have to renumber everything again. Okay. So it was number 27 where the identification cards start coming in. It was number 27. It's on page 8 of the original bill. Okay. Okay. So it's now, so what was 27, 28, 29, and 30 is now 57, 58, 59, and 60. We made sure those stayed in. And 31 became 61. Okay, everybody with me so far? Okay, number 32, lead paint poisoning becomes number 23. No, it's 32 right now. It becomes 23 on the amendment, yes. Number 35, public health, food service, becomes 24. I know it's in here. No, that was the.
Yes.
Oh, I'm sorry. I read it as 35. I'm sorry. That was my fault. Sorry. Yes. So the food service licensure is now 24. The number 34, compensation of certain state officers, is 25. What was 35 is now 26. What was 36 is now 27. I'll pause at the end of each page. What was 37 is now 28. Yes. What was 38 is now 29. What was Yes. What was 39 is now 30. What was 40 is now 31. What was 41 is now 32. What was 42 is now 33. What was 43 is now 34. What was 44 is now 35. What was 45 is now 36. What was, what was 46 is now 37. What was 47 is now 38. What was What was 48 is now 39. What was 49 is now 40. What was 41? I'm sorry, what was 50 is 41. What was 51 is 42. What was 52 is now 43. What do you mean?
What am I? 52 is now 43.
I'm on the bill where my notes are. You're looking at the amendment. Okay. Okay, what was 53 is now 44. What was 54 is now 45. What was 55 is now 46. What was What was 56 is now 47. What was 57 is now 48. What was 58 is now 49. What was 59 is now 50. What was 60 is now 51. Okay. Mm-hmm. Yes. What was 61 is now 52. What was 62 is now 53. Now we have some that have been taken out, and we'll explain why later. We've taken out 63, 64, 65, 66, 66 is gone. 67 is gone. 68 is gone. 69 is gone. 70 is now 54. Um, 71 is gone. Okay. 71 was removed. I'll explain what happened. 72 is now 55. $73 is now 56. Yes. Yeah. 73 is 56. 74 is now 62. Okay.
76, okay, 70.
That's weird, because 56 and 73.
I'm sorry.
Because they added all of the.
Remember, the marijuana bills then jumped down to the.
What's that again? 62. 62 is basically the 72. Yeah.
Okay, so there's not as many missing and changes as it looked like. Things just got renumbered a lot. So now now I suggest we go through. I'm assuming you want to know why we pulled certain ones we pulled. Okay.
I also ask, when you say we,
I talked to a few different people and who had problems with things, and so I threw together an amendment and tried to get it all bunched in. And
last question. Did you by any chance consult with DHHS about these changes to get their point of view?
yes.
Okay.
I gave them.
He's here.
I gave
Yeah.
them copies of this so
And
they could follow
and that's
through.
fine. And part of the thing is if one or two of them that we pulled, you're going, no, we should have left that in. We can have an amendment put on in finance if we need to. Or, you know, I mean, we'll figure out how to fix something that got inadvertently taken out that most people. So we were trying our best. Okay, so 15 and 16, everybody has gone over.
Old 15, 16.
Old 15 and 16 are gone. 17 is gone, but that wasn't one of mine. Right. Whoever it was I talked to about 17, can you speak to it?
I was getting my papers. It's been a long day for all of us. This is this is something that I think should have its own hearing. Having us rush through at the last minute, looking to add something into the budget makes a lot of sense. And making this be its own monstrosity of having all these different things in, I think that anytime we're adding more benefits, it needs to be discussed by more than just one person who's coming in. As much as I respect the position and and everything that was expressed by the American Heart Association here today, I think that this needs to have more discussion about the costs, both the cost of not doing it and the cost of doing it. But it deserves more discussion.
Point of order.
How should we do this? Should we debate each one as it come up, or should we let them go through all of them and get the
I think
reasons
we'd
for
all
of
get
them?
confused if we did a number of them and then went back and tried to discuss. I would suggest we take a look at them one at a time. And back to your exhortation that let's limit. We can either say El Stinko or hip hip hooray or words to the equivalent. So we're on 17, and Representative Leon has given her a reason for why she wanted this taken out.
Yes, it's
It's
out
out in the
there,
amendment.
In the amendment.
If,
And-
if the amendment passes.
And it's one of those areas too. I think back about the people that are on this aid asking me how they can get cheaper drugs because they're busy buying all of their cigarettes. I know that it's a cat and mouse sort of thing, chicken and egg, but I've had too many of those conversations as well. It's, you know what? It's late. Just delete what I said right there, and I already made my statements before.
I'll keep it brief. I'll just say that I don't think there's too much to say. I just disagree. I think I think that for the most part, my reading from DHHS is that these were well considered and that we don't have to come from a place of scarcity right now, and this is a good thing to add. So
May I suggest what everybody could do is, as we go through this, and there's things that have been changed or removed that you don't like, jot that down. And at the end of all of this, if there's a lot of them, you vote against the amendment.
Right,
If
okay.
there's a few of them, you probably vote for it. But we can also, individuals can remonstrate to Finance Division 3, because we really don't have the time, in spite of the fact the janitor appreciates time and a half, to go on. If we did it that way, I think that might speed it up. Representative Knirk.
I'd just like to point out that preventive services are some of the most cost-effective things that we do, but it's also important in the fiscal note. It points out that for this section, that the effective date is June 30th, 2023, to give them time to build it into the budget. So we are not committing ourselves to it. This will be something which they will try then to build into the budget, very much like what the dental did. And if we decide not to do it, then it'll be not in the budget. But it allows them to start looking at the concept and figuring out how to build it into the budget. So there's no fiscal impact fiscal year 22 or 23. It would not begin until 24. That would be in the new budget cycle. So it has the chance to be not funded if we decide not to do it.
Then that should go on your list. Representative
It already
Sullivan.
is.
Thank you, Mr. Chairman. Ladies and gentlemen, we have a reputation for finely crafted legislation. We were brought to this committee an omnibus bill put together by our very highly respected professional colleagues at DHHS. Under the pressure of time, we are now totally massaging an otherwise very nice omnibus bill, making changes hither and yon without due consideration for the implications. There will be opportunities for amendment at finance, and there are opportunities for floor amendments. May I respectfully suggest to you that we simply pass the bill as submitted by DHHS, call it an evening, we've only been here 11 hours, and then take a look at our opportunities in finance and on the floor to fix what we don't like. Thank you for listening.
Representatives, in that case, I'll vote ITL on the whole thing. And I do not want to do that, and I'm not the only one who feels that way. I think this is, from my perspective, a more respectful way to go forward. So let's not debate what we're debating. Let's move on, please, because I appreciate your comments, but I don't agree with you.
Okay, section 26 was the next one that came out. This came out with agreement from DHHS.
This is old 26.
Page 7.
Not everybody might know.
Page 7.
It doesn't exist anymore. We are taking 26 out. Okay, 26 is coming out because it's totally unnecessary. It's just reiterating the law that actually now exists. The cannabis section got renumbered because of a miscommunication, I believe, on my part. I'll give it to me. You know me. By the end of the day, I'm saying things I shouldn't say.
I start that way.
I know. I know.
We don't have to agree.
Okay, so nothing else gets deleted.
63 was the next thing you told us it was removed.
Yep, hold on. Okay. The next whole bunch of deletions all have to do with child care definitions. My thought is that should go before child and family law. It's all, yes, set, if the amendment comes through, it is purely that I feel that should go to child and family law.
And that is sections 63 through 69, or that whole
Yes.
bundle.
63 through 69.
The old
Old
numbers.
number.
Everything
Old
we're talking
numbers.
about is gone.
So 61, 62 stays. Those are important changes, the reduction in the,
Yes,
Okay.
the reduction in the fees stay. This is just the part about all the definitions. Well, we'll argue for a better committee. Let's put it that way. I really feel that they have a better handle on all the childhood laws and will spot anything wrong faster than any of us could spot. I mean, they've got those down. Hold on a second. No, the old 70. Yes. Right. The old 70 picks us up again at 54. Yes. Section. Yeah. I'm just waiting until people are listening so that I don't have to answer them again.
We're talking about
Right.
1476.
No, just ignore the other amendments. Just go with what you were given as the
Oh,
bill
yeah,
from the
that part,
Senate
yeah,
as
no, I got that.
amended. That's the bill at this point. Right. Okay. And that kind of will tell you why this got really confusing with me running to and from OLS and phone calls and everything, because we were dealing with all of these different documents. And that's what happened to section 71.
You
It
should
got-
be looking at Amendment 1476. That is what we are discussing. Anything else for the moment is irrelevant. Put it to your side.
Okay, the section that got dropped regarding recreation camp licensing was a mistake. I don't think it's a major issue. I think it could get picked up pretty quickly. I wouldn't, I'm not even going to guess how you can do it, but it's not going to change the world tonight by us not having this in here right now.
So when you say it was a mistake, they dropped it and you didn't ask for it.
Or we might have confused numbers because we were just like with the marijuana thing, or, the cannabis thing. It could, we're running back and forth and we're trying to keep track of which number is what and the different fiscal notes, and some mistakes were made. So this is one that purely was a mistake. We have no reason to take it out. I will take ownership of it. No, it just says, camps, we get to come in, and if and make sure things are okay and investigate if something's wrong. I think that is, yeah, it can be put back in finance. Mm-hmm. Right, yes.
Or even a floor amendment.
Right. And so I had talked with several people about that could happen. So basically, the things that have been taken out was the old 27, or I'm sorry, 17, which is the one that is the most back and forth on. 26, which was redundant with law. The section for defining all the terms for childhood care terms.
Those are all those 60. Right?
Yeah.
Yeah.
And
Or 63
then
to 69.
the one about the camps. So it's not a huge difference. It just looks huge but they had to do it as amend all as a big bill to get all the numbering right all the way through. Mm-hmm.
Can we hear briefly from DHHS just about what consequences this will have or not?
Come on up.
Yeah, come on up to the mic.
Mike.
That's okay, but come to the mic so we can hear you. And the
There
outside
may
people
still be
can.
people watching in radio land.
Rapidly.
I think the green light is flash. Oh, here we go. Thank you. Chairman Pearson, thank you very much. And also thank you to Representative Folsom for taking the time to review with me some of the possible amendments. We really appreciate the attention of this committee. What our earnest approach would be to this if we do have issues with any of the amendments being made. We think that a fair effort is being made to pass this bill out of this committee, and I think that would be my first and last statement. I would ask to please pass this bill out of the committee. We can certainly work on some of the differences. Clearly, the change removing the section dealing with the 60-month look back, that's existing law. That actually makes sense to clean up to doing that. I respectfully do understand that some of the subject matter overlaps with other committees and certainly understand that viewpoint, but certainly there's a process for us to continue that conversation, whether in the Finance Committee or, as the very sage Representative Weber had suggested, in a committee of conference, if there is still disagreement between the House and the Senate positions on bills, working collaboratively together. The section dealing with preventative medicine, respect where Representative Leon is coming from in terms of wanting to get a better understanding of the finances. But on the other hand, we really, really would like that section. But respectfully, please pass this bill out of this committee. And I think this amendment may represent a path moving forward. So thank you.
Representative Knurk.
Just a question regarding the preventive. Since the goal was to allow you to start getting it organized to put in the budget, if we don't pass that, will you be able to coordinate getting this into the budget in the next budget cycle, or will that actually slow it down?
Our preference would have been to address the policy issue earlier on so we could start developing that as part of the budget. We're actually putting our budget together at the present time. But if we decided to, we could bring it forward in HB2 to the trailer bill of the budget, and you could see language that looks very much like the language you see in the legislation as it came over from the Senate on that section.
Representative Weber.
So just to go back to the First Amendment, which we passed, and we took the old Section 7 out and replaced it. Did that get put back in anywhere here?
Representative Leon.
It is being printed and being brought back down to get that back in there.
Okay, so that's a
Yes.
further coming attraction.
Yes, it is.
Okay, so that's
Squared
that
back
one.
circle.
And so all that, in that amendment, the replacement of everything after 71 became 72. So that's gone with this amendment?
Yes, because my amendment replaced everything from after 14.
Right.
So his amendment went on, but then mine overlapped his and
Right.
took out
Mhm.
the bottom half of his amendment.
So the top half of his bit is in and the other part is out, and there's another thing coming to replace 7.
Real soon,
Okay.
we hope.
Because we didn't
Thank you.
realize that they had done that at
Right,
first.
no, I got that. I just wanted to be sure I understood what the interaction with our first action and our second action was.
Do we have anything more to say on the Folsom amendment, or can we put it? Yes, you have more to say, or yes,
I
we can
just,
put
I
it.
just want to say I'm going to oppose it because I liked some of the stuff that was
Okay.
in there, but
All right,
I would also like to say that I really don't think we're doing our proper due diligence on this. Yes, we saw that the first 3 words of each section were there, but has anybody actually read that, make sure that no word got dropped? We've seen a lot of drafting errors coming out of OLS this year where there were all kinds of things dropped here, dropped there. I'm concerned we'll pass something that we'll find later on was something omitted that we really didn't know, a line, something.
Could I suggest after we've all had a good night's sleep, we read the thing and then pitch it over to Finance 3 if that's the case?
That might be reasonable.
Both getting a good night's sleep and pitching it to 3, yeah.
That first part is probably not going to happen now.
Don't happen to get home.
Right. On the amendment, they just took out the other language. They didn't even touch the script that was already there.
We don't need to look at any of that because all the numbering.
Yeah, right. They went through, fixed all the numbering. Yeah, they took quite a bit of time doing that. We had hoped to have this up to you much sooner, but they took their time to make sure they had it right.
And of course, the amended analysis still has to be.
They don't amend. Yeah, they don't amend. And I would have absolutely no problem offering an amendment to finance to put that back in. The recreational stuff.
Anything further on this that you would like to say to the group before we look at this amendment and vote on it? Seeing none, Representative Folsom for a motion.
I move amendment. I move amendment 2022-1476H.
And your motion is?
Ought to pass.
OTP, and is there a second? Representative Leon, thank you. That is the motion before us. Yep.
Yes.
And the next amendment, and they'll all homogenize this. I have to say this, I hope there is none, but any further discussion? Would the clerk please call? Yes, Leon. Would the clerk please call the roll? The motion before us is Amendment 1476 on Senate Bill 430. Motion is ought to pass, made by Folsom, seconded by Leon. Please call the roll.
Representative Leon.
Yes.
Representative McMahon. Yes. Representative Acton. Yes. Representative Gay.
Yes.
Representative Mooney.
Yes.
Representative Folsom.
Yes.
Representative Bohm.
Yes.
Representative King, yes. Representative Colfault.
Yes.
Representative Delamis. Representative Weber.
No.
Representative McKay.
Yes.
Representative Snow.
Yes.
Representative Knirk.
No.
Representative Soloway is not here. Representative Cannon.
Yes.
Representative Nutter Upham.
No.
Representative Shapiro.
No.
Representative Woods.
No.
Representative Query.
No.
And Representative Pearson.
Yes.
1, 2, 3, 4, 5, 6, 15 to 6.
No,
Sorry, 14
14
to 6.
to 6. Okay, so that amendment has passed. Now we are awaiting imminently.
We are awaiting imminently 1483, which should be being printed upstairs, and Anne's supposed to be running it down. So I can move my little legs and see if I can intercept to get that. Or if you would like me to explain what it does. This adds back the 7 that accidentally got deleted with the First Amendment.
No, I want you to, no, no,
We
you
ha-
have
do
to
we have
see it.
And that is the 7 that is on the original bill, correct?
Yes, this is the original 7 as passed out of 2 Senate committees with amendments.
Somebody's got the floor.
Okay,
So this
got
is this is the 7 that we all should have been reading when we walked in with the right copy this morning.
Yep.
Okay, now you can chit chat.
I will point out that all of it was passed with 2 amendments on the Senate floor. So.
It was passed, but some of us were holding copies that only had one of the passed amendments, and that's where the first part of our confusion of the day began. Oh,
Who
yes.
asked about the Sox score? I heard somebody asking about the Sox. I heard it over, no, that was before. Just now somebody said, how'd the Sox do?
An important piece of information. Does anybody know the Red Sox won today?
So,
Yeah, I was just gonna say,
What? Listen up, everybody. You've got this short amendment coming, And then you've got, would you, fourth floor person, please explain what the rule is here?
If you can explain the rules,
Okay.
I've learned this recently.
Okay, so and I just confirmed it, so I hope I have it right. But you can do one amendment. We can't have three separate amendments, even if they're not inconsistent. So what they're working on now at OLS is basically combining everything that you've been doing into one amendment, which will be the amendment that amends the bill.
Yeah. We have in the past
Right.
done two amendments that were consistent with each other.
Right.
And they have melded them.
Right.
So
They
why
will-
can't we do that now, which is what we were doing?
I'm not sure why we can't do that now, but if we have this and we pass what we all agree on, if we just keep a skeleton crew and have our honor that we're not going to do anything else or add anything else, we can at least let some people go home before we get that final one that should
I'm
be on
just
its way.
concerned about the fact that our house traditions seem to have been changed without any.
Representative Bohm.
Yeah, I've been here a long time. I mean, not today, but I mean, but in the past, when we've done multiple amendments, we let OLS put them together and as one amendment.
Do we have to vote on that one amendment?
No. We haven't. in the
I'd like a
past.
ruling.
Never have in the past. They have taken our three amendments or two amendments,
All right.
and they have created, and I think that we're on the same page with this, they have created something called the committee amendment, but they've taken the Folsom amendment and whatever the other amendments are, and it is, yes, another amendment, but we haven't had to sit around and vote on that. They just take them and meld them together.
Thank you, and the chair decides that is great wisdom. So before you now is Amendment 1483, which keeps the concern that Mr. Hall had in 7, but puts the rest of it back that we took out by mistake, that a lot of us thought we shouldn't have done it that way. So would you please look at Amendment 1483? And once we have dealt with this, then we have to pass the bill as amended 3 times.
Do you need, I've got an extra one down the street.
And we passed Amendment 1406.
Got it.
Yes. So far, we have passed Amendment 1387 and 0642.
1387? I don't see that. 1406.
I'm sorry, I had flipped my notes over.
Page turning is tricky. Yeah. Okay, you all have before you.
All stand here and say I'm sorry a few times and we'll cover each other.
And we also had 14.
Okay, before us is Amendment 1483. May I have a motion for that?
I would move that ought to pass on Amendment 2022-14838H.
Do I have a second? This restores Representative Cannon. Thank you so much. Any further discussion on this amendment and nothing else? Are we ready to call a question? The question is, the motion is ought to pass on House Amendment 2022-1483, amendment to Senate Bill 430 FN, moved by Representative Leon and seconded by Representative Cannon. Would the clerk call the roll, please?
We're getting there.
Well, I didn't say when. Sometime.
Representative Leon.
Yes.
Representative McMahon.
Yes.
Representative Acton.
Yes.
Representative Gay.
Yes.
Representative Mooney.
Yes.
Representative Folsom.
Yes.
Representative Bohm.
Yes.
Representative King, yes. Representative Kofalt.
Yes.
Representative DeLemus.
Yes.
Representative Weber.
Yes.
Representative McKay.
Yes.
Representative Snow.
Yes.
Representative Knirk.
Yes.
Representative Soloway is still not here. Representative Cannon,
Yes.
Representative Nutter Upham, Representative Shapiro.
Yes.
Representative Woods,
Yes.
Representative Query,
Yes.
and Representative Pearson.
Yes, it is 20-0. The motion passes. Now, the item of consideration before us is Senate Bill 430 as amended by 1406, 1476, and 1483, which will all be turned into a super amendment. Now, who will make a motion for this bill? Representative Folsom, and what is your motion?
OTPA.
OTP AAA. Okay. Sounds like a car thing. And who would second it? Representative Nutter Upham. Are we ready for the question? The motion before us is Senate Bill 430 FN as amended by 1406, 1476, and 1483. The motion is ought to pass with all these amendments made by Representative Folsom and seconded by Representative Nutter Upham. Would the clerk please call the roll?
Representative Leon,
Yes.
Representative McMahon.
Yes.
Representative Acton,
Yes.
Representative Gay. Yes. Representative Mooney,
Yes.
Representative Folsom,
Yes.
Representative Bohm,
Yes.
Representative King, yes. Representative Kohlfalt,
No.
Representative Delamus, Representative Weber, Representative McKay,
Yes.
Representative Snow,
Yes.
Representative Knirk,
Yes.
Representative Soloway not here, Representative Cannon,
Yes.
Representative Nutter Upham, Representative Shapiro,
Yes.
Representative Woods,
Yes.
Representative Query,
Yes.
and Representative Pearson,
Yes.
19-1.
And off to finance it goes. Okay for consent?
Do I list all
Okay,
this?
you do not have to write a report if you do not wish.
Here.
It is not on consent. And who's going to write the blurb?
I will.
Thank you. You write nice blurbs.
Well, no, it still has to be voted on the floor to get votes.
Do you have another bill?
And unless there's objection, this meeting is adjourned.
Can I just ask a quick question? What are the bills we're doing on the 19th? Do we have like about 4 or something like that?
We've got some, I don't know.
The rest will just be executive session. Well, there's executive
We've got
session to
one
follow.
of your amendments to do, but we've got a couple of bills left over.
Yes, a few to hear, and then we have the amendments. Yes, got it.
Well, I'll work that out tomorrow when I'm up here, and then shoot y'all an email. Thanks, everybody.
Nobody wants to leave.
Who's going to bring the drinks?